classes and all. Yeah,
Chidambaram, right?
Yeah.
So, think so, sir. Nice meeting you, sir.
Hello.
Then Dr. Jeevaratnam is there. He's a professor in Balaji Dental College. Chennai.
Hello, sir. Hello, sir. I am from Chennai, sir. Hello, sir. I have not met you. This is the first time we are meeting, sir.
So we have disabled the waiting area and we are live, sir.
Okay. You're going to mute all and then unmute the judges.
Yes, sir.
Good evening, one and all. Thank you so much for coming in early. Hope your slides, everything is ready. Give us some time. Give us 2 to 3 minutes more so that everybody can enter. Dr. Joby?
Yes, Binu.
Deen Dayal sir has just logged in.
Okay, fine. Sir has also come.
Dr. Joe, just make sure the candidates have renamed themselves and they are ready to go in next 5 minutes time.
Yes, sir.
You haven't, you have disabled the waiting area, no?
Yes, we have, sir.
Then why is it?
So they are coming in, so they are all coming in, sir. Just showing they'll come in soon, sir.
Good evening, all. Just give us some time. Dr. Dendran, sir, thank you so much, sir. I will make sir also a co-host.
I've done that, sir.
Yes, so you can unmute yourself. We can talk now, sir.
Yes, sir. Good afternoon, sir. Sorry, sir. I couldn't make it up in time, sir.
No, you're right on time.
Just
right
reached my home, sir. Just reached my home, sir.
You're right on time. We haven't started,
yeah.
Doctor. Right
yes,
on
sir.
time.
Right, sir.
In there, sir, there's Dr. Jeevaratnam, sir, from Chennai.
Yeah, I could see, sir. I could see, sir. I could see.
Yeah, and Dr. Nirmal Madhavan from Chidambaram, Annamalai University.
Yes,
Hello,
sir.
sir.
Hello, sir.
Yeah.
Good afternoon, sir. Good afternoon to all, sir.
Good afternoon, sir. Good afternoon, sir.
Ramesh is also will be joining soon.
Okay. Joe, that voting questions, it's already right?
Yes, it is, sir.
That instructions has to be given when you start.
Yeah.
2 more minutes we will start, Binu. 4:05 we will start because almost all candidates have come. Very few are to be yet to come.
Okay. And judges are also there.
Judges are also there. First 5 are already there, so no issue. By the time others can join.
Fine. So good evening once again. First of all, congratulations to all the top 20. As I personally called them today and told them that it is not an easy task to become top 20 out of more than 400 odd participants. So you have already won. Now it's time to present. So judges are here. Without much delay, we will be starting. Online dentistry started 12 years before. Myself, Dr. Binu Abraham, orthodontist practicing in Kochi, and Dr. Joby Peter, pediatric dentist, head of the department of Malabar Dental College. Both of us started this firm together, started with offline programs and currently doing online programs. Whole lockdown period, we did almost 340 free webinars for the dental fraternity. And now, as we end 2020, we decided to think and look dentistry beyond 2020. There is definitely going to be a brighter side for dentistry in 2021. So we wanted to end 2020 with a conference for all, and we wanted it to be free, and we wanted everybody all around the world to attend. We want the students, we wanted artists, we have dental art competitions, dental talent competitions, everything there happening in the virtual world. Lots and lots of artwork, talents received. Just had a tough time selecting, and we are almost through in that also. What is remaining today is the postgraduate paper presentation, 20 candidates. With that, we are ready to go. Just a couple of instructions. The candidate, as they come in, they can share their screen, switch on the PowerPoint, share the screen, switch on the PowerPoint, and come to play mode. Make sure you come to play mode of PowerPoint, and then you ask, is my slides visible and my audio audible? When one of us will say, yes, you are visible and audible, you are ready to start. The moment we say start, that's it, timer starts at that time. Okay. And then end of your presentation, there is a polling that is for the audience to rate your presentation from 1 to 5. That instruction will be given during the polling time. After each presentation, there will be a 45 seconds viewers polling time. And this time, a viewer's choice special prize is also planned. So that's it. With that, over to you, Dr. Joby. Can we start today's without much delay?
Yes, Bill. Thank you so much. Thank you so much. So good evening to one and all, the respected judges and all the faculties, postgraduate students, general dentists, practitioners, and all those who are attending and listening for today's session of postgraduate PG paper competitions. Let me welcome to you this platform again. As Dr. Binu rightly said, online dentistry, our main aim is to redefine dental education in an ethical and professional way. And thanks for the immense supports that you have given for the past 1 month, also for this conclave, and you have made it very successful. The entire community is talking about this conference. Thank you so much for your support. So we are into the last part of the postgraduate paper presentation, followed by the sessions, and tomorrow is the big finale, entire day dedicated for scientific discussions from starting from 10:30 we are opening up, and 11 o'clock onwards the session starts and goes till night 9:30. Lots of scientific sessions are there, and the instructions for the winners. So today judges are going to select 5 top papers, and they are going to give us the result by tonight itself. And by towards the end of today's session, we will be announcing the winners of the previous poster competition, UG poster competition, PG poster competition, PG paper presentation, and UG poster presentation. All those winners will be announced in each sessions. So be tuned whether check your name is there in the best 5 in this 4 category. If so, you need to be listen to the last instructions which I'm going to give today. On Sunday, a time is being allotted to you. You have those 5 people have to come on that time, and in the group I'm going to give you the YouTube link of your presentation of the 5 people selected. YouTube link, only those 5 people's presentation is going to come, and you can click the link, watch it. Whatever mistakes, whatever improvisation the judges told you during the time, correct that, and no changes in the slide, but otherwise whatever things that you told, whatever questions they asked, they just want to listen and improvise you. So this is the one of a kind of presentation that is going to happen. So, and attend Sunday, be there on Sunday and a full day. Lots of speakers are going to come and going to highlight you there. So starting with the judges of today's judging panel, we have a light team of judges who are going to observe each part of your presentation. Wishing all the students all the best. Let me take this opportunity to invite and introduce the judging panel for today. The judge of the today, Professor Dr. Nirmal Madhavan, is a professor and head of the Department of Oral and Maxillofacial Pathology, Annamale University. Thank you so much, sir, for coming. Sir has finished his BDS in the Faculty of Dentistry, Annamale University, and MDS from Tamil Nadu Government Dental College, Chennai. Sir has finished a PhD in the Faculty of Dentistry, Annamale University. Sir has got 75 journals, out of which is 43 are international and 32 are national. And believe me, sir has contributed into the Bible of oral pathology. You know, from third years onwards, we used to study what is the Bible of oral pathology. This is nothing other than Schaefer's. Sir has contributed in the 9th edition of Schaefer's, and also sir has contributed in the textbook Oral Cancer and Avoidable and Preventable Cancer by Dr. S. Manoharan, first edition. Sir holds lots of position in lots of association. He is an eminent researcher, a guide, PhD guide and researcher, and the association with me long way back. We have an association, and I know sir's eagerness to learn and go into newer research field. The famous field being cancer research, oral cancer. That is his favorite field. Thank you so much, sir, for coming on this day and judging for our esteemed students who are participating there. Next, we have another eminent person, Dr. Jeevaratnam. Sir is a pediatric dentist. Sir is a professor and head of the department of Balaji Dental College, Chennai. Sir has finished BDS from Savida Dental College and Meenakshi Ammal University. Sir has finished his post-graduation in MDS. Sir's main objective is to obtain academic and clinical excellence in dentistry. He caters all family dentistry. That is his concept. Aesthetics, you name it, everything sir caters. And he has got an exclusive family dental clinic in Velachery, Chennai. Now he's a professor and working as a professor in Balaji Dental College. Thank you so much, sir. And he is one of the most sought-out speaker in Indian Society of ISPPD. That is a specialty for pediatrics in India. He will be there. One of the speaker. Always he will be there. Thank you so much for spending time with us, sir. We are looking forward to your expertise judgments today. Then we have Dr. Deen Dayalan, sir. Sir is a prosthodontist and implantologist. Sir is working as a professor in prosthodontics and department of prosthodontics and implantology, CSI Dental Science and Research Center, Madurai. Sir has got some special interest, you know, as when we started our BDS, we learned about dental materials. Sir's main area of interest and research is on dental materials. Being a prosthodontist, definitely you will be much knowledgeable on that, and his research area is dental materials. Thank you so much for coming in at this time, sir. We are waiting for your judgment. And finally, Dr. K. Ramesh Kumar is a pediatric dentist again from Chennai. Sir is also joining us soon, and he, sir, is also be one of the part of the judges. Thus, we have an expertise. You are all in the experts' hands, or you can see the pioneers in this field who are guiding the postgraduates and guiding the PhD scholars. So you are in the safe hands, and they will do justice to your hard work, and wish you all the best. And is over to our MC, Dr. Joe.
Thank you, sir. Judges, please note, we are starting off with DB01. DB01, you can unmute yourself and start your screen share.
Is my screen visible?
It is visible, doctor. You can go into the full screen mode now.
Yes. Am I audible?
You are audible, doctor.
Can I begin?
Yes, your time starts now.
Great things never come from your comfort zone. And the comfort zone for us dentists are the full crowns. I am here today to urge you to get out of that comfort zone and look into contemporary restorations of endodontically treated teeth. Endodontically treated posterior teeth are more susceptible to biomechanical failure because of coronal destruction from dental caries, fractures, previous restorations, and endodontic access cavities. The loss of mechanoreceptors after endodontic therapy increases the threshold of the pressure receptors in the periodontium, leading to a functional overload, thus making the tooth highly susceptible to fracture and in turn affecting their prognosis. The successful outcome in such teeth depends not only on an adequate root canal treatment, but also to a far greater extent on an adequate coronal restoration. Now, conventionally, full crown is given for almost all endodontically treated teeth. However, strictly speaking, a full coverage crown is indicated in case of teeth heavily weakened by pathology with extensive involvement of the cervical enamel or in the presence of previous prosthetic preparation. So partial indirect adhesive restorations are more conservative than prosthetic restorations and should be preferred when possible. The full crown is considered the gold standard by literature with a 6 times greater rate of success in endodontically treated teeth. But in medium-sized cavities, bonded indirect restorations allow to delay the execution of a full crown with the subsequent sacrifice of healthy dental tissues. Thus, adhesively bonded ceramic inlays, onlays, and endocrowns offer a minimally invasive solution and have been suggested in various studies. The decision-making criteria largely rests on the amount of remaining tooth structure among various other factors, and accordingly, a decision can be made incorporating various features of retention and resistance as demanded by the case. Following is a case series demonstrating such partial bonded restorations in endodontically treated teeth. A class 1 access cavity doesn't require a full coverage restoration when minimally invasive options are available. A combination of resin bonded composite, wedge-shaped increments, and ultra-high molecular weight polyethylene fiber reinforcement system like the Rebond was considered of paramount importance to further reduce polymerization shrinkage, better support the composite, reinforce the remaining tooth structure, and reduce the total composite volume while offering a quick, cost-effective one-appointment solution. First described by Bindle and Mormon, the endocrown is an adhesive monolithic ceramic restoration anchored in the pulp chamber, exploiting the micromechanical retention properties of the pulp chamber walls. The cuspal coverage or protection is achieved by an occlusal onlay-like preparation, and in this case, although there was a slight mismatch that was visible, it didn't bother the patient much into the posterior location of the tooth. In medium-sized class 2 cavities like this, bonded indirect restorations are preferred, and here the preparation was modified to have an intracoronal portion for added retention. The overlay preserved the coronal structure, reinforced residual dental tissues, guaranteed optimal form, function, aesthetics, and offered ergonomic and economic undoubted clinical advantages. In the next case, a different type was tried for this class 2 access, where we wanted to save the buccal portion of the tooth in the aesthetic zone and made an intracoronal preparation extending palatally with a shoulder finish line. Immediate dentinal sealing was done, and an even margin of enamel cervical sidewalk enabled the success of this partial bonded restoration prepared and delivered minimalistically. Next up is what I would like to term as a pin lay, is where we took retention from the distal canal, where 3 mm of GP was removed and the inlay preparation was modified to receive the prosthesis. Impression was taken with the help of a modified wooden matchstick, and finally a metal pin lay was delivered the very next day. In the presence of one marginal ridge lost and the 2 adjacent tusks compromised, like mesoocclusal or distocclusal cavities, and only indirect restoration could be performed if the other marginal ridge and tusks are healthy. My last case is that of an onlay, where an attempt was made to preserve the bulk of the mesial half of the tooth, which remained untouched with the distal lingual tusk capping because it was less than 2 mm of remaining tooth thickness, and a butt margin of enamel was present all around, and immediate dentinal sealing was done after the preparation. A beautiful partial ceramic restoration was delivered to the patient, keeping in mind that the occlusal was maintained as it is. The restoration of endodontically treated teeth is one of the topics most studied and controversial in dentistry, but here are my clinical tips and tricks I would like to share, which I learned through these cases. Complete proximal separation is highly necessary. Proximal boxes should be extended gingival to the contact points, and internal walls should be divergent with no undercuts. Management of the mesial margins requires some amount of manual skill, and in these cases, it could be convenient to use proximal fine sonic tips or reciprocating tips. Lastly, I cannot stress enough the importance of immediate dentinal sealing and a rubber dam during cementation. On one side, the full crown is the first condition able to improve the tooth survival after endodontic treatment, and on the other side, new materials, instrumentation, and techniques have enhanced the performance of current posterior composite restorations over the predecessors. However, the success of these adhesive restorations depends on a proper preparation design, the choice of ceramic material, and the high technique-sensitive adhesive luting protocol. And ultimately, it is a clinician's operative skill that determines the quality of a restorative options. The advent of adhesive procedures has heralded the need to switch to prevention of extension and allow for a minimally invasive restoration approach to restore pulpless teeth. And preparing sound tooth structure to receive a full coverage restoration may not be suitable anymore in the current era of adhesive dentistry. We have all heard the famous quote, "You're always one decision away from a totally different life." Well, today I would like to modify it and put it as, "You're always one preparation away from a totally different restoration." Thank you.
Thank you, Doctor. Judges, please note that was DB01. Judges can now ask questions. Sir.
Sir, this is Dr. Deena Dayalan. I just want to ask one question. In an endodontically treated tooth, when you consider a fiber reinforced composite or a metal inlay, which would you prefer? You're given two options, and which will you prefer, FRC or metal restorations, and why is it so?
So I would, there are a lot of factors that go into play when we decide what kind of post-endodontic restoration we have to give to the patient. And most of the times it is what I would like to call a cavity analysis. How much of remaining tooth structure is left? Do we have a class 1 cavity? If I have a class 1 cavity, I will go ahead and do a fiber reinforced composite where I can layer wallpaper the entire thing around the walls, because then all my cuts will be reinforced with the help of this fiber reinforced composite. Whereas on the other hand, if I have a disto-occlusal or a mesio-occlusal cavity and I have more than 2 mm of cuspal thickness remaining, then I will go ahead and do an inlay for a post-endodontic restoration. And if at all one of the cuts is compromised, then I would like to cover that and go ahead and do an onlay in such cases, where I would get intracononal retention from the pulp chamber as well as cover both the cusps or whichever cusp is weakened.
Okay. Apart from the design configurations, I just want to add two more points. One is the coefficient of thermal expansion, as well as the resiliency of the dentin, where which FRC always has a higher end or upper hand over the metal. Just 2 points to be added. Thank you.
Thank you, sir.
Thank you, sir. Any other judges would like to ask questions?
So what is the longest follow-up of these cases you have?
So the longest follow-up I have is around 1.5 years for like the fiber reinforced composite, whereas the other cases, the endocrown itself has become 2 years because I did that in first year of PG. So that I have a follow-up of almost 2 years for that case. The inlay with the only with cusp capping and the pinlays are all 1 year follow-up cases. A minimum of at least 6 months to 1 year follow-up is present.
What practical problems you have encountered during these follow-ups?
So the problem is that sometimes if the cavity analysis is not done properly and you go ahead and give such partial indirect restoration, within a few months, you will have debonding problems. And that is not because of your bonding protocol or something. It's because of the retention and the resistance characteristics of the cavity that you couldn't keep in mind. You have to consider those as well, whether this sort of partial indirect restoration will be able to withstand the forces of mastication. So if you don't have those, then you will have debonding in the long run.
Okay.
Nirmal sir, do you have any question?
Yeah, no, not now.
Okay, sir. Thank you.
Yeah.
Thank you, sir. Now we have an audience voting of the same presentation. Audience, please note, you will have a poll present before you with a scale of 1 to 5. 1 is good and 5 is excellent. Please cast your votes.
So our next judge, Dr. Ramesh sir, has come. Would you please make him as a co-host so that he also can unmute?
Yes, sir. Thank you, doctors. Moving on, judges, please note, we have DB02. DB02 can now start screen sharing.
Am I video visible?
Yes, doctor, you are visible, doctor.
My slides.
Not yet. Yes, now it's visible, doctor. You can go into full screen mode now.
Yes, is it visible now?
Yes, doctor. You can start.
Am I audible? Am I clear, sir?
You're audible and clear, doctor. You can start.
Good afternoon, everyone. So, as you can see that my title name is Turn the Tide. As we know that during this in this era and this recent years, we have been talking more about fluoride remineralization and the caries process. But we never thought that what if fluoride causes some dangers to us or causes some problem to us? Yes, obviously in this recent years or previous years, we have come to a known fact that the fluoride is causing fluorosis, and it has caused a formation of occult caries. So because of this, what has happened is they have led to researchers and the investigators to lead to a new method or a new mineralization method to develop they developed from a demineralized enamel is a non-fluoride remineralization system. So this system was put forward by the WHO in a recommendation that when this fluoride was categorized into a chemical neurotoxicant, so this has been kept in a mind as well as with the fluorosis factors. So this method has been come to an invention that is non-fluoride remineralization system. So this non-fluoride remineralization system, I will be explaining on its remineralization technique. It's how this changed from normal management system and about its concept of how does it remineralize. Next is the classification. It is broadly classified as a biomimetic regenerative system, and the second one is a fluoride booster. This biomimetic regenerative system is nothing but a production of the exact biomimetic material of enamel characteristics. As we know that this enamel is of acellular nature and it does not resolve. So to produce this enamel was very difficult in the previous stage, but because of now that advancement in tissue engineering had led to this invention of this biomimetic materials. This biomimetic material which are presently available or which are under investigation are the dentin phosphopeptine, the P11-4 peptides, the leucine-rich amylogenin peptides, the electrically assisted and enhanced immunization, and nano-hydroxyapatite. These fluoride boosters are already been discussed and already been available in our techniques to develop these systems. So the first is the amylogenin protein. This amylogenin is nothing but the protein which are present during the tooth development stages. This amylogenin, what happens is it stabilizes the calcium and phosphate ions, which leads to the growth of enamel crystals, in turn increasing the hardness of the tooth. But you can ask me a question that what happens that there is a regrowth which is not controlled growth of remineralization. So to control this growth and shape of this enamel crystals, there has been addition of a material called inorganic pyrophosphate. So this inorganic pyrophosphate controls this growth. So this, every material has a disadvantage. This amylogenin also has a disadvantage because it is very difficult to extract and it cannot be stored for a longer period of time. And this amylogenin caused a very little growth in a very short period of time. Next is a dentin phosphoprotein. It is a non-collagenous extracellular matrix protein which is present in the dentin. It is nothing but an aspartate serine nucleotide. It also promotes the hydroxyapatite formation. This formation has a better fit than the amylogenin protein, and the most active form of it was 8-dentin serine peptide. So this dentin peptide has a two dual function. That has it limits the dissolution of calcium and phosphate rather by reducing the demineralization and captures the ion by producing a new mineral deposit. So there will be uniform deposition and it reduces the surface hardness. Next is the self-assembling P11 peptide. This main peptide is mostly dependent upon on the saliva quality. So when the patient with a reduced salivary buffer capacity or reduced salivary flow in the like xerostomia patients, this material has a very least efficacy. And this also forms a needle-like crystals which is very opaque in a radiographic nature. And there has been a randomized control trial conducted by Alkisi et al. In 2018 where he combined this material with fluoride and he has proved that this material is very effective. So this has to be applied on the tooth surface. Due to the tiny pores which are available in the demineralized structures of enamel, this enters into the pores of the demineralized structure. So where it assembles into an elastomeric material forming an hydroxyapatite crystal in a 3D way. So this 3D form causes a biomineralization of the lesion. Next is a amido-amine dendrimase. These amido dendrimase are analogs of amylogenin. This has an exact function of amylogenin. To overcome the difficulty which was caused by the amylogenin, this material has been introduced. So this material was easy to store and it was can be easily extracted. It exactly mimics the organic matrix property. Next is the electrically accelerated and enhanced remineralization. This enhanced remineralization causes a preservation of all the healthy tissues by using an iontophoresis. This iontophoresis causes the acceleration of these ions into the deeper lesion. So this deeper lesion will cause the abstract or the bioabsorption of the calcium and phosphate ions, and rather in turn leading to a remineralization of the lesion. Next is a nano-hydroxyapatite. This is now commercially available. That's an aspartate system. Aspartate in the name of aspartate toothpaste. It is biocompatible and bioactive. It strongly binds to the enamel surface and causes the retraction of the cyst. Because of this smaller size, the increase in the binding area increases and small pores has an attraction of these ions. So this ions doesn't have any clear mechanism. There has been two mechanisms which has been proposed. One is a creation of a new layer of synthetic enamel. And next, as I say, second is the calcium bioreservoirs. As I come to the end of the biomimetic materials, as we know that all biomimetic materials are still in the shoes or still in the investigation of the investor. But the fluoride boosters have been boosted where the fluoride concentration is reduced in the product, and it has another additional product has been added. So the CPP ACP is nothing but KC phosphopeptide and amongst the calcium phosphate had been added to this material, which causes a metastable or an super saturated liquid, which causes a bioavailability or it says a bioreservoir of calcium and phosphate ions. So there are various studies which have put a significant and non-significant studies to mention few.
Thank you, Doctor, for the wonderful presentation. You have automatically been muted by the system as you have exceeded 6 minutes. Judges can now ask questions. Judges, please note, this is DB02. DB02 can now unmute yourself.
Is this more of a review?
Yes, it's a review article.
There is no like testing in your setup or anything like that.
Yes, sir. I have like my own thesis determines the fluoride efficacy in a demineralized enamel, sir, where I had found that when a laser is assisted along with a fluoride treatment, it enhanced more, or it produced a value which is of a baseline value which I recorded before and lesion was demineralized. And after remineralization, I got the value which is exactly to the baseline value of the applying this material of fluoride, so that is CPP, ACP, and topical fluoride. Sir.
Okay.
Any more questions, judges?
In any of the
Yes, sir. So it's a biomimicking material you have told, right?
Yes, sir.
That is like a lesion only remineralization, or it is going to be repair completely, like it's going to form?
Yes, sir. The lesion repair as well as the formation of a new material also happens, sir. That is the greater advantage of these materials. Only
what is the how it will bond with the original teeth there, like a apatite there?
Sir, it itself forms as a new apatite crystal-like structure, sir.
How that crystal will be bonding with the existing?
Sir, actually the crystals only arrange them particularly to the structure which will mimic the environment of an enamel, sir. But the bonding has not been tested till now, sir. It is under the research process.
Okay. Deenadayalan, sir, you can go ahead.
In any of the study, what you have mentioned, has it been treated in patients with the developmental enamel defects like enamel hypoplasia or dentinogenesis imperfecta or amelogenesis imperfecta?
No, sir, not on the imperfecta cases, but on the hypoplastic tooth they have done, sir. And that they have found that fluoride boosters are more effective than the biomimetic materials. When they combine with fluoride, it is more effective.
Okay. In those patients, you mean to say that fluoride is more effective than the remineralization?
No, sir. Fluoride has to be reduced in its concentration with this fluoride boosters which is available in the recent studies. So like CPP, ACP or tricalcium phosphate. So this will cause more effectiveness rather than only a fluoride application.
Okay.
Can I ask you a question?
Yes, sir.
Yeah. You said amelogenin.
Yes, sir.
Amelogenin, dentin phosphoprotein and all.
Yes, sir.
Okay. Those are actually proteins which are formed by the during the development of the tooth by the epithelial cells, which attract calcium from the blood to settle down and form crystals. Okay. If you apply, one thing is creating them and like maintaining them outside is very difficult because they have a very specific period during which they form. They don't form continuously. Only during the development, especially when the cells become amyloblasts, they form. Very transient period. And they have a very short life. After that, they disintegrate. My question is, when you apply it topically, from where they attract calcium and phosphorus? Because during the development, you'll have blood vessels there from where like calcium moves and settles in the crystals. But topically, when you apply it, how do you get the calcium and phosphorus settling down? From where you get calcium and phosphorus from?
Yes, sir. Basically, this biomimetic material are actually dependent majorly on the salivary flow of the patient, sir. So then that's why there is a disadvantage in the patients when we use in a xerostomia patient that they doesn't have a salivary flow much. So when this salivary flow is reduced, that in xerostomia patient we prefer a fluoride boosters rather than a biomimetic material. So this biomimetic material calcium the fluoride and calcium which is available in the saliva and accumulates. Because of their higher efficiency and absorption of this calcium and phosphate, there is a data tendency of a calculus formation also. And the storage disadvantage of this amylogenin and this dentin D8DS peptides has been overcome by the analogs which is used is the polyamidoamine material. So this storage disadvantage as well as the longevity of this material can be overcome. And also to control the growth of this material, there has been addition of matrix metalloproteins as well as a polymetaphosphates into that. So this controls the growth of the formation of crystals also, sir.
Okay, fine.
Yeah, doctor, one last question.
Yes, sir.
How toxic fluoride is if it is applied topically?
Sir, fluoride is actually from beginning when we talk about fluoride, it was in some concentration. So studies which prove that the concentration is less, so they what try to do is they increase the concentration of the fluoride. But still the increase caused the fluorosis, but the result was very good in controlling the caries. So to overcome this disadvantage only, they invented these products so that the disadvantage of fluoride can be reduced. That fluorosis formation, the occult caries formation, because fluoride only caused the superficial mineralization of the areas.
So according to you, if fluoride is applied under the optimal level, it is still safer, right?
Yes, sir. It is safer, sir. But the efficacy is more when these materials are used.
Thank you.
Thank you, sir.
Thank you, judges. Audience, please note that was DB02. You can now start voting on a scale of 1 to 5. 1 is good and 5 is excellent. Thank you, doctors. Moving on, we have DB03. DB03 can now start screen sharing.
Yes, sir. Yes, sir. Okay, sir. Is my screen seen, sir?
Yes, doctor, your screen is seen. Please go into the full screen mode now.
Is my video seen, sir?
Yes,
Okay,
doctor.
sir.
You're visible, doctor.
Am I audible, sir?
You're audible, doctor. You can start now. All the best.
Okay, sir. Okay, sir. Thank you, sir. Good evening to all the judges and all the dignitaries present. My topic for paper presentation is non-invasive approach for treatment of white spot lesion. As you all know, dental caries is caused by the plaque bacteria which is present in the dental plaque. This dental bacteria which is present in a dental plaque acts on the fermentable carbohydrates, which leads to demineralization of the tooth surface. And because of this, there will be an increase in the demineralization and reducing the remineralization. And there's an imbalance in the demineralization and remineralization cycle. Because of this, there will be causation of dental caries. White spot lesion. White spot lesion is the earliest stage of caries, and at this stage, it's very important to control the caries process, and at this stage, remineralization can occur. So white spot lesion has been defined as subsurface enamel porosity from carious demineralization. They present themselves as a milky white opacity when located on the smooth surfaces. But we have to understand, why does this enamel appear opaque? This enamel appear opaque because of the mineral loss in the body of the lesion, resulting in the greater visual enamel opacity. And this is due to the alteration in the refractive index of the affected area. we have to understand the refractive area or refractive index of the affected area is different than the refractive area, refractive index of the normal area. Because of this, the enamel appears opaque. And we have been practicing various treatment for the treatment of this white spot lesion. We used to use restorations which were causing extensive tooth destruction. But now we can look into a more non-invasive sort of a treatment, which is very helpful, which causes no harm to tooth structure, as well as it can make the child, especially a child, more compliant, because there is no dental drilling present. The various remineralizing agents which can be used are fluoride varnishes, casein phosphopeptide, amorphous calcium phosphate, resin infiltrate, sodium calcium phosphosilicate, calcium carbonate carrier, xylitol carrier, nanohydroxyapatite, and others. Various fluoride varnishes can be used in the remineralization of the white spot lesion. The mechanism of its action is that it releases fluoride, and it's also very easy to apply this fluoride varnishes on the teeth. It sticks the tooth surfaces, and it releases fluoride and calcium, and it can diffuse into the dental plaque and cause remineralization. Now, various fluoride varnishes available with various contents, like Durafat, which contains 5% sodium fluoride. Next is amorphous calcium phosphate and casein phosphopeptide. This component, the casein phosphopeptide, what it does is like it attaches to the tooth surfaces, and this helps the ACP which is present to go and attach to the tooth surface, and then releases calcium and phosphate ions. It also causes an increase in the fluoride ions. Because of this, the remineralization occurs, and there are various materials available in the market which can be used in the remineralization of white spot lesion. Next is resin infiltrate, which is marketed under the name of Icon. The principle is that the refractive index of sound enamel is 1.62, whereas the refractive index of enamel after being filled with water is 1.33. And the refractive index of enamel after being filled with air is 1.0. Because of this, the whitish appearance of enamel is seen. Whereas when we use resin infiltrate, the refractive index is 1.46, which is very close to that of enamel. Because of this, the masking of white spot lesion takes place, and also this resin infiltrates the pore and stops the caries process, and it also helps in stopping the caries. And resin infiltrate, once the caries is stopped, the saliva is present, which causes the remineralization of the lesion. Next is sodium calcium phosphosilicate, which is also a bioactive glass. So this sodium calcium phosphosilicate, when it is applied, it releases sodium, calcium, and phosphorus. Because of that, it attaches to the tooth surface and leads to the remineralization. It causes the formation of hydroxycarbonate ion. Because of that, the remineralization takes place. Next is calcium carbonate carrier sensitate. It is made up of arginine bicarbonate and amino acid complex and particles of calcium carbonate, a common abrasive used in toothpaste. Arginine complex is responsible for calcium particles to the surface, which releases calcium, and then it is available to remineralize the tooth surface. Xylitol carrier. Use xylitol carrier chewing gum, which is present in chewing gum. What it does, like it increases the salivary flow. Because of the increase in the salivary flow and others, the pH increases. Because of it, the bicarbonate and phosphate ion increases. Because of it, the remineralization can occur. Next is nanohydroxyapatite particles. Nanohydroxyapatite particles are present in the concentration which is more used for remineralization, which is helpful is 10:5. These hydroxyapatite crystals directly fill up the defects and micropores present in the demineralized tooth. A large amount of calcium and phosphate ions are attracted from the remineralization solution to the enamel surface to fill the vacant position on the enamel calcium crystals and causes remineralization. There are a few other materials which are also helpful in the remineralization, which is trimetaphosphate ion, alpha tricalcium phosphate, dicalcium phosphate dihydrate. Alpha tricalcium phosphate and dicalcium phosphate dihydrate ions materials releases calcium and phosphate ions, because of which the remineralization of the demineralized area occurs. Whereas trimetaphosphate surface, and it prevents the acid attack to occur. Because of this, the demineralization doesn't occur, and it leads to remineralization. So I like to conclude that the dynamic balance between demineralization and remineralization determines the progress of white spot lesion. Increase in the remineralization process leads to a reversal of white spot lesion. The treatment should be done in such a way there is no loss of enamel surface, and various treatment methods and materials can be used to prevent white spot lesions. These are my references. Thank you.
Thank you, doctor, for the wonderful presentation. Judges, please note that was DB03. Judges can now ask questions. Sir.
Suppose you have identified a patient with a white spot lesion and you have prescribed the remineralization protocol to that particular patient, how long you will advise for the remineralization protocol, and how do you confirm that it has completely reversed back to its original form?
So we can use various instruments like Diagnodent. Diagnodent can be used in checking the remineralization as well as the demineralization. So we can use Diagnodent and check the score. So depending upon the score, we take a score first. We apply this remineralization agent. We can follow up the patient in a duration of 1 month, 3 months, or 6 months, and we can see whether the Diagnodent score is decreasing. Depending upon that, we can understand whether the remineralization of these lesions have been happening or no.
What is the role of disclosing agent? How it will react?
So disclosing agents can also help. We can see like various disclosing agents can be used to identify if there's a plaque present or no. So this also can help in the identification of demineralization. So this also can be used to check.
How long the protocol should be there on an average for a patient?
On an average, I feel 3 to 6 months. Like we can follow up the patient for around 3 to 6 months to understand if the remineralization has occurred.
Do you have any evidence of literature supporting that 3 to 6 weeks?
Sir, depending on fluoride varnish using Durafat and resin infiltrate, there was an article in which they have told that we can use, and 3 months they checked the Diagnodent score and they found out that the remineralization of the lesion has occurred in 3 months. And there was reduction in the score of Diagnodent, and because of this, we can understand that the remineralization of the lesion has occurred.
Thank you.
I have a question. Just prescribing remineralizing agents for a patient, will it be sufficient without taking into control of their dietary habits? Because whatever the study you have mentioned are all in vitro studies.
Yes, sir. Yes. So no, sir. Like we have to definitely enforce dietary changes in the patient. We have to identify what is the caries risk of a patient. Depending upon that, we have to change the diet. We have to prescribe. We have to understand that we have to make the dietary changes which are required for the patient. Also, there are various other methods. Like we have to, like in pediatric patient, we have to guide the parents to make them understand the role of diet as well as this remineralization. So it goes hand in hand. It's not just a remineralization agent. We have to even take the dietary role into consideration when you are prescribing these things to achieve a better result.
Yeah, you just talked about pediatric patients, right? In pediatric patient, any material of choice for remineralization?
So as we all know, like in pediatric patient right now, mostly what we use is fluoride varnishes.
What is SDF?
SDF is silver diamine fluoride. So it's this thing. It stops the dental caries.
So it will not remineralize.
But
it will not remineralize.
It doesn't remineralize. It stops the caries process. Sir.
Okay. And you just mentioned about the bioactive classes. And recalcitrant technology. What are the products available in market in India?
Sir, this is Novamin, sir. Whereas for this CPP, ACP is Recaldent. It goes in the name, sir.
No,
which is available.
Available in market. I mean, in the shops.
So Novamin.
Novamin is technology, right?
Available, sir. And GC.
Yeah.
GC toothpaste, sir.
GC toothpaste. Okay, fine.
Recaldent GC toothpaste.
Okay, and last question is how does the laser and ozone will aid in remineralization? Laser, ozone.
Sir, laser. It helps to remineralize the area by it causes thermal changes. Because of this thermal changes, that it can cause remineralization, like prevents remineralization and causes remineralization. And it also ozone is antibacterial, sir. Because of this, it can cause stop the demineralization process.
Ozone is antibacterial.
And it opens up the pores, sir.
Okay. Okay. Thank you.
Thank you, judges. Thank you, doctor. Audience, please note we have a polling that has started. Please cast your vote on a scale of 1 to 5, where 5 is excellent and 1 is good. Thank you, doctors. Moving on, we have DB04. DB04 can unmute yourself and start your screen share, doctor.
Good evening, sir.
Good evening, doctor. You can start your screen share. You can go into full screen mode now. Yes.
Is my screen visible, sir?
It is, doctor. You can start.
Good evening, respected panelists. I'm delighted to be a part of the first of its kind International Online Conclave. As the theme goes, Dentistry Beyond 2020. I'm here presenting before you a paper regarding documentation, Elucidate with Buzzer. The past is gone, we live in the present and no one can predict the future. This is a reality that we cannot deny because our memories can become unclear and lack detail. To keep them alive, we often try to capture moments with photographs and videos. In digital dental photography, we use cameras, and the applications include diagnosis and treatment planning, legal documentation, publishing, and lecturing. DSLR cameras are widely used in dentistry to take high-definition macro images. Smartphones and tablet cameras were designed for public use and not for dentistry. So the macro functionality was developed to use these devices as scanners to be able to copy and send documents immediately. The gap between the two devices continue to get smaller as smartphone technology is improving. The inventor, Nicephore, is credited for the first partially successful photograph in the early 19th century. With the evolution of the technology in the late 20th century and the introduction of pocket cameras followed the integration of cameras in mobile phones. Billions of photographs are taken worldwide each day, and most of them are captured with mobile phones. Improved optical zooming, 3D imaging, and depth sensing are the series of projects that projects the future of the smartphone cameras. We know that many dentists are already using smartphones because they do not have the professional cameras, but a poorly taken photograph can compromise the quality of the dentistry delivered to the patient. So it is important to understand how to properly use the smartphone camera in the context of clinical photography. The photographs are widely divided into preoperative and postoperative photographs, and further divided into intraoral and extraoral, and 5 dental different views are available. They are the anterior view, right lateral view, left lateral view, upper occlusal view, and the lower occlusal view. Tricks to get a good quality photograph includes, we need a lip retractor to hold the lips and which does not appear in the image. We'll place them at about 45 degrees. We disinfect the mobile to avoid possible infections to be transmitted from the patient to patient. We place straight opaque retractor in the patient's mouth to prevent the tongue from interfering with the image and create reflections or bad contrast. The opaque retractor will also be used as a base to hold the mobile, always placing it 45 degrees. And for the luminosity, we use the light of the lamp that is incorporated in the dental chair. We place the lamp above the patient at 90 degrees to get more texture in the image. And ideal would be to diffuse the light to lower intensity by placing a white cloth in a lamp in the shape of a bag. Once all the steps are complete, it is time to take a picture. And with the lock focus function in the camera, we can simply click on the screen where you want the image to be more focused. The extraoral photographs are made as a portrait, and we see how the bite affects the morphology of the face. The patient should have a complete natural smile, and nose should be the center of the image. Special care must be taken so that no shadow appears in the wall where the photo is taken, and the background should be black or white. And the patient should be placed 50 to 60 centimeter in front of the fundus to reduce the shadow. And the mobile phone is placed at the level of patient's eye. General tips for a good photograph includes removal of the remains such as plaques, stones, blood, or excess cement, good positioning of the patient in a uniform background and with the facial asymmetries taken into account, proper use of angle, framing, focus values, and correct tilting of the camera. Many external artificial light sources devices, they have been developed to provide DSLR quality pictures with smartphones, which include Cocolux, Smile Light, MDP, and Smart Dental Light And coming to the Smart Dentalite mobile dental photography, this device is equipped with 3 groups of LEDs. Each group can be lit individually, and the back is equipped with a universal adapter that is adjustable for any model of smartphones having a width between 55 to 85 millimeter. It is a plug-and-play device and very easy to use and does not require any special app or calibration or specific education. It makes the photography very easy. Photographs allow the patient to visualize his or her smile and oral conditions with the same acute perspective as that of the dentist and helps the patient to understand the rationale of recommended treatment. Method to simplify dental photography can be use of mobile phones with high megapixel camera. Mobile photography has evolved during the last few years, enabling easy way to capture the images without any expensive gadgets. High quality dental photography is readily achievable with practice and consistent application in clinical practice. Understanding the basics of mobile photography techniques and properly applying the fundamentals will help dental team to consistently document clinically useful dental photographic records. So I'll conclude by saying, why not mobile phones rather than a DSLR? Thank you.
Yeah. Before someone asks question, I would like to tell one of our judges, Dr. Madhav Nirmal sir, he is more fond of this photography, this wildlife photography and all those stuff. So I know, sir, if you ask sir to talk about photography, he'll be talking for ages. Okay, I think sir will put on all the questions to you. I have one question towards the end, I'll tell.
Sure, sir. I have a lot of points against cell phone photography. First thing is there is something called as linear distortion. Okay, the mobile phone photography is good when you want to show the picture only to the patient. If you want to record it properly and send it for publication and all, this distortion has to be overcome, which is not possible with mobile. Second, flat light, in the sense like light from your dental chair or light from a flash in the camera, like anything straight, will compress the picture and you lose the three-dimension nature of the picture. That is why for aesthetic dentistry, you should always use dual flash. Even ring flash will flatten the picture. Dual flash is better because one side the intensity will be slightly lesser comparing to the other side, which will clearly show you what color the teeth is and is there any variation in the color and all those things. And also megapixel is something like even 5 megapixel pictures will be really good. 50 megapixel pictures will not be good. The pixel mania is something which is market mimic. It is needed only when you want to enlarge your picture to make a hoarding which can be kept in any cities like 40 into life size or more than that. Anything seen in the computer, or like if you want to send it to a journal, 5 megapixel is more than enough, and you can't differentiate a picture taken in 5 megapixel and 50 megapixel or 500 megapixel. Okay, so that megapixel is totally market gimmick. You don't require that much. A4 size photograph taken in 5 megapixel and 50 megapixel, you can't make out which is better. Okay, so mobile photography, okay, to a certain extent you can use it if you don't have aesthetic dentistry practicing in your clinic, or if you don't want to send it to a good international publication, then it is fine. To show it to just to patient is fine. And the worst and the most difficult part is like sterilization protocol. It's very difficult. Like you have to go very closer to the patient, and so each time you have to watch your iPhone if you're using iPhone. Okay, all these things are there. Anyway, it is a good presentation. Okay.
Yes, sir. After all your insights, I would like to ask her one thing. In extraoral photography, you mentioned complete natural smile. How it should be, doctor? Can you just make one? Because I couldn't able to gain that for 90% of patients. Sir, any tips for that, sir? Complete natural smile.
Even I don't know, sir.
Yes, sir. Thank you, sir.
Yeah, welcome.
Sir,
okay, thank you.
One question. You're telling about mobile photography. You know, there is a recent advancement in mobile photography called as LIDAR technology. Can you enlighten about that? LIDAR. Madhavan sir was telling the answer. The last sentence he told the answer. LIDAR technology.
Sir, to take the pictures in small speed, like nano speeds, to reduce the.
Like we tell our PGs, you find it out and tell it in the final presentation, okay? So it's actually a two-dimensional photography converted into 3D representation. And sir was mentioning about iPhone. It is available in iPhone, the LIDAR technology. You can just read it about 2D into 3D.
Thank you, sir. Sure.
Thank you.
Thank you, judges. The audience can now start voting. Please note, on a scale of 1 to 5, 1 is excellent. 5 is excellent and 1 is good. Thank you, doctors. Moving on, judges, please note, we have DB05. DB05 can now start your screen share.
Good evening, sir. Can you see my slides?
Yes, doctor. Slides are visible. You could be a bit more louder, doctor.
Audio and video?
Yeah.
Can I start, sir?
Yes, you can start, doctor.
Good evening, respected panelists. I am here to present the way to conference, practice with evidence, to change the dogmas to corroboration in prosthodontics. Dogma is defined as a belief or opinion held to be true, but still cherished with implicit faith, whereas corroboration is defined as evidence which confirms or supports a statement, theory, or finding, or confirmation. Clinical procedures without good evidence means outcome is unknown or worse, do more good than harm. I would like to start with the picture of Galileo Galilei trying to correct the dogma that Earth is flat but round, which is later corroborated. Similarly, in the long run, many of today's dogmas that lack evidence will be abandoned. In the era of evidence-based dentistry, ineffective interventions should be eliminated and decisions should be made on best available literatures and evidences. We used the materials and methods. We used the Medline PubMed search with EBSCOhost, revealed around 1 lakh active articles for selected aspects of the prosthodontic treatment, focused on long-term randomized control studies on various aspects of prosthodontic treatment. The lack of evidences are seen in almost all the literatures. There is no randomized control study comparing a 3-unit bridge with a single implant restoration when replacing a tooth. No randomized control study found comparing root canal treatment followed by a crown or extraction and a single tooth implant treatment of compromised tooth. Those are many of the missing evidences in the planning treatment. There are some old dogmas, one of which is shortened dental arch, SDA. Tooth loss must always be replaced. This was questioned. And acceptable dental occlusion by patient with reduced dentition. Occlusion has to be comfortable to the patients, functions without problems, is stable and does not change. The reference is Ludar et al. In his article. Concept of ideal occlusion was later corroborated by individuals of ideal occlusion, seldom seen in real life, still they function well. Occlusion of restorations in natural teeth and of implant processes differs in bone contact between implant and natural teeth, but clinically that difference was negligible. Reference is Mohammed Ali and Davidson et al. Therapeutic occlusion, modified occlusion in order to change a non-physiological occlusion that is in FPD, crown, etc. Even with this modification, systematic review shows that FPD survival rate of 89% in 10 years and median survival rate of FPDs can be assessed as 20 years. The fabrication of a complete denture, classical randomized control studies of around 20 years duration in 1969 stated there is no difference was noted between simple and complex method of denture fabrication in respect to tissue response, patient satisfaction, and denture quality. Maintaining complex and sophisticated methods may not lead to better clinical end results. Study using Delphi technique revealed that it does not matter which type of teeth are used or which occlusal philosophy is used, as long as the scheme chosen contributes to the stability in function and parafunctions. Reference is Iki JC et al. Use of face bows. In Scandinavia, face bows have been scarcely used been used at all during the last 3 decades, since no evidence of better clinical results without them has been published. They stated no significant advantage compared to an average mounting. 97% of the prosthodontists in China seldom use face bows. It is sometimes argued in complete denture fabrication, we may manage without a face bow, but in special situations like planning orthognathic surgery, face bow is an absolute necessity. Reference is Kawai et al. Dental implants, even though it's 60 years since Brennemark first replaced implants, it took another 17 years to accept the present it to the Northern American Prosthodontic Journal. Initial skepticism later changed to the enthusiasm. Unprecedented success flourished implant treatment, but treatment charges has becoming an obstacle for many. Based on studies, success rate for tooth supported is more compared to the implant supported processes. Most of the edentulous patients prefer conventional denture treatment than implant. The reason being they belong to the poorer segment of the population, so we should intensify teaching and specialist training in complete denture prosthodontics. Systematic review shows the incidence of technical complications was higher for implant supported than for the tooth supported reconstructions. Reference is Pettigens B. et al. Implant failure, occlusal conditions and overloading was said to be the main cause of failure, but no clear studies has proven it. The only evidence is the opinion has been demonstrated in a single animal study, but not in any of the human studies. The causative relationship between loading and bone loss was never been convincingly demonstrated in that study. Schwartz MS is the reference for this. Role of occlusion in TMD etiology. Occlusal disturbances were believed to be the dominant cause of TMD. Randomized control studies showed that other therapies without effect on occlusion provided equally good or better results. So correcting the occlusion is not mandatory for TMD patients. Rather, simple therapy like self-care instructions, medication will solve majority of the issues. Occlusal splints or appliances. An anterior biplane with occlusal contacts only on the incisors and canines has proven to be as effective as a stabilization splint. The so-called placebo splint that only covers the palate without touching the occlusion is largely as effective as an occlusal splint. Like crutches in the orthopedic patients, splint's outcome is based on the time factor only and complaint fluctuations. This is quoted by Tarab JC et al. As a conclusion, much of the research has been performed without ambiguous and imprecise definitions and has not provided unshakable results to convince all the practitioners. Studies showed that any proved new method took around 17 years to get implemented in the daily practice. But it takes more time to rule out any dogmas that is being followed through decades. Thank you.
Thank you, Doctor. Judges, please note that was DB05. Judges can now ask questions. Sir.
So as a prosthodontist, actually this particular presentation is highly controversial. Anybody who likes to present in our society will definitely get a lot of beatings. But then the way of presentation, you have showcased a lot of evidence-based literature. But on a nutshell, I would say that not everything should be exactly looked upon based on the literature. It's also a common sense approach. You've been mentioning about what is a simple and what is a complex procedure. I mean, you've been comparing one study about simple and complex. What according to that study is simple and what according to that is complex? Can you just elaborate? Just one point.
So in a study, we can even use a face bow to fabricate face bow and articulator to fabricate, or you can use a fox plane also. Sir. But the result outcome is is more or less same for the patient side, from the patient side.
Okay. Usage of face bow is not a complex procedure. First of all, you should understand, just because that we have not taught in our undergraduate level, we always say that using a face bow is so complex. It's not at all so. Hardly it is going to take 1 or 2 minutes. Once you know the technical know-how, you're going to assemble it and relate it with the patient. So I don't think so. These things are complex procedures and should be avoided. So there will be always pros and cons. And there will be always schools of thought which advocate the usage of all these procedures. And there will be some articles which will be against these things. So you cannot take it as granted. So you mean to say that only simple procedures should be advocated hereafter, isn't it? Not complex procedures.
So many of the cases in which we are planning for bigger orthognathic surgery, we have to relate the maxilla with the cranium and the other point.
Why only orthognathic? Why only orthognathic? Is there any reason for that?
orthognathics, most of the structures of the maxilla will be like in a maxillectomy cases and all, most of the portion of the maxilla will be removed. So in those cases, if we want to establish a plane of occlusion, we have to relate it with the cranium. So in those cases, we can, it's very, it's an absolute necessity to use a Facebook and relate it. So,
Okay.
it's a bit controversial. So.
Thank you, sir. Sir is facing a net issue, I think. Any other judges would like to ask questions?
I'm sorry, I've lost connection. Please go ahead. Sorry.
Yeah, thank you, sir. So up next, we have the polling section. Audience can now vote on a scale of 1 to 5, with 5 being excellent and 1 being good. Thank you, doctors. Moving on, we have DB06. DB06, can unmute yourself and start your screen share now.
Yes, sir.
You can go into full screen mode now.
Yes, sir. Is it visible?
Yes, doctor. We can start now.
Good evening, respected judges, my teachers, and all. Today, I will be presenting the case presentation on vital teeth bleaching. These are my table of contents. Starting with the introduction, tooth whitening can be a very effective way of lightening the enamel color of your teeth without removing any of the tooth surfaces. It cannot make a complete color change, but it may lighten the existing shade of the tooth. In general dental practice, tooth whitening is known as a tooth bleaching procedure. Self-awareness of a discolored teeth has ranged by the color quality of television, movies, electronic, and print media. As we all are seeing the heroines in television and mobiles and social medias. Intrinsic color of the tooth and the external stains are in combination responsible for the tooth color. Usually, the extrinsic stains tend to form in the areas of the teeth that are less accessible to cleaning procedures by toothbrushes and also associated with the smoking, dietary intake of tannin-rich foods like red wine and tea, and the use of a certain cationic agent such as chlorhexidine or metal salts such as tin and iron-based products. There are various methods to remove the surface discolorations, which includes the scaling, polishing, whitening toothpaste, bleaching, microabrasion of enamel, veneers, crowns, and etc. So coming to the case report, a 22-year-old female patient reported to our college with the chief complaint of discoloration of her teeth. Patient had no significant medical history. Intraoral examination revealed the yellowish intrinsic stains and areas of opacity on the maxillary anterior teeth. There was no pitting was present. There is no history of any sensitivity. So we came to final diagnosis is that grade 2 moderate dental fluorosis, and the treatment plan was vital teeth bleaching in relation to 1-1 and 2-1. So coming to the clinical procedure, the oral prophylaxis was carried out before starting the bleaching treatment. The selection of the bleaching agent for this patient, the Pola office was chosen. This material contains the 35% hydrogen peroxide and a potassium nitrate, which act as a desensitizer. In first appointment, the teeth were dyed and isolated. The gingival barrier was applied over the tooth and the light cured for 20 seconds. The equal amount of bleaching powder and the gel was taken and the mix until a thick homogeneous mixture was formed. A thick layer of this gel was applied on the labial surfaces of the teeth using the applicator tip. After the application of the gel, the bleaching LED light was applied for 8 minutes. The 3 applications were used to complete the in-office procedure. After the last application, the bleaching agent was removed using the air-water syringe and suction. The post-operative instructions were then given to the patients. So in next appointment, the similar clinical procedure was carried out for next appointment as in the first appointment. As we can see in the picture, the results after the second appointment and the results after the third appointment is the final results. So in this picture, we can compare the results of how it was looking pre-operatively and how it was the result came after post-operative treatment. So coming to the discussion, Tooth discoloration is defined as any change in the hue, color, or translucency of the tooth due to any causes like restorative filling materials, drugs such as topical and systemic drugs, pulpal necrosis, or hemorrhage, that may be responsible. The discoloration may be induced by the intrinsic stains incorporated into tooth structures and extrinsic stains deposited onto the tooth surfaces. Dental fluorosis or mottled tooth is a type of enamel hypoplasia. It is caused by the excessive exposure of a fluoride during the tooth formation, resulting in defects in mineralized tooth structure, particularly in the enamel matrix. There are various brands of bleaching agents with various concentrations are available. There are various materials like hydrogen peroxide, sodium paraborate, and carbamide peroxides are available. Here in this case, the polyoffice bleaching is used, and it is the it has the most promising outcome among all the other materials. Along 35% hydrogen peroxide, polyoffice consisting of a potassium nitrate, so patient's post-operative sensitivity will be reduced. Before starting the bleaching procedure, the proper clinical evaluation and the history taking is very important to understand the etiological factors responsible for the tooth discoloration and the degree of discoloration of the tooth. Non-vital and traumatic tooth usually looks discolored. Hence, before bleaching procedure, the electric pulp testing should be done to avoid the misdiagnosis and the wrong treatment of a tooth. The pulpal irritation and the tooth sensitivity may be higher with the use of the bleaching lights or heat application, and the causes has been advised before their use. High concentration bleaching agent has an adverse effect on underlying pulp tissue. Many in vitro studies have shown that the penetration of a bleaching agent into the pulpal chamber when bleaching agent is exposed to the tooth surface for more than 60 minutes. In vivo studies by the Cohen and Robertson shows either no or very minimal inflammation of the pulp when exposed to the 35% hydrogen peroxide. The pulp is a protective mechanism of pulp against the bleaching agent is by the breakdown of peroxide molecule by enzyme peroxidase and catalase. Anderson reported the hemoxygenase enzyme is protective enzyme present in the endothelial cells and the odontoblast present near the blanch enamel and prevents the diffusion of a bleaching molecule into the pulp chamber. Another factor responsible for the diffusion of a bleaching molecule into the pulp chamber is a positive pressure within the pulp chamber and the osmotic pressure of the bleaching agent. Clinically, bleaching technique is still the most conservative treatment to discolor teeth when compared to the veneers and the crowns. So coming to the conclusion, nowadays the tooth bleaching has gained the popularity because of its growing awareness and increased aesthetic desires of the patients. In-office tooth bleaching procedure is one of the safe and the fastest procedure for teeth whitening. As per newer bleaching material evolution into the field of dentistry, in-office bleaching is safe without any adverse effect on the tooth structure when proper concentration of a bleaching agent is used and instruction to the patient is given. A careful monitoring and a supervision is critical for achieving a successful and a safe. Sir, I was muted.
Yeah.
It is automatically muted because you exceeded the timing. That's why. Now the judges can ask question, please.
Okay.
Yeah. What is the novelty in your case? Like what you did differently, or what are you trying to tell us?
So there was a stains of a fluorosis case. We removed the stains of that fluorosis. It was the grade 2 mottled fluorosis stain.
Okay. You did anything like different from the regular protocol of using the particular product?
No, sir. I just followed the protocol which we are doing usually for the bleaching procedure.
Yeah, that's what.
Yes.
Okay.
If home bleaching is safer than in-office bleaching, why you want to go for in-office bleaching?
Sir, because we get the faster results in the in-office bleaching, sir, and we can maintain the solutions like hydrogen peroxide are irritating to the gingival tissue, sir. We can in clinic, sir, we can prevent this kind of the complications, sir. That's why, sir, we are preferring to do in-office.
But imagine the situation: you are trying to dehydrate the tooth completely. You are removing the moisture content. You are frying the tooth with LED light, and you are applying power bleach. more than what is permissible, obviously the results will be faster.
Yes,
But
sir.
is it really necessary to go with in-office bleaching every time for a vital tooth?
No, sir. We can advise, sir, night guards to go for the vital bleaching.
I mean, home
Yes.
bleach.
Yes, sir. Home bleach.
Home bleach will be always safer. It
Yes,
is
sir.
less than 10%. It's
Yes,
going
sir.
to be
10%.
slow, but
Yes,
the
sir.
result is sustained. But
Yes.
this is faster and sometimes deleterious to the patient also.
Yes, sir.
That's what my point.
Yes.
Thank you.
Thank you.
Whether your patient had any sensitivity issues?
No, sir. Patient was not having any issues, sir. And sir, post-operative instructions I had given, and sir, I had also advised that desensitizing toothpaste for the patient.
You
Sir,
advise that
yes,
desensitizing toothpaste.
Yes, sir.
Okay. Okay.
Thank you, sir. Audience can now start voting. On a scale of 1 to 5, 5 is excellent and 1 is good.
Thank you, judges. Thank you, my teachers. Thank you.
Thank you, doctors. Moving on, we have DB07. DB07 can now unmute yourself and start your screen share.
Hello. Am I audible?
Yes, doctor, you are.
Yes, sir.
Please go into the full screen mode, doctor.
Yes, sir. Is my screen visible?
Yes, doctor, you can start.
Okay. Very popular quote in the dental fraternity that I was created to create beautiful smile. Good evening, everyone. Good evening to all the jury members and my colleagues in this new normal. So today, let's just broaden our views. Let's just go a step ahead from the old school thought and visualize new concept of special complete dentures for medically compromised patients with QR code labeling. We all know that when a geriatric patient enters our clinic, they need a special care. And if the person is medically compromised, the perception of our treatment changes drastically. There is always a sip between the cup and the lip. We have to be very much careful and take care of the particular patient that enters, especially a geriatric medically compromised patient. See, no matter how the patient enters to the clinic, the main aim and the main motto of a clinician is to provide him a beautiful smile. The main aim is to provide an aesthetically appealing smile and good in function. Now, to say that a geriatric teen is tough to handle, they have not met a prosthodontist yet. We provide the best aesthetic smile to the patient so that he could be happy with, and the function or the masticatory functions could be retained. Now, when a medically compromised patient enters to the clinic, we have all witnessed it. He's always carried out with an assistant, a person who is assisting him and accompanying him with a bunch of prescriptions and all. He's trying to convey all those terms, that what has happened, what is happening, and what are the past history of the patient. He's telling all to the particular dentist or the clinician. Now, in these cases, many a times it happens there is a miscommunication and the communication gap because the particular accompanying person is not aware of many of the medical terms. There is a communication gap between the clinician, between the accompanying person, and to the patient who is there. Now, after the treatment have been done or the post-operative instructions have been given to the accompanying person, sometimes he found it very difficult to deliver exactly and accurately all those instructions to the family members correctly. Now, the basic idea what I got was, why not to capitalize everything? Why not to summarize all this stuff into a PDF and bombard it over to a QR code? Why not to create something that would be more easy and that would be more feasible and more appealing for the patient and for the family members also. Now, there have been many research articles that have been published by the many clinicians regarding the reliability of QR codes, placements of QR code over the dentures, barcode for the patient identification, how the QR codes are temperature or acids, or QR codes being the future of dentistry, or the use of QR codes in the forensic dentistry. There have been many research work that have been done by different clinicians or different dentists, like they have placed the QR codes over the patient for the personal identification, placement of QR codes, like in the dental clinics for their identification and keeping a record, placement of QR codes with a heat cure clear acrylic resin in order to find that whether they are reliable or not, they are heat resistant. And the mode of way is to just scan the QR code and get the particular information of what the patient name and age was. Now, what I did was I generated a QR code using the QR code generator software. It's a software where you can generate the QR codes. Now, it has got various manifestation in it. You can add websites, email links, your Facebook links and all. But there's one option where you can feed a PDF. Now, what I did was I created a PDF, a sample PDF for a patient in which I wrote some of the N number of details regarding the patient details, medical history, dental history, past history, the drug allergy systems and all. I converted that PDF and I placed it over to my QR code. Now I placed my QR code and placed a clear film over to the QR code, a IOPA film, and placed that over to my DVAX denture. Now, what the idea was placing the clear acrylic over to the QR code was that my QR code should not damage. It should not hamper. Now, when I'm placing my QR code over to my DVAX surface, keeping in mind that it should be stable, sticking it with the clear acrylic so that when I'm packing my denture, when I'm acrylizing it, it should not be shifted. Now, this is the result what I get. My maxillary denture in which there was a QR code embedded very beautifully onto it. When I polished it, I finished it and polished it. So this is the masterpiece I generated. The QR codes that have been brilliantly and efficiently placed over to the dentures without any distortion, without any discomfort. They are embedded directly, no elevation. They are just, when they are polished, they are not causing any discomfort or no elevation that could cause any pain, discomfort or harm to the patient. Now, what I did was I placed some heat or hot liquid over to it in order to test that whether my QR code is reliable, whether I could skim it. I placed vigorously the Russian and all, and I still found that my QR code was still reliable. I could scan my QR code and could generate the possible detail. Now, what the PDF, this was the PDF, a sample PDF I created. When you scan this QR code, this is what I generated. I generated a photograph of the patient. I could write any photograph, the name, age, sex, address, the past medical history, his past dental history, the drugs he's following or any drug he's allergic to, the diet he's following or the diet he need to follow. We could add pictures here for those persons who have got a language issue, or for illiterate people, we could have pictorials of denture cleaning aids.
Thank you, doctor, for the wonderful presentation. The system has actually muted you as you have exceeded the 6 minutes. Judges can now ask questions. You can unmute yourself now, DB7.
Yeah, placing a QR code chip in denture is not new. I have seen it around 6-7 years back, somebody presenting in Bangalore. What is new in this study?
The new in this study was I particularly placed it for, especially I categorized this study for a medically compromised patient, and this was not a QR code. What I placed, what I did was it was just only for those medically compromised patients. It was a specific research over there because those patients are very much conscious enough. They could not even talk to the dentist. They have got medical issues. So it's not easy each and every time for them to answer the problem or answer to the clinician's question. And when he visits to another clinician or any other medical professional for any other medical issues, now getting away with all those prescriptions is not easy. You could just get this software and you can scan the QR code for that particular patient and you can get all the ample number of necessary details that is possible.
Okay.
Yeah, doctor, you did this denture, right?
Yes, sir.
So for benefiting medically compromised patient, right?
Yes, sir.
Why can't you try oral sensors like smart tooth concept? There are sensors available which will analyze the saliva and send the data now and then to
Yes,
the receiving thing.
Mhm.
So they
Yes,
can,
sir.
I think a spit test, like a saliva test, can definitely replace a prick test, blood test. Why don't you try that concept?
I have learned, I've just studied all this concept. Was the main aim was to provide something that could be economic too. The QR code generation is a very, the software is not so costly. You can economically generate a software, and you can generate around 30 to 40 QRs with the help of the software if you buy the software. Now, every time it's not easy for every clinician to go for that scanners and all, because they are costly, and it's not feasible at every point of time, because sometimes what the patient also feels discomfort when he sees that like something saliva is tasting, because they have the conscious, and they are very conscious in the mind. If you are taking a saliva, if you're picking and you're going for it testing, they might the things might go in their mind that what the dentist is doing.
I think it's stuck.
DB07, can you hear me?
Yes, sir.
Yes, you had a small internet issue.
Sorry, sir. Yeah, I was like, the main aim was to provide the most economic method, because the scanners are very costly. The QR code generator software is, if we buy the software, we can produce n number of things. Because those medically compromised patients, they're very conscious when, like if we just check their oral cavity also, they have this thing in their mind that whether is something wrong has happened to my oral cavity, why the dentist is continuously looking at it. So if we take the saliva out of it, he might feel conscious. That's the reason we tried the most convenient and economic method that could be easily given and provided to all the dentists at different areas. In the different areas, we could provide this treatment protocol. It's not costly, it's very economic, and it's very easy to fabricate.
No, doctor, you didn't understand my point. Okay, that's fine. Any other questions, sir? Any other answer?
Yeah. How long this QR code is going to stay in the denture? Because it is going to be subjected with oral fluids daily, as well as dentrifices,
yes, sir,
and oral cleansing tablets. With all these things, how long it is going to stay?
So if we have, because I have placed a clear acrylic heat cure, a clear acrylic layer over to it, it will be very much effective and long lasting for the particular patient. If he's not temporarily, he's not intentionally harming that QR code, because it's the layer is covered with a clear acrylic, 1 to 2 clear acrylic is over there. So till the time the layer is there, if it's not intentionally harming that particular QR acrylic layer, it's feasible.
Is there any study? Is there
Yes,
any
sir.
study about the
Yes, sir.
longevity of the
Yes,
QR
sir.
code?
There has been a study where they have placed acrylic blocks, and they have placed the QR codes and placed a clear acrylic layer, 1 to 2 layer over it. And they have tested that if they place that particular block over to acid, over to heat, over to temperature, and over to fracture, then is the QR code reliable, or it resists for how many period of time? And they have got a study that the QR code is reliable if you put, if you have or clear acrylic over to it, it's reliable. If you kept it over to the acid for a longer of 1 to 1.5 hour, you place it, it's still, it doesn't hamper. They have placed hot liquids also. I have placed hot liquids over to that, keeping in mind and seeing that whether the clear acrylic layer goes off or it started degrading my QR code or not. But it was very much, what I saw the result was, it was very much clear and feasible for me.
Thank you.
Okay, thank you, sir.
Thank you, sir. Thank you, doctor. Now we have the polling session. Audience can now rate the program on a scale of 1 to 5, 5 being excellent and 1 being good. Thank you, doctors. Moving on, we have DB08. DB08 can unmute yourself and start your screen share. Please start, doctor.
Yes, sir. Good evening, respected judges and everyone present here. Today, I'll be presenting a paper on the topic Betatin, a boost in the fight against the COVID-19. Now, as we all know that the world is fighting against this pandemic, which is caused by the infectious disease called the coronavirus disease, also known as the COVID-19. Now, most of the people who are infected experience mild to moderate respiratory illness and recover without special treatments. However, when it comes to older people and those who are having underlying diseases are more likely to develop serious illness and may even cause death. Now, the best way to prevent and slow down the transmission is to be well informed about the virus and how it spreads. Now, here in this paper, I will be discussing on how the use of Betatin mouthwash can help us prevent the severe progression of this COVID-19. Now, there are various studies which have been done regarding the mouthwash that is effective against the COVID-19. I have selected few studies for this paper. This is a journal published in July 2020 under the Infectious Disease and Therapy Journal. Here, the Monty Pharma, they have announced that the laboratory testing at the Duke News Medical College in Singapore, they have found that the effectiveness of Betatin against this coronavirus. The testing has demonstrated that Betatin kills around 99.99% of the coronavirus, and the products which are subjected to testings were the antiseptic products, namely the solution that is 10%, the skin cleanser that is 7.5%, gargle and mouthwash, and also the throat spray. Another article published in Times of India under the heading, Can the Humble Betatin Help Fights Against the COVID-19? Here an associate professor, Dr. Sumita Shankar, they have started a study in COVID-19 positive patients at NRI Medical College Hospital. For both COVID-19 dedicated hospital, almost 40 days ago, she secured a green signal from the Indian Council for Medical Research and also the AIMS almost a month ago to take up the study. So after doing the study, she have said that the effectiveness of Betatin lasts for like around 4 to 6 hours, and it needs to be repeated at least 4 to 6 times a day. She noted that this seems to be the most simple and also inexpensive way of protecting the people in the current scenario. Another study published in the British Dental Journal 2020. Here, the evidence was based in vitro data of the povidone iodine virucidal activity against the coronavirus. Here, they presented a direct evidence of the viral activity of the povidone gargle against the coronavirus in just 15 seconds. So, in this scenario, today's scenario, the gargle as well as the mouthwash can be used as an adjuvant to the PPEs in reducing the risk of COVID-19 transmission in healthcare practices, especially when the oral interventions are warranted, such as in dental practices. Now, what is the significance of all these studies? COVID-19 is a pandemic spreading worldwide, and we need to develop an evidence-based protocol that can effectively prevent the virus spread via the droplet transmission. And all these studies demonstrate how the use of a Betatin mouthwash can minimize the spread of the virus. Now, how do we apply this evidence? They say that when we use Betatin, we can avoid the virus for 2 to 3 hours with 10 ml for 30 seconds. That is, we have to repeat for at least 4 to 5 times a day, and then we can avoid the virus for at least 2 to 3 hours. Now, first of all, preventing the infection spread at home. Suspected individuals or travelers that are put in home quarantine can be given the mouthwash at every 2 to 3 hours to prevent the spread at home. And also, the working people from the family going out every day to work cannot use mask at home, so they must use the mouthwash every 2 to 3 hours for up to 4 times a day when they come home. Another is preventing the infection spread in the OPD clinics. Outpatient care, we have to ask the patient to gargle the mouthwash before entering the clinics. That will give them safety period of around 2 to 3 hours in which they can complete their appointments. Now, dentists being the highest risk group may also use the mouthwash even more frequently to keep the risk consistency low. Now, to reduce the risk of infection spread to the health workers, now in special patient care hospitals, many patients are admitted which may be asymptomatic. So to prevent the disease transmission within the hospitals, the mouthwash used to be repeated at least 4 times a day. And also in COVID facilities, lot of health workers are getting infected in COVID wards. So mouthwash given every 2 hours to the admitted patients and also the health workers may minimize the transmission. Now, to reduce the risk of infection spread at the community level, people going out for events and gatherings should mandate that the events should get over in 1 to 2 hours maximum. And every person has to use the mouthwash before the event and also have to follow other safety protocols. Now, domestic flights of up to 2 hours duration, passengers can rinse and gargle before getting into the flights. And since the flights are closed environments, so additional measures have to be taken along with the mouthwash. Now, in order to conclude my paper, I would like to say that the betadine wash is obviously not the ultimate answer to the pandemic. However, it does definitely takes a place in the battle against the COVID-19. Now, as the saying goes, better safe than sorry. So it's better to follow all these measures along with other protective guidelines in order to prevent the transmission of the disease so that we keep ourselves as well as our community safe. These are my references. Thank you.
Thank you, Doctor. Judges, please note that was DB08. Judges can now ask questions. Sir?
Yeah, you're telling about the povidone. What are the equivalent formulations for povidone?
Sir, actually, whenever in the mouthwash, it is said that 0.2%, according to the study, they have used that. And when we are diluting it with water, then 2 ml in.
I'm sorry to interrupt. I'm not
Hello?
asking about the concentration. I'm asking about equivalent preparations. Something similar to povidone. What are the other alternate formulations? Do you know anything about that?
Hello?
08? Yes.
Yes, sir. Hello?
Okay, I don't know whether you have answered or not. The answer goes like this: stabilized chlorine dioxide. The brand name is Fresh Chlor, is an equivalent one for this betadine, povidone. That is what I was asking.
Okay, sir. Okay, sir. Yes, sir.
It is not the concentration, equivalent formulation I'm asking. Thank
yes,
you.
sir.
Yeah, doctor, what is the action of betadine against a virus? Hello?
DB08? She seems
Hello?
to have a net issue. Yes, she's back.
Yeah,
Yes,
yeah, what is the action, mode of action of betadine against
sir.
virus?
So actually, the antibacterial action is that first of all, there is a bovidin iodine complex. So whenever the iodine dissociates from the complex, it has a separate action. So it dissociates into the membrane, and then it goes and dissolves the cell membrane. Since this COVID-19, this virus, it's a capsulated. So chlorhexidine is also helpful, but it's not that effective compared to betadine because it cannot penetrate. But the betadine, it can penetrate into the membrane and then dissolve the proteins, denaturates a protein, and help to decrease the viricity.
Okay, accidental swallowing of the betadine, what will happen? How much we can swallow, at least you can tell that.
DB08? No, this time we have a net issue.
Hello?
No, doctor's back. DB08? Are you still here?
Okay, how much we can swallow it?
Hello? Yes, sir. Hello?
Okay, what will happen if accidentally we swallow it?
Sir, the diluted form is safe, sir. Like if we are, yes, sir, if we are using 0.23% of the chlorhexidine for gargling, then it is safe, sir. 0.23% of the betadine gargle. If it is in more, yes, sir.
Okay, fine. Any other questions, sir?
No.
Okay, thank you, sir. Audience, please note, we have the polling on. You can now vote for DB08 on a scale of 1 to 5, 5 being excellent and 1 being good. Thank you, doctors. Moving on, we have DB09. DB09 can now start your screen share.
Am I audible, sir?
Yes, doctor, you are. Go to the full screen mode, doctor.
Sir,
Yes, you can start now.
good evening, one and all. Today I am presenting the paper on the topic Knowledge, Attitude and Practice about Infection Control Protocols among Pediatric Dentists or General Dentists in India during COVID-19 pandemic and online cross-sectional survey. COVID-19, which is a fatal respiratory infection caused by a novel coronavirus, also known as SARS-CoV-2, which was first discovered in December 2019 in Wuhan City, Hubei Province, China. In India, the first confirmed case was reported on 30th January 2020 in Kerala. Dentists, who are at the front line for providing treatment for the oral disease, are one of the highest risk category to get COVID-19 infection. Hence, the Center for Disease Control, American Dental Association, and World Health Organization has suggested several interim guidelines to be followed in dental practice to curb the spread of infection. American Academy of Pediatric Dentists has also recommended guidelines for the pediatric dentists to practice during COVID-19 pandemic. The dentists may practice cautiously by following the interim guidelines by health authorities and dental association and to implement sound prevention measures in dental clinics and optimize their clinical practice to the changing trends to ensure safe and risk-free practice. Hence, the aim of my study is to assess the knowledge, attitude, and practice about infection control protocols among pediatric dentists or general dentists in India during COVID-19 pandemic. The materials and method. A cross-sectional and anonymous online survey was conducted among general dentists or pediatric dentists from different states of India, and a pilot study was done on 30 subjects to check the study validity. The sample size was calculated and it was 338. A semi-structured questionnaire in English was designed for the Google survey tool by a research expert for the study. The final questionnaire consisted of 5 questions related to the demographic data and 22 questions were related to the infection control protocol. This is the sample of the questionnaire that I had used for the study, which we will discuss in detail in the result. A total of 445, out of which 242 general dentists who are practicing pediatric dentistry and 203 specialists were responded, included in the final analysis, of which 79.1% were female and 20.9% were male. The majority were postgraduates within the age group of 20 to 30 years and 16.7% having private practice, with the 96.2% having experience of 0 to 10 years. On analyzing the results, we can see that 80% of the subjects were practicing during COVID-19 pandemic, and out of which 96.9% were aware of the current WHO, DCI, IDA, CDC guidelines regarding the cross-infection control of COVID-19. Out of which 91.2% were following these guidelines, and the 88.3% had trained their clinical staffs regarding these guidelines. 80% had also started pre-appointment screening and telephone triage of the patient. We can see that 82.2% had to modify their clinic setup in order to follow the guidelines. 92.1% is following the universal precaution for COVID-19 guideline for every patient. It's shown that 81.8% had started giving emergency care for the pediatric patients during COVID-19 pandemic. As a result, 61.3% had to modify their clinic's play area according to new guidelines. 64% had started treating the patients with aerosol generating procedures. It's observed that 44.7% had used personal protective equipment prior to the COVID-19 outbreak. But right now, 65.6% of the clinics have a separate area for donning and doffing of the PPE. 91.7% had concluded that the infection control protocols application in their clinic has affected the income expenditure of the clinic. 80.4% were confident in treating the patients with all these precautions during COVID-19 pandemic. 91% were aware of the authority to contact if they come across any patient with suspected COVID-19 infection. On analyzing the infection control device that had been installed in the clinic, 49.9% were gone for fumigation or fogging system. And it's observed that 49.4% of the subjects preferred surgical 3-ply or N95 face mask, gloves, and face shield for routine consultation of the patients. It's observed that the guideline recommend 3 times disinfection of the clinic, that is before starting daily work, after every procedure, and after finishing daily work. It's shown that only 33.5% of the subject is following this guideline properly. 45.4% of the participants fumigate their clinic daily, while 35.3% fumigate weekly once only, and 30% never fumigated their clinic. 43.4% of the participants managed the extra expenditure during COVID-19 by maintaining the treatment charge same, but additional charges for maintaining the protocol. 26.3% were following the practice with the same treatment charge before COVID-19 pandemic, while 22.5% increased their treatment charge. Discussion. Center for Disease Control and American Dental Association, along with the local governing authorities, has issued several interim guidelines and protocols to prevent the spread of COVID-19 in dental setup and instructed only to provide emergency treatment and all aerosol generating procedures needed to be avoided. The majority of the respondents were aware of the protocols issued by CDC, ADA, WHO, DCI, or IDA in the prevention of disease transmission. However, there are some lacunae in the knowledge with regard to the use of personal protective equipment, HEPA filters, and frequency of the disinfection of dental clinics. Conclusion, the finding of the study revealed that most of the subjects had adequate knowledge regarding the infection control protocol and are practicing it, resulting in few cases of COVID-19 infection among the dentists. The need of the hour is to update ourselves with the constantly changing situations and reorganize our methods of practice to combat new infections. These are my references. Thank you.
Thank you, Doctor. Judges, please note that was DB09. The audience can now start polling. Meanwhile, the judges can ask questions. Sir?
It's an interesting study. I appreciate that. And out of curiosity, I'm just asking, why have we included only pediatric dentists and general dentists for this particular survey? Is there any specific reason for that?
Sir, I'm a postgraduate in pediatric dentistry. That's why, sir.
You're not interested in other specialties. You're not going to practice.
No, sir. And another important thing is that there are general dentists who are practicing pediatric dentistry, and it's very important that we have to take care of the infection control should be more specific and up to the mark in case of pediatric practice, because because children who are under the age of 10 years are more prone for infection. So the infection control protocol need to be more specific, and we should be following it. There should be no compromise regarding the infection control protocols in case of pediatric dentistry specifically compared to the adults.
Thank you.
Oh, you mean to say that adults there can be compromise? No, I don't think so. For everybody, it has to be adopted. Okay.
No, sir.
And you said most of your subjects are postgraduate students.
Yes, sir.
Am I right?
Yes, sir. Yes, sir.
Is it not a bias in your study? Because only postgraduates are there and they definitely do 1 or 2 presentations. So they will know the protocol. You should have included other age group also, like people who are not postgraduates practicing activity, right? It is definitely a bias in your study.
Yes, sir.
So one thing, you have confined yourself to pediatric dentists. Second thing, that too, most of your samples are PGs. So the validity of the study is definitely biased. That's what I feel.
Sir, my
Okay,
study.
Tell me.
Out of the 453 samples, we have got general dentists, sir. About 338 were. They are not postgraduates. They are general dentists who are practicing pediatric dentistry.
No, okay, but earlier, like you said, most of them were postgraduates. The word you used, that's why I asked you.
Yeah.
Okay. So you can, when you take samples, like it has to cover everybody. Okay, a considerable number of doctors should be there, like in all categories, male, female, all kind of people should be there.
Yes, sir. Yes,
Thank
sir.
you.
Thank you, sir.
Thank you, sir. Moving on, we have DB10. DB10, can unmute yourself and start your screen share. DB10.
Yes, sir.
You can start your screen share, doctor. Yes. You can go to the full screen mode, doctor.
Is my screen visible, sir?
It's visible, doctor. You need to go into the full screen mode, doctor.
Yes, sir. Yes, sir.
Yes. You can start, doctor.
Yes, sir. Very good evening to all. Today I am here to present a case report on management of maxillary center incisor with periapical lesion and an open apex. And I will be covering this topic under the following headings. Now, starting with the introduction. As we all know, in the cases of open apices and large periapical lesions presents multiple challenges to successful treatment. In the first challenge is it is very difficult to disinfect such canals. Now, once the canals are properly disinfected, it is very difficult to fill the canal as the open apex provide no barrier for stopping the root filling materials before impinging on the periodontal tissue. And once all these challenges are overcome, the roots of these teeth are very thin and they have a very high susceptibility to fracture. Now there are two types of open apices. The first one is non-blunderbuss, in which walls are parallel to slightly convergent, and another one is blunderbuss, in which the walls are divergent and flaring. Now the causes of open apices are incomplete development, necrosis of pulp due to caries or trauma before root formation is completed, extensive apical resorption, root end resection, and over-instrumentation. Now, starting with the case report, a male patient aged 20 years reported to the Department of Conservative Dentistry and Endodontics with a chief complaint of tooth discoloration in relation to upper right front tooth since 2 to 3 months. Patient revealed history of trauma 10 years back, and patient history revealed no pain and swelling. And the provisional diagnosis was made of necrotic in relation to 1-1, and the local examination revealed discolored tooth in relation to 1-1. And the electric pulp testing showed no response in relation to 1-1. And the radiographic examination showed an open apex with a periapical lesion in relation to 1-1. The following photograph shows the preoperative intraoral photograph and preoperative IOPA. And so the final diagnosis was made of chronic periapical abscess with an open apex in relation to 1-1. And the treatment plan was made of root canal therapy with single-step MTA apexification. On the first appointment, excess cavity was prepared and working length was established, and the canals were debrided and irrigated using 3% sodium hypochlorite and 2% chlorhexidine gluconate mouthwash. And after the cleaning and shaping procedure, intracanal dressing of triple antibiotic paste containing metronidazole, ciprofloxacin, and doxycycline was given for 21 days. And after that, excess cavity was sealed with an intermediate restorative material. Then after that, patient reported after 21 days during the second appointment, the canals were properly cleaned and dried with the help of paper points. The hand plugger was inserted into the canal to confirm the plugger size such that it can be used up to the working length to condense MTA. And after that, MTA was placed into the canal with the help of MTA carrier, and it was condensed using the hand plugger, and a 4 to 5 mm apical plug was made. And after that, patient was recalled next day. On the following day, the canal was thoroughly dried with absorbent points, followed by obturation with gutta percha, by cold lateral condensation, and by using a zinc oxide eugenol sealer. And the final restoration was given with the help of composites. Then after that, patient reported for follow-up after 6 months. And the second photograph shows the 6-month follow-up IOP. It shows the complete healing of the periapical lesion with no signs and symptoms. Starting with the discussion, for a developing tooth, trauma can cause pulpal necrosis, thereby resulting in an open apex. Now this necrotic pulps provides a good nutritional supply for pathogenic bacteria, which must be present for the development of a periapical lesion. Now, apexification is defined as a method of inducing a calcified apical barrier or continued apical development of an incompletely formed root in teeth with necrotic pulp. Now there are various treatment modalities which are available to which serve as an option, such as calcium hydroxide, multiple step apexification, and we can also do revascularization. It can be done with calcium hydroxide or triple antibiotic paste, or we can use PRF as a matrix and MTA as an apical barrier. Now, MTA is a biactive cement with a capacity to induce the formation of new cementum and periodontal ligament, which makes the material biologically acceptable for closing a root canal with an open apex. The mechanism of action of MTA lies in releasing calcium ions that activate cell attachment.
DB10.
Hard tissue formation by MTA, which yes sir. Scaffolding is provided for hard tissue formation by MTA, which modules cytokine production, encourages differentiation and migration of hard tissue producing cells, and hydroxyapatite is formed on the surface of the mineral trioxide aggregate, thus providing a biological seal. Although calcium hydroxide was used most commonly for the process of epexification, the long duration in range of 12 to 24 months is a disadvantage. Moreover, the barrier formed by epexification using calcium hydroxide has an incomplete structure, which is called tunnel defects, which can allow apical microleakage leading to reinfection. And the extended use of calcium hydroxide in immature roots reduces their fracture resistance. The pulp revascularization is dependent on the availability of the residual pulp and apical and periodontal.
Thank you, Doctor, for the presentation. You have been muted by the system as you have crossed the 6 minutes. Judges, please note that was DB10. DB10 can now unmute yourself. Audience, you can start voting. Judges can now ask the questions. Sir?
Doctor, why you preferred an MTA epexification instead of pulp revascularization?
Actually, sir, before starting the procedure, patient was explained regarding both the treatment protocols. But as we all know that in revascularization, we need multiple appointments for the patients to come. So patient was not ready to come for the multiple appointments.
It's only the patient convenience you have done.
Yes, sir.
Okay. If you are going to attempt pulp revascularization, will you try again a triple antibiotic paste as a antimicrobial agent there?
Yes, sir. I will. If I am trying revascularization, then I will definitely try a triple antibiotic paste.
Are you sure? Will it not be toxic to your cells of your apical papilla?
No, sir.
How long you are going to place it?
Sorry, sir.
How many days you will place a triple antibiotic paste?
Sir, I will be placing it for 21 days.
Hello?
Yes, sir. I will be placing it for 21 days.
Okay. But you go out and see the literature, but triple antibiotic paste is not so effective, or it is more cytotoxic to the cells of your apical papilla.
Yes, sir.
In those cases, if you are going to attempt revascularization, it is always safer to use a calcium hydroxide instead of triple antibiotic paste. That is the latest treatment
Yes,
regimen they are advising it. Okay?
Yes, sir. Yes, sir.
Yeah, doctor, what are the disadvantages of MTA?
Sir, first of all, MTA takes the setting time of MTA is 3 to 4 hours. Then and then it is very hard to apply MTA. That application of MTA is very hard. We need a special instrument such as MTA carrier to fill the MTA up to the apex.
You used it, doctor?
Yes, sir.
What is the name of the instrument?
Sir, MTA carrier.
Machine gun, right?
Yes, sir.
Okay. What about tooth discoloration? How you manage it post-endodontically?
Sir, I had given a full ceramic crown after the treatment procedure was over.
Okay, if in this case you had a periapical lesion, right?
Yes, sir.
Periapical
Yes, sir.
pathology is there.
Yes,
then
sir.
what will be the scope of periapical papilla? That's okay. Thank you.
Yes, sir. Thank you, sir.
Thank you, sir. Any other judges? Thank you, doctors, for the wonderful session. Now over to Joby, sir.
Now, just wanted to, dear all, just wanted to tell you, tell all those people present here about the sponsors we have for the program. The main sponsor is EVM Autocraft, BMW people. Then we got Yogi Enterprises and the Conscious Edition people as our sponsors. And another reason why I've come up now is to just show you the amazing talents of our dentists. Look at the work of our dentists. Judges had a tough time selecting 20 out of 250 or so artworks. Excellent artworks by our dentists. Just have a look, guys. Look at the work. Look at the effort they have taken. We have picked 20, and then from this top 5 will be picked by celebrity judges tomorrow. So just be here, be there in the conference full time. You will be seeing the results of this, and there is dentists got talent, dances, music, all sorts of stuff, guitar, everything is coming up. You'll be seeing all that soon. So stay tuned, be here, and enjoy the conference Dentistry Beyond 2020. With that, over to you, Joe. We can start the session.
Thank you, sir. Moving on, we have DB11. DB11 can unmute yourself, start your video also. DB11 can now start your screen share.
Good evening, one and all. I am going to present a case report on topic management of flabby ridge using modified window technique and liquid supported denture. Introduction. Flabby ridges possess difficulty and may intensify complaints of pain or looseness of complete denture resting on them. They are hyperplastic growth of soft tissue that replaces alveolar bone. They are easily distorted while impression making. The denture fabricated on such foundations are often compromised and its retention and stability. An ideal denture base should be flexible and at the same time has to be rigid. Flexible because it has to incessantly attach to the mucosa, and rigid to support the denture during function. These properties cannot be combined in one material but are conceivable by using combination of materials. A variety of tissue conditioning material have been put forth and soft liner is one of them. But over some stretch of time, it loses its plasticity properties. So a liquid supported denture due to its flexible tissue surface can be an alternate treatment modality for flabby ridges. This case report depicts the use of modified window impression technique to fabricate a liquid supported denture to eliminate the disadvantage encountered due to rigid denture based materials, thereby providing proper retention, stability, and support to the denture. The case report: a 54-year-old male patient reported to the Department of Prosthodontics for replacement of missing teeth. The patient had a history of wearing maxillary and mandibular complete denture since past 5 years. His chief complaint was the poor fit of the denture and discomfort during chewing. In the given figure, you can see the flabby area is marked. Clinical procedures which has been done: the primary impression were made with alginate so that there is minimal distortion. A custom tray is made with 2 posterior handles and a vacuum sheet of 1.5 mm adapted over it. The window was removed and 3 holes of similar dimension were placed on the polyethylene sheet in the window area. Border molding was done with the conventional technique, following which a maxillary impression was made using a medium body polyvinyl siloxane impression material. The impression material in the area of flabby ridge was light body polyvinyl siloxane impression material was injected starting from one of the side holes till the material start coming out from the other end. Final impression was then completed. Jaw relation was recorded and phaseboard transfer was done, followed by trying. Laboratory procedures: a 1.5 mm thin flexible sheet was adapted over the master cast using vacuum heat pressed machine. This sheet was kept 2 mm short of the sulcus and PPS area during final curing. Patient was asked to use the denture for 2 weeks till he got adjusted to the new denture. Patient was recalled after 2 weeks to convert the denture into liquid supported denture. A putty impression of the tissue surface of the maxillary denture was obtained and was poured with dental stone. Temporarily, polyethylene 1.5 mm thick spacious sheet was removed by the 1 mm thick sheet were placed in the crevice formed. The cyanoacrylate adhesive and self-cure acrylic resin were used to seal the border and prevent escape of liquid. The space created due to the replacement of a 1.5 mm thick sheet with a 1 mm thick sheet was filled with a viscous liquid. That the liquid I used was a glycerine. Insertion of the maxillary liquid supported denture. Discussion. The success of complete denture prosthesis is certainly a reflection of the impression technique instituted. Recording tissues at rest is repeatedly found in the literature and has gained acceptance by many clinicians. A window tray technique has been used to achieve the concept of microstatic impression technique where flabby tissue is located. Inability to control and uniform application of impression material was the possible limitation of conventional window technique. The principle of this design was that a liquid supported denture is flexible and continuously adapts itself to the mucosa of flavi. The concept of liquid supported denture was that when there was no force applied to the denture, it acts as a soft liner, and when the masticatory load is applied due to the hydrodynamics of the liquid, the stress gets equalized over the denture during function. Tissue overloading is minimized due to optimum stress distribution of masticatory forces on maximum denture coverage area. The prime benefit of the liquid supported denture includes prevention of soreness and increased comfort level. Conclusion. Flabby ridge causes problem in denture retention, stability and support. So it acts as a challenge to a prosthodontist during impression making. Liquid supported denture and modified window impression technique has proven the patient comfort and acceptance. These are the references. Thank you.
Thank you, Doctor. Judges, please note that was DB11. Judges can now ask questions. Audience can start voting.
So this is one of the method where you try to manage the flabby ridge. What are the other alternatives that can be used otherwise?
So we can give flexible denture to the patient.
Flexible denture.
Yes, sir.
Do you have any supporting articles regarding flexible denture?
Sir, in Hindawi article in 2012, it has been given due to use of flexible denture, the pressure applied to the flabby area is minimized.
Okay. What are the other alternatives of treatment protocol I'm asking? Apart from the material aspect, how do you manage flabby ridge?
Sir, the main problem occurs during impression making. So we start with the impression only. If the impression we take...
No. I'm asking about the protocols or guidelines, how to manage flabby ridge. Surgical protocols, non-surgical
protocols. If there are hyperplastic tissues are there, then through surgery we remove the tissue. But when excess of the material is there, when after removing also it is not helpful, then we go for the conventional technique of flabby ridge liquid supported denture.
What about the role of tissue conditioners?
Tissue conditioner protects the flabby area from soreness and other problem, discomfort during function. But in tissue conditioner with long-term duration, it loses its plasticity. So it is inconvenient for the patient to every time come and get this soft liner done, because it is a temporary process, not the permanent one.
I'm not getting the question. Anyway, thank you.
Thank you, sir.
Other judges would like to ask questions. Moving on, we have DB12. DB12, you can unmute yourself and start your screen share.
Yes, sir. Shall I start, sir?
Please go into the full screen mode, Doctor. Yes, you can start now.
Good evening, everyone. I am DB12. My topic for presentation is microgravity dentistry. As we all know, that the scope of dentistry is very vast. Dentists are not just concerned with the people working on land. They are also concerned about the people working underwater. We call it as underwater dentistry. Dentists are also concerned about the pilots and the other crew members of the flight, and so we call it as aviation dentistry. But what about the astronauts in the space? For them, we call it as space dentistry or aeronautical dentistry or microgravity dentistry. Now, what you must be thinking, why I'm using the word microgravity? Because there is nothing called as zero gravity in space. Microgravity means there is little gravity between the celestial bodies present in the space. Microgravity can have a significant impact on the physiological and the psychological well-being of astronauts, including oral health. Dental emergencies are real medical emergencies during short and long-term space mission and must be handled carefully. Humans have little surviving in space for short periods in time. It is still unknown whether long-term exposure to microgravity may be detrimental to human health or not. Now, you cannot blame gravity for falling in love, and you must be thinking why long-term exposure to Mars is important. Just because many countries from all over the world are planning to send their people to other planets like Mars. And now here, it takes from Earth to Mars, it takes around 6 to 8 months. Now, what affects the oral cavity in space? It is the microgravity, barometric pressure, and the radiation. Let's see how it affects the oral cavity. Barotrauma. It refers to the acute inflammation of the sinus and the middle ear cavities, while barosinusitis is an inflammation of the paranasal air sinuses. Effect on the tooth. Due to changes in the external environment, barometric pressure changes. This causes dental pain called as barotontalgia. Effect on the periodontium. Increase in virulence of pathogens and lower immunity leads to higher prevalence of periodontal disease among astronauts. During microgravity phase, bone tends to lose mineral and become porous due to reduced stress on them. This results into weak bones and more prone to fracture. Level of osteocalcin increases in saliva, serum, and GCF during microgravity, and this leads to bone resorption. Effect on microflora. Humans suffer immune suppression with prolonged space flight. Bacteria become less susceptible to antimicrobial agents in microgravity. The development of biofilm increases the resistance of bacteria to antibiotics, thereby enhancing the chances of survival in hostile environment and becoming more infectious and dangerous to human health. Effect on saliva and salivary proteins. The amount of saliva decreases in the astronaut because the activity of submandibular muscle also decreases. This leads to xerostomia, which increases the risk of periodontal diseases. In addition, there is an increase in salivary stone formation risk during the space flight. In few studies, salivary IgG levels and Streptococcus mutant activities were found significantly higher, and serum and salivary vitamin C and E concentration were decreased. Odontocresis. Fractures caused by a high altitude environment is called odontocresis or barometric tooth explosion. This describes physical disruption of teeth with leaking restoration due to barometric pressure changes. Effect on restoration. Dental pain while flying may be caused in a restored tooth by the expansion of air entrapped while restorative procedure, and that pressure is exerted on the pulp while the dentinal tubules. Effect on prosthesis. Decrease in barometric pressure can impair the retention of complete denture. To favor the retention of prosthesis, an implant-supported prosthesis can be chosen. A study was also conducted to evaluate the same. Carcinogenic potential varies from person to person depending upon multiple factors, such as heredity, self-immune response, gender, and presence of hazardous habits. Cosmic radiations have the capacity to induce malignant changes, thus resulting in precancerous changes in the oral mucosa. High-speed atomic particles cause tearing of DNA of cells, resulting in cellular damage, which undergoes mutation, resulting in carcinogenic changes. Now, from where all this data has been obtained? It has been obtained from the records of dental problems that were faced during previous space flights, information on the medical condition that occurred during short and long-term Earth expeditions, general population studies, pre- and post-flight records, and JBR studies of Martian soil bed rest and pilot surveys. Now, once the applicants are accepted, all the astronauts have to undergo a thorough oral exam annually. Based on their oral health, they are divided into 3 types. Class 1, which have a good oral health and they're not expected to require dental treatment or re-evaluation within 12 months. Class 2, they have some oral condition and if left untreated would not expect to result in dental emergency. Class 3, they have an oral condition and if left untreated is expected to result in dental emergency within a 12-month period. In addition to annual screening, astronauts undergo pre-flight examination 18 to 21 months before the launch. All necessary treatment is then to be completed 90 days prior to the launch. Now, all these studies the past dental emergencies that have occurred in space, like incapacitating dental pain was suffered by a Russian cosmonaut, and few other dental emergencies like a crown displacement was also described. Now, how can all these emergencies be described? Every mission has two crew medical officers who are trained to perform both medical and dental emergency procedures. They are authorized to treat with antibiotics, analgesics, place temporary fillings of crowns, treat exposed pulp, and as a last resort, extract the teeth. Any emergency treatment would include communication with the ground support flight physician, as CMOs are not necessarily physicians or dentists themselves. Besides this, a dental emergency kit is also provided, which would be lightweight, non-toxic, and meets relevant packaging criteria.
Thank you, Doctor, for the wonderful presentation. You have been muted upon finishing of the 6 minutes. Audience can now start voting for the presentation. Judges can start asking the questions. DB12, please unmute yourself. DB12, you can unmute yourself now.
Yes, sir.
Judges.
Doctor, you missed the conclusion, right? There's no time.
Yes.
Can you just tell that?
So it's just that any single dental emergency can also result in a very big problem, and it can result in the astronauts to come back to the space, Earth. So it can jeopardize many $1 million.
Okay.
So a dental emergency is very important.
Okay, you told like in future people are tend to go and shift there to other planets, right?
Sir, actually many countries are planning to send their people on Mars for research work and for finding of life. Now, India is sending 3 astronauts next year in 2021 December. So this oral screening has been done by the Russian Space Organization and not
No,
in
I
India.
meant to tell. See, I think I come across someone from Tamil Nadu. He got selected as an astro. I didn't remember the term. As a doctor for future astronauts, he'll be traveling with the team. Okay, he's a doctor. Yeah, he'll be a physician for the astronauts. Like that, anything happening in dentistry, astro dentistry, something like that, space dentistry.
Sorry, I could not get you, sir.
No, actually, physicians are getting selected.
Yes, sir.
Okay, there are training started in US. They'll be traveling with the astronaut to learn about. To treat astronauts there.
Yes,
It's not nothing like getting treated here and going there. Okay, I know one guy from here near E Road, I guess. Okay, he got selected and he's under training in NASA. Anything like that happening in dentistry?
Sir, actually, it was before in US only. In NASA, they were dentists. But after that, they said that every astronaut has to get their screening on their own from their dentist personally.
Okay. So, okay, fine.
Yes, sir.
Any more questions, judges? Thank you, sir. Moving on, we have DB13. DB13, you can unmute yourself and start your screen share.
Sir, is it visible?
It is visible, Doctor. You can go into the full screen mode. Yes, you can start now, Doctor.
Yes. Good evening, respected judges. I am going to present a case report on regenerative endodontics, a true paradigm shift. According to American Association of Endodontists, apexification is defined as a method to induce calcific barrier in root having an open apex. There are 3 major components involved in apexification regarding tissue engineering. They are cells that are capable of hard tissue formation like differentiated odontoblast, scaffolds that can support cell growth and differentiation, molecules that provide signaling and intracanal dentin formation. What is apexogenesis? A vital pulp therapy procedure performed to encourage continued physiological development and formation of the root end. What are the various goals of apexogenesis? It should allow continued development of root length. It should allow remaining odontoblast to lay down dentin. It should promote root enclosure, creating natural apical constriction. It should generate dentinal bridge and should maintain the vitality of the pulp. What are the mechanism of action in case of calcium hydroxide apexification? Hydroxyl ions are released which diffuse through the dentinal tubules and produce high pH environment around the cytoplasmic membrane of the bacteria, acting as bactericidal. According to Cook and Robodom et al., hurtling epithelial root sheet under certain favorable conditions organize the apical mesoderm tissue into root components. In case of MTA apexogenesis, dentinal bridge formation occurs at a faster rate, and it has an improved ability to maintain pulp tissue integrity. Various cells like multipotent dental pulp stem cells, they differentiate into odontoblast and deposit tertiary dentin. Various cells like cells of dental sac, mesenchymal cells, connective tissue cells, pluripotent cells participate in apexification, whereas dental papilla cells, dental pulp cells, apical papilla progenitor cells participate in apexogenesis. Coming over to the case report, an 8-year-old female patient reported with swelling in the lower left back tooth region since 20 days. Patient gave history of pain, which was sudden in onset, intermittent, sharp and shooting, aggravated on chewing, and subsided on taking medication. On hard tissue examination, presence of deep dental caries with associated grade 1 mobility and tender percussion was revealed with respect to 3-6, whereas deep dental caries with respect to 4-6 was seen. There was no response to electric or thermal testing with respect to 3-6. On soft tissue examination, tender, non-reducible, non-fluctuant hard swelling with no associated bleeding or pus discharge was noted with respect to 3-6. On medical history, patient gave history of medications like antibiotics and analgesics since 20 days. So a provisional diagnosis of chronic periapical abscess with respect to 3-6 and deep dental caries with respect to 4-6 was formed. After taking radiographic investigations, final diagnosis of antibioma with deep dental caries with respect to 3-6 and deep dental caries with respect to 4-6 was formed. This is the radiographic investigation, that is OPG, showing deep dental caries with periapical radiolucency involving mesial and distal root with respect to 3-6 and deep dental caries with respect to 4-6, both the teeth being immature young permanent molar. These are the pictures of patient before and after treatment. Coming over to the treatment plan. MTA metapex apexification was carried out with respect to 3-6. Here we can appreciate the periapical radiographic success after 3 months, 6 months, 1 year. In the periapical radiograph after 1 year, we can see apical root formation and bone deposition, indicating healing of lesion. MTA apexogenesis was carried out with respect to 4-6, where caries excavation followed by MTA direct pulp capping and composite restoration was carried out. Here we can see after 1 year in the periapical radiograph, MTA apexogenesis success can be noted with complete root formation. Coming over to the discussion. According to Guven et al., placement of MTA on exposed pulp tissue stimulates growth factors which organize odontoblasts to lay down preparatory dentin. According to Murray et al., clinical and radiographic success of 95% has been seen with MTA. Whereas, according to Chenshi, MTA has been found to be superior to calcium hydroxide in direct pulp capping. The success rate of calcium hydroxide in permanent teeth was found to be 91% after 2 years, whereas in MTA it was found to be 95%. So I conclude, nature has an incredible capacity for regeneration and growth, which can be experienced if we stay focused. Hence, complete root development is possible with regenerative endodontic procedure, and there is a paradigm shift in the endodontic management of immature permanent teeth. Thank you.
Thank you, Doctor. Judges, please note that was TB13. Audience can now start polling. Judges, you may ask the questions. Sir.
Yes, Doctor?
Yes. Good evening.
In one of your slides, especially where your provisional diagnosis and differential diagnosis was there,
yes.
You have given a differential diagnosis of lymphadenitis.
Yes.
How is it possible? Like when you have a pathology in the periapex, how do you consider it to be lymphadenitis?
Because the lymph nodes were palpable and they were.
Yeah, tell me.
The lymph nodes were palpable and initially, and it was tender. Patient had presented with palpable lymph nodes, and there might be an infection involving lymph nodes. So we had to rule out whether there was infection involving lymph node or it was related to the teeth or carious teeth. And after taking medical
Okay,
history,
okay,
we came to a
okay.
conclusion that
Yeah, I got a point. The thing is, like, when you have a provisional diagnosis, which is there in the periapex, then differential diagnosis should be the alternative of provisional diagnosis, not somewhere else. Okay, when you have something in the periapex, given a diagnosis, provisional diagnosis of cyst or abscess or any pathology in the periapex, differential diagnosis should be alternative to the provisional diagnosis, which is there in the periapex. So it should not be somewhere else. Then it becomes a different lesion. Okay, and lymphadenitis is part of any infection or any inflammation. Okay, whenever you have any pathology anywhere in the oral cavity, definitely lymphadenitis will be there. So it doesn't make a separate differential diagnosis for any oral lesion. Okay, thank you.
Thank you, sir. Any more judges? Yes.
Doctor, is your patient 8-year-old?
yes, doctor. Now patient has turned 9-year-old.
No, but the OPG, I think you have an erupted lower premolars and everything, no? Am I right?
Yes, sir.
With a good amount of root development, still she's 8 years old.
So she has turned 9-year-old now. When she came to me, she was 8 years. She came in the previous year. I started the treatment, and a few weeks back only, I have taken this final radiograph after 1 year. She came to me in October last, 2019.
Your case has been followed for 1 year, no? Am I right?
Yes, doctor.
Okay. Why you didn't give any post-endodontic restoration? For example, a stainless steel crown, especially in an apexification tooth and your MTA where you attempted a regenerative procedure. Why you didn't go for a stainless steel crown?
Actually, the treatment before the simultaneously, I got a platform to give my presentation. Actually, the patient is still on follow-up, and I have given an appointment for the post and endodontic procedure. And this November only, I have finished with the case presentation, and I have made the presentation. And actually, she's on follow-up right now.
No, I'm not asking why you didn't give a stainless steel crown for at least 1 year. 1 year, the patient was being there, no? Usually the stainless steel crown, whenever you do any apexification or any regenerative procedures, is something which we give it immediately after some time. Any specific reason I'm asking?
Yeah. Doctor, in my method, I was planning to go for root canal treatment once the root root formation is complete. So I wanted to give an interim restoration or a restoration where I can proceed with the obturation later on with gutta percha. I wanted to complete the root canal treatment also in this patient.
So, doctor, according to you, stainless steel crown is permanent restoration, right?
Stainless steel crown is a permanent restoration, and I wanted to give an interim restoration. And yes, sir.
You're a pediodontist?
No, sir, I am a pediodontist.
Okay, pediodontist. You're a PG or you're completed?
No, sir, I'm doing PG. I'm in final year right now.
Okay. What is semi-permanent restoration?
Sir, intermediate restorations.
Interim restoration, right? Semi-permanent means.
Yes.
Then the stainless steel crown comes under permanent or semi-permanent?
It's a permanent restoration.
Okay, thank you.
Okay.
Actually, it comes under semi-permanent. Okay.
Okay.
Thank you, sir. Moving on.
Thank you, sir. Thank you, ma'am.
We have DB14. DB14, You can unmute yourself and start your screen share.
Sure. Sir, am I audible, sir?
You're audible, doctor. You can start now.
Finding a solution is the way to go. A very good evening to one and all. Here I'm presenting the paper titled Knowledge, Attitude and Practice about Teledentistry among General Population in Kerala during COVID-19 outbreak, a cross-sectional online survey. COVID-19 or coronavirus is a novel disease of a global concern that creates a public health crisis. It broke out in early 2020s in Kerala, and World Health Organization categorized it as a pandemic on March 11, 2020. Teledentistry is a domain of telemedicine that combines the information technology and dentistry. It is defined as the use of electronic information and telecommunication technologies to support long-distance clinical oral healthcare, patient and professional health-related education, public health, and health administration. During the COVID-19 outbreak, people have received a large volume of information that could lead to confusion, and teledentistry can play a very important role during this public health crisis to maintain the oral health of the public. Thus, my study aims to evaluate the knowledge, attitude, and practice about teledentistry among general population in Kerala during COVID-19 outbreak. The materials and methods, it is a cross-sectional study conducted among the general population of Kerala. Initially, we conducted a pilot study on 30 subjects and we calculated the sample size as 400. A self-designed questionnaire written in both regional language as well as English, which consists of demographic data and 22 questions relating to knowledge, attitude, and practice about teledentistry among general population were included. This was the questionnaire that was used in the survey. 410 participants completed the survey questionnaire, and we could see that majority of the participants were females and age ranged from 25 to 50 years. When we summarize the frequency and percentage of the responses, we can see that 99.8% of the Kerala population is aware of COVID-19 or coronavirus, and 91.4% thinks that this virus can spread through dental treatment. 73.6% believes that they are afraid of taking dental treatment during this COVID-19 outbreak, and 62.6% is aware of teledentistry. Among them, 87.8% have utilized this tele or video consultation in their daily life, and 62.6% has find any difficulty in communicating with the dentist by using teledentistry. 50.4% is ready to prefer this teledentistry even after the COVID-19 outbreak. 90.5% is willing to take the dental treatment only in emergency situations, and 67.5% is taking pre-appointment by using teledentistry. 53.5% is willing to take dental treatment only after the COVID vaccines and ready are marketed to use, and 73.3% thinks that this can increase the accessibility of the dentist to village and underdeveloped areas. 75.3% believes that it reduces the cost, and they are ready to prefer, 65% are ready to prefer in future. There were multiple choice questions which was included in the survey, of which one were the measures that was implemented by the Kerala population in the daily life against COVID-19. And we could see that 95% practice wearing mask and gloves, 83% practice frequent hand washing, and 71.1% practice no handshaking, and 81.3% maintained social distancing. When we talk about the mode by which this virus spreads, 97.3% believes it can spread through coughing and sneezing, whereas 70.8% believes it can spread through saliva, 25.2% through food, 18.5% believes through feces and urine, 58.4% believes it through air, 59.6% through objects, and 28.4% through blood transfusion. When we inquire what is teledentistry, 76.6% believes that is contacting the dentist and taking advices through telephone, internet, etc. When the various methods for communicating was assessed, 71.3% believes that all the methods, all the options, that is live video conferences, recorded health information videos, through communication devices like cell phones, tablets, computers, everything are various methods in teledentistry. About the charges of fee, we could see that 24.7% experienced a charge lower than the normal, whereas 9.2% experienced a charge higher than the normal. 32.2% experienced participants come across dental problems during this outbreak, and 12.6% used teledentistry. 11% were having ongoing dental treatment like root canal therapies, fixed orthodontic therapy, and 8.5% used teledentistry. So we can see that in the present study, majority of the general population in Kerala is aware of COVID-19 and coronavirus, and more than half of the general population is aware of teledentistry and has taken tele or video consultation with a dentist before. But we could see that majority of the population find difficulty in using this teledentistry, and similar results were seen in the study conducted by Bohr et al. Half of the respondents agreed to use this teledentistry after COVID-19 pandemic, and majority of them believe that it can increase the accessibility of the dentist to village and underdeveloped areas. So concluding that every problem has a solution, every lock has a key. Teledentistry can help the public to maintain the oral health during the COVID pandemic period. These are my references. So rise above the storm and you will see the sunshine. Thank you.
Thank you, Doctor. Judges, please note that was DB14. Judges can now ask questions and the audience can vote. Sir?
So what are the methods or treatment modalities that teledentistry can impart to the patients, apart from prescriptions? Apart from e-prescriptions, what are the treatments you think that can be imparted to the patient or delivered to the patient to relieve the pain?
We can reviews can be done through teledentistry about a patient. Along with that, emergency emergency dental care of like pain, swelling, means there is mobile phone teledentistry where we can the photographs of there are studies says that photographs of dental dentitions have been given to the dentist and they can assess the dental carers. But mostly teledentistry is reliable in taking reviews and prescriptions.
No, I'm specifically asking any other self-medications or self-treatments can be done through teledentistry. Apart from taking medicines orally, any other thing which can be done by the patient himself or maybe the attender?
I don't know, sir. I will check, sir.
Say, for example, if the patient is experiencing so much pain even after taking antibiotics and painkillers, probably an acute pulpitis, he can use clove oil like Colgate's Pain Out or something like that. Some other brand. I'm not endorsing any particular thing. So is there any treatments which can be done by the patient himself, do you think?
Sir, saline irrigation, saline gargling, sir. Other than that.
Okay. Fine, thank you.
Thank you, sir.
Thank you, sir. Would any other judges would like to ask questions? Thank you, Doctor.
Thank you.
We have DB15. DB15 can unmute yourself now.
Hello.
DB15.
Hello.
Yes. Yes, you're audible.
Am I audible, sir?
You're audible, Doctor.
Okay, sir. Okay, sir.
Please start.
Shall I start?
Yes, you can start.
A very good evening to one and all present over here.
Doctor.
Pardon, sir?
Please open the slideshow, Doctor. Yes.
Yes, I did, sir.
Proceed, Doctor.
Shall I start, sir?
You can start,
Hello.
Doctor. You can start, Doctor.
Okay. A very good evening to one and all present over here. Myself, DB15, is present over here to present paper on the topic pulpal revascularization in young permanent teeth. Contents for my paper are as follow. Coming to introduction, revascularization was first introduced by Ostby in the year 1961 and later documented in the year 1966 by Rule and Winter. It can be defined as invagination of undifferentiated periodontal cells from the apical region in an immature teeth. It may represent as an ideal alternative treatment to traditional root canal therapies. Present concept of pulp tissue regeneration include two possible approaches. First is revascularization and second is replacement of the diseased pulp with a healthy tissue. Stem cell therapy, gene therapy, three-dimensional cell printing, scaffold implantation, pulp implantation are suggested for these approaches. Conventional root canal therapy become more complicated in case of immature teeth with open apex because there is a real risk of influx of solid and plastic material overflow into the periapical area. History. It has a very promising and innovative treatment concept. It has the potential to create a paradigm shift in the management of young immature permanent teeth. Summarization: Nagard and Ostby in the year 1961 suggested that because of the bleeding, the healing is induced. From 2000 onwards, it was considered to be as alternative to epexification. Ivaya et al. In the year 2001 suggested that it has the potential to create a paradigm shift. Rationale: it has large communication. Vascular supply in such teeth is coupled with the successful disinfection. Windley et al. Suggested that treatment basically depends on three factors: canal disinfection, scaffold placement, and bacteria tight seal. There is a triad of regeneration which include stem cell, scaffold, and the growth factor. Stem cell is involved in the possibility of differentiation, whereas scaffold provide the three-dimensional structure, and the growth factor is involved in the regulation. Example of stem cell present in the oral cavity are as follow. Scaffold should has the ideal property, which has been quoted over here. There are type of scaffold. They are basically biological and the synthetic or the artificial ones. Growth factor. They influence in cell migration, proliferation, and differentiation. They are basically protein or polypeptide in nature. Coming to clinical consideration, foremost step is the case selection. This is the foremost step in the revascularization technique. Then comes the informed consent by the parent or the guardian. Then comes the first appointment. Under first appointment, we opt for the triple antibiotic paste. Triple antibiotic paste is the mixture of ciprofloxacin, metronidazole, and minocycline. Minocycline present over here is responsible for the discoloration. Comparing the intracanal medication, Bose et al. Suggested that both the calcium hydroxide and triple antibiotic paste were equally effective in pulp dentine complex. But these results confined only when the calcium hydroxide insertion was limited to the cervical third of the root canal. Coming to second appointment. Second appointment, we opt for the over-instrumentation. A small clinical tip behind it include a small bend is made in the endodontic file and it is dipped in EDTA, which is an anticoagulant. Alternatively, we can draw the blood and inject into the canal system itself. This is the picture showing manual stimulation of blood clot. Seal the space. MTA is considered to be as gold standard in sealing the space. Then comes the follow-up. Follow-up 3, 9, 18 and 24-month follow-up is given. After 3 months, the tooth is normally asymptomatic. 9 months, we can visualize in X-ray, and at around 18 to 24, the revascularization is completed. This is the case of 16-year-old girl where the central incisor is treated with revascularization and lateral with the traditional root canal. At the end of 18 months, we can see that there is presence of mineralized barrier is present, and nevertheless, no root lending, neither apexogenesis was evident. This is the case of pulpal necrosis in the premolar, which has undergone chronic and having the chronic abscess. The GP marker tracks the periapical tissue of an immature teeth. The blood clot induction was done. MTA was placed over the blood clot, and at the 18 month, we can see the root maturation indicated by increased width of root dentine and the apical closure. Chen et al. Suggested 5 types of treatment outcome which demonstrate the success of the treatment. Number 1, increased dentine wall. Number 2, continued root development with apical closure. Root end development without apical closure. Calcification and mineralized tissue barrier presence. Consideration: young adult patient and patient with avulsed teeth has greater likelihood towards the revascularization procedure. Revascularization assumes that the canal is disinfected and trapped cells are capable of new tissue formation. Histology: Anderson and Buckland on 1200 traumatized teeth and 370 auto-transplanted premolar suggested 4 types of healing outcome, which has been described over here. Then there is lack of histological data on human teeth. However, the animal study shows the promising result. Some of the study has been quoted over here. Coming to merit of revascularization, it is very simple and easy to carry. It eliminates the chance of fracture, reinforcement of lateral dentine wall, avoid the possibility of immune rejection. There are 2 case reports by Anna Graciela et al. And Arvind Rai and Usha Ghiraya. Both the case report supports the merit of the revascularization. Coming to limitation: long-term clinical result, revitalized tooth may be susceptible to further pulpal disease. Post and core are the ultimate option. It should not be done. It has allergic reaction to intracanal medicaments, potential risk of necrosis, and minimum case report published till date. Coming to my conclusion, it presents a new era in biological and clinical endodontics. It is recognized as first treatment choice for immature teeth with pulp necrosis. It represents recent and promising treatment modality that has been in evidence due to preservation of biological principles and possibility of minimizing the treatment period of immature teeth. These are my references, and I'm very thankful to all of you for listening to me.
Thank you, Doctor. Judges, please note that was DB15. Audience can now start voting. Judges, you may ask your questions now. Sir. Sir.
Yeah, is there any question?
Yeah, you can hear me?
Yes, sir.
Yes, we can, sir.
Yes, sir.
Yes, okay. So the ideal concept, what you told is LSTR, right, doctor?
Pardon, sir?
What the concept what you shared is LSTR, right? Revascularization.
Yes, sir.
So where it arises, what is LSTR? You know that?
Please pardon, sir. Your voice is not clear.
LSTR. Lesion
Please pardon.
sterilization and tissue regeneration. That is the concept, right?
So please pardon. Hello.
No, doctor, your ideal concept is lesion sterilization and tissue regeneration. That is LSTR, right?
Yes, sir. Yes, sir. Yes, sir.
Okay. So it's a new concept, right?
Yes, sir.
Okay, can you just tell me when it started?
Sir, it was documented by
When is the first publication?
Ostby.
No,
sir.
not by you, doctor. Generally, I mean, you mean to tell it's a new concept, right?
So it was documented first by Ostby in 1961 and documented by Rule and Winter in 1966.
Okay, and what antibiotic they used in 1960s?
Triple antibiotics, sir. Antibiotics.
That's what antibiotic was there inside that? In the three antibiotic,
so minocycline, minocycline, ciprofloxacin, and minocycline, ciprofloxacin, metronidazole.
Okay, then why they stopped it? I don't think so.
Sir,
Ciprofloxacin was introduced in 1960. Okay, then why it was not used widely?
So because it is a strong and periapical effect of these antibiotics is not very promising. Nowadays, we are mainly concentrating on calcium hydroxide. Only we have to take care of its insertion. It should be inserted at the cervical third of the root canal.
So
the study was done by the Bayer et al., which has been quoted in the.
Okay, so calcium hydroxide is better than minocycline. You mean to tell that?
No, sir. Triple antibiotic combination. Calcium hydroxide is better than the triple antibiotic combination.
Okay, no, actually that's not the right thing. Okay, antimicrobial property, triple antibiotic base is better. But as Dr. Jeevarathan sir told before, it reacts with the cytokines. Okay, action there.
Yes, sir.
Okay, so in that way, the revascularization effect is, compromised. Okay, then one more thing is, you just told the follow-up, right? 3, 9, 12, 24. Okay.
Yes, sir. Please
okay, you were doing pulp testing in that time just to check the revitality?
Sir, actually, we were after 6 months. Sir, at 3 months, the tooth is normally asymptomatic. The symptom has been not there. At 9 months, we can visualize in X-rays.
No,
we can
symptomatic,
take the
I'm not
X-ray
telling. No, revascularization is a non-vital teeth. You're making it to vital, right?
Yes, sir.
So you're doing any vitality test to check whether the teeth is vital or not?
Sir, at the initial appointment, we are just checking the radiograph where the root end closure is happening or not. Initially, the root end is parallel. Gradually, it is become conical and it is getting closed, right?
Okay. So vitality is not tested. Okay, doctor. Thank you.
Thank you, sir.
Thank you, sir.
Later, sir, we will check the vitality once the apical closure is done. We can check in the radiograph and later we can check, sir.
Thank you, doctor. Moving on, we have DB16. DB16, you can unmute yourself and start your screen share.
Hello.
Yes, DB16, you can start your screen share.
Thank you so much, sir. Thank you, sir. Thank you so much, sir. Thank you so much, sir. Yes, sir.
You can start, doctor. Go into full screen mode first, doctor. Yes. Open the full screen mode, doctor.
Can you hear me, sir?
Yes, we can hear you. You can start now, doctor.
Good afternoon, all. Today, my topic is on a study on the comparison of the efficacy of K-file, canal brush technique, and sonic irrigation technique in the retrievability of metapex from the root canals and in vitro con-beam computer tomography analysis. As an introduction, we can say that the bacteria can be considered as a main etiology for the pulpal and periapical pathosis, and these bacteria are eliminated by the chemomechanical preparation, but the bacteria can exist even after this chemomechanical preparation within the root canal because of the anatomic complexities. So an intracanal medicaments are recommended in between the appointments to prevent the proliferation of residual strains as well as the recontamination. And the calcium hydroxide is considered to be the gold standard and a widely accepted intracanal medicament because of its antimicrobial activity. But before we go for the obturation, we have to completely remove these intracanal medicaments from the root canal. So according to the Semra and Serpa et al., they reported that when calcium hydroxide was incompletely removed from the root canal, the sealer did not penetrate into the dentinal tubules, as well as it can affect the adhesion of root canal sealer into the dentin and cause increase of apical leakage. And also it can potentially interact with the zinc oxide eugenol sealers and make them brittle and granular. So with this as a basis, the aim of the study is to achieve complete removal of metapex using various irrigant activation techniques such as K-file, canal brush technique, and sonic irrigation technique from the root canals of extracted human teeth. The materials used were the extracted 36 human mandibular premolar teeth, a protaper system, and 17% ethylene diamine tetracetic acid, 5.25% sodium hypochlorite, and K-file, canal brush, sonic MM1500 handpiece attached to the Shaper sonic files, metapex paste, on-demand 3D software, and CBCT imaging system. And sample size, a total of 36 human extracted mandibular premolars with mature apices were selected. And as when comes to methodology, crowns of the teeth were removed 14 mm from the apex in order to standardize their length, and the canals were confirmed for apical patency with size 10 K file. Then root canal width near the apex was controlled with the size 15 K file. Then chemomechanical preparation was done using protaper files up to the F3 instrument as a master apical file in a crown down manner, and the metapex was injected into the root canal until the material extruded through the apex. Then the access cavity was temporarily sealed with the cotton pellet and intermediate restoration. Then it is stored in 37 degrees Celsius at 100% relative humidity for 7 days. Then the teeth were mounted on a modeling wax for the purpose of CBCT, and the CBCT was taken, and the volume of the filled material in each tooth were estimated in coronal section using on-demand 3D software. These are the pictures showing the volume analysis using on-demand 3D software. Then after that, we have gone for the subgrouping of the samples according to the irrigant activation techniques used. First subgroup, the K file is used to activate the irrigant within the canal, and in second subgroup, the canal brush is used to activate the irrigant in order to remove the calcium hydroxide. And for third group, sonic MM1500 handpiece attached to the Shaper sonic file is used as the irrigant activation technique. And in the fourth group, it is a control group. Only 1 ml of sodium hypochlorite was used without any activation. And after removing this metapex from the root canal using different irrigant activation techniques, a second CBCT was done, and the volume of the remaining material was estimated or using on-demand 3D software. Then the volume was expressed in cubic mm. Then the removal efficacy was calculated using a formula A minus B into 100 by A, where A was the volume of material packed in the root canal and B was the volume remaining after the retrieval. These are all the CBCT images showing the volume of calcium hydroxide inside the root canal before irrigation as well as the post irrigation. And the statistical analysis within the group and between the test group, the data was analyzed by using T-test and F-test followed by post and valid Lucan test. The results at the cervical third and at the apical third, maximum removal efficacy was shown by sonic MM1500 handpiece for the activation of irrigant, followed by K-file and canal brush, which showed equal efficiency between them. At the middle third, there is no statistically significant difference was found among any of the irrigant activation techniques used, and the least efficacy was shown by the control group. When it comes to the discussion, using conventional irrigation technique, the efficacy of calcium hydroxide removal from the canal system mainly depends on the irrigant penetration into the apical area, and it could be limited by the narrow dimensions and as well as the size of of the needle used. The effectiveness of irrigation mainly depends on the streaming action of the irrigant, not on the irrigant volume. So current endodontic techniques fall short of the goal to remove the calcium hydroxide intracanal medicament completely from the root canal system. To overcome this, different irrigant activation techniques were introduced. And the results of the present study demonstrated that none of the irrigant activation techniques tested above are able to completely remove the metapex from the root canal. And this is in accordance with the findings of Weissman et al., M. Mukherjee et al., Kumar et al., and Altureiki et al. And when the test groups, Sonic MM1500 handpiece performed better than K-file, canal brush, and control group, followed by the Sonic MM1500 canal brush as well as the K-file shows almost equal efficiency in the removal of metapex from the cervical, middle, as well as the apical region. And this is in accordance with the findings of Gary Petter. The better efficacy by the Sonic MM1500 may be by because of the production of vigorous intracanal fluid agitation through acoustic streaming and cavitations. As a conclusion, we can say that none of the irrigant activation technique used were completely able to remove the metapex from the root canal, and the activation of irrigant using Sonic MM1500 performed better than K-file, canal brush, and the control group in removal of oil-based calcium hydroxide. And there is no significant difference in the efficacy of canal brush and K-file in the removal of oil-based calcium hydroxide. And these are all my references. Thank you.
Thank you, Doctor. Judges, please note that was DB16. Judges can now ask questions. Audience can start voting. Sir. Sir. Any questions, sir?
I don't think I have any question. No. Anybody else?
Is the irrigant temperature has to do anything with the efficiency of the removal by warming it up or by changing the temperatures?
Warming it up can actually the warming of sodium hypochlorite can increase its efficiency of removing the debris or as well as on the removal of pulpal vitality, pulpal vital pulp from the root canal. But
so why it has not been included in this particular study? Temperature changes.
Actually, we are doing with the different activation methods are tested here. Actually, not with the irrigant types of irrigant. Actually.
Okay. Got it. Thank you.
Thank you, sir. Moving on, we have DB17. DB17, you can unmute yourself and start your screen share.
Thank you, sir. Okay. Should I start, sir?
Yes, after making it into full screen, you can start, Doctor.
Okay.
Yes, you may start now.
Good evening to one and all present. My topic for today is imaging modalities in implant dentistry. These are the contents we are going to discuss today. Imaging in implant dentistry is divided into 3 phases. Phase 1, also called as pre-surgical implant imaging, commences before implant placement, determines the quantity, quality, and angulation of bones, the relationship of critical structures to the prospective implant sites. Phase 2, also called as surgical and intraoperative implant imaging, assists in surgical and prosthetic intervention of the patient, evaluates the surgical site during and immediately after surgery, evaluates the healing and integration phase of implant surgery. Phase 3, also called as post-prosthetic implant imaging, remains till implant remains in the jaw, evaluates long-term maintenance of implant rigid fixation, evaluates the implant complex. Imaging modalities are usually divided into 2 categories, 2D imaging and 3D imaging, which is further divided into subcategories. The first we are looking into is periapical radiography. They are the images of a limited region of the mandibular or maxillary alveolus. Periapical radiographs are produced by placing the film intraorally. Advantages are they are easily available, greater resolution, cost effective, less distortion, low dose. Limitations are limited area imaging, facial-lingual dimension not recorded, limited reproducibility, image distortion. Occlusal radiography, Planar radiographs produced by placing the film intraorally to the occlusal plane with the central X-ray perpendicular to the film for the mandibular image and oblique for maxillary image. Advantages are they are easily available, high image definition, relatively large imaging area, low cost, low dose. Limitations are image superimposition, not much information on buccolingual dimension, less use in maxilla, limited reproducibility. Cephalometric radiography, oriented planar radiographs of the skull. The skull is oriented with respect to the X-ray device and the image receptor using a cephalometer, which physically fixes the position of the skull with projections into the external auditory canal, demonstrates the geometry of the alveolus in the anterior region and the relationship of lingual plate to the patient's skeletal anatomy. Not useful for demonstrating bone quality. Other disadvantages include image magnification and superimposition. Panoramic radiography, curved plane tomographic radiographic technique used to depict the body of the mandible, maxilla, and lower one half of the maxillary sinus, all in a single image. This radiographic technique produces an image of a section of the jaw of variable thickness and magnification. They are easily available, minimal cost, large imaging area, low dose. While the limitations are buccolingual dimensions not provided, image distortion present, technique errors are common, inconsistent horizontal magnification. In 3D imaging, the first is conventional tomography. The basic principle is X-ray tube and film are connected by a rigid bar called the fulcrum bar, which pivots on a pivot point called the fulcrum. Advantages are minimal image overlap, low to moderate dose, buccolingual information, simulates implant placement with use of software, moderate cost, accurate measurements. Limitations include technique sensitive, limited availability, less image resolution than plain films, requires trained personnel. Cone beam computed tomography or CBCT, patients who are edentulous or who are being considered for multiple implant placement may be best imaged by these techniques. The jaws are aligned so that the acquired axial computed tomographic image slices are parallel to the occlusal plane. Better image resolution, lower dose, lower cost than CT, simulates implant placement, easy availability, compact equipment, image with better resolution, minimal distortion and magnification, makes interpretation more reliable. Limitations are does not represent the actual grayscale value, bone density cannot be evaluated because of the X-ray scattering, longer scanning time. Computed tomography or CT is a digital and mathematical imaging technique that creates tomographic sections where the tomographic layer is not contaminated by blurred structures from adjacent anatomy. Advantages are no superimposition, uniform magnification, accurate measurements, simulates implant placement with use of software, makes interpretation more reliable, technique sensitive,
Joby, you can mute.
limited availability, special training required, high cost, high dose. Magnetic resonance imaging, MRI. They are a 3D imaging technique with an electronic image acquisition process and a resulting digital image. Advantages are quantitatively accurate technique with exact sections and no distortion. Limitations are not usual in characterizing bone mineralization or as high-yield technique for identifying bone or dental disease. Interactive computed tomography, ICT, addresses many of the limitations of CT. ICT was developed to bridge the gap in information transfer between the radiologist and the clinician. Advantages are determination of bone quality adjacent to the prospective implant sites, the number and size of implants accurately along with the density of bone at the proposed implant sites. The refinement and exact relative orientation of the implant position is difficult and cumbersome, which is the limitation of ICT. These are my references. Thank you so much.
Thank you, Doctor. Judges, please note that was DB17. Judges can now ask questions and the audience can also start voting. Sir.
That's a good presentation.
Thank you, sir.
And any recent advancements in dental CBCT or CBCT in general? Any advancements happened?
There are many softwares which are new advancements in the softwares for implant planning prior to implant placement. There are also softwares which can plan the implant pre-implant placement and post-implant placement, and we can compare the discrepancy between the planning and post. Those are the new software which are the new.
Yeah, those are actually softwares. I'm not bothered about that. I'm bothered about hardware developments. Any other thing you know?
No, no idea, sir.
Have you heard about portable CBCT, handheld CBCT?
No.
Way back
no
in
idea.
2009, an article is published, and a lot of
Okay, sir.
companies have developed actually. It's in the pipeline.
Okay.
Years to come, definitely it is going to be there in the market. So we
Okay,
have
sir.
portable CBCTs where you can carry the CBCT to your designed dental chair and you can make the scan out of it. So that
Okay,
is in
sir.
the pipeline. Like chair-side CAD/CAM scanners, you have these gadgets, and in the near future, definitely it is going to flood the market.
Okay,
Thank
sir.
you.
I didn't know about it. Okay.
Thank you, judges. Moving on, we have DB18. DB18, you can unmute yourself and start your screen share.
Sir, is it visible, sir?
It is visible. It is not yet started. Yes.
So can I start, sir?
Yes, you can start, doctor. Good luck.
If you can't handle stress, you won't manage success. Good evening. I'm here to present a paper on the topic Assessment of Stress and Anxiety among General Dentists and Pediatric Dentists after COVID-19 outbreak. An outbreak of novel coronavirus disease in China and its spread globally had a profound influence on human life and lifestyle. And on 11th March 2020, the World Health Organization declared it as a controllable pandemic disease. In India, the first confirmed case of COVID-19 was reported on January 30, 2020. Health workers, including dentists all around the world, are under stress after this pandemic outbreak. The increasing number of confirmed cases and deaths, work burden, inadequate personal protective equipment, and media coverage of and vulnerability to infection, having to stay in quarantine, as well as feelings of being inadequately supported in workplace, can contribute to the mental burden of health workers. The pediatric dentists who are exposed to children's crying, jerking, anger, and a variety of other avoidance behaviors were also exposed to the added stress and anxiety due to this pandemic. Furthermore, little is known about the anxiety and stress of pediatric dentists related to the impact of this pandemic. The aim of my study is to assess the stress and anxiety among pediatric dentists and general dentists after COVID-19 pandemic outbreak. Materials and methods include a cross-sectional and anonymous online population-based survey was conducted among general dentists and pediatric dentists from different states of India. A pilot study was done on 30 subjects. To check the study validity, and the sample size calculator was around 360. A semi-structured questionnaire in English was designed for the Google survey tool by a research expert for the study, and the final questionnaire consists of 5 demographic data questions and 23 questions. These are the questions included in my study. From the total responses came 465 respondents were included in the final analysis, of which 71.6% were females and 28.4% are male. The majority were general dentists, accounting to 52.5%, and within the age group 20 to 30 years, and which accounts to 72.7%, and having private clinical setup, accounting to 38.3%. On analyzing the result, 59.8% of the general dentists and 57% of the pediatric dentists says that COVID-19 has not affected their sleeping hours. When it comes to implementation of the new treatment and infection protocols in the clinic after COVID-19 outbreak, 48.4% of the pediatric dentists are able to cope up with it, but 47.1% of the general dentists have opted for almost as their opinion. 81.4% of the pediatric dentists and 82.8% of the general dentists are of opinion that there is change in behavior of the children when they see doctors and assistants in full PPE kit. And also majority of both groups find it difficulty to carry out dental procedures in full PPE kit. 82.8% of the pediatric dentists and 77% of the general dentists face challenges in treating children with lengthy appointments after COVID-19 outbreak. On these questions, We can appreciate that huge majority of both groups doesn't have any alternate source of income and are planning to find another source to stabilize their income after this pandemic outbreak. And 87.8% of the pediatric dentists and 82.8% of the general dentists are afraid of getting infected with COVID-19 from patients, assistants, and co-workers. Majority of both groups believe that the patient will not reveal the full travel and past medical history during this pandemic time. And we can also find that majority of the dentists are confident of treating patients previously infected with COVID-19 disease. Here, 85.1% of the pediatric dentists and 82.4% of the general dentists are anxious about treating patients who cough and sneeze during this pandemic, and huge majority of both groups fear that they will carry the infection from dental clinic back to the family and are also anxious about the cost of the treatment if they get infected. We can also appreciate that majority are not able to manage the expenditure of the clinic from the patient income and thus wants to close the dental clinic. Still, the cases starts declining. From here, we can appreciate that 68.8% of the pediatric dentistry population says that there is significant reduction in the average number of patients per day after the COVID-19 outbreak, and similar results were obtained with the general dentist also. 68.8% of the pediatric population says that they find stress in making patients understand about the new treatment protocol, and likewise 59.4% of the general dentists came up with the same opinion. Majority of the pediatric dentists and general dentists have opted for engaging with family and friends to cope up with the stress during this pandemic time, followed by physical exercise and music. 50.7% of the pediatric dentists and 50.8% of the general dentists were worried about the impact of this pandemic on the social and emotional development of the children and its implication in the dental behavior. Discussion: the social or physical distancing and other COVID-19 restrictions have caused significant disruption globally, and this burden cannot be underestimated as it could potentially influence on all other spheres of life. According to the study, majority of the pediatric dentists and general dentists are undergoing stress and anxiety after COVID-19 outbreak, and the increase in death rates among health workers, television, newspaper update, unavailability of a COVID-specific drug and vaccine has upshot their anxiety level, and there is significant reduction in the patient inflow after COVID-19 outbreak, and majority of both groups are worried about their professional future. Oral healthcare involves use of aerosol producing devices as well as working in close proximity with the oral mucosa and their secretions. The risk of cross-infection could be high between the dental practitioners and the COVID-19 patients, according to David Orr in 2020. So it is essential that in the present scenario, priority is given to the dental procedures labeled as emergencies by the WHO, and that all dental treatments are deferred until a time when the outbreak goes into recession. And this would be appropriate step in attempts to curtail the further spread of COVID-19 outbreak. These are my references. Thank you, sir.
Thank you, Doctor. Judges, please note that was DB 18. Audience can now start voting. Judges, you may ask your questions now. Sir. Judges, any questions?
No, sir.
Jeevarathan, sir.
Yeah. So what is your overall outcome related to the stress among the pediatric? Whom you feel it is more? Any specific reason?
So on analyzing both the groups, both the dentists and pediatrics have equal amount of anxiety.
Okay. You mean to say even the pediatric dentists who master among the patients with dental anxiety had more anxiety with COVID, related to COVID?
Yes, sir.
Okay.
Any other questions, judges? Thank you, sir. Moving on, we have DB 19. DB 19, you can unmute yourself and start your screen share.
Is my screen visible, sir?
Yes, it is, Doctor.
And I hope I'm audible enough.
You are, Doctor. You can start now. Go into the full screen mode first.
Yes, sir.
You can start now.
DB9.
Are you there, Doctor? DB19.
Element analysis. Of my study input to analyze the stress at implant bone interface between mesiodistally and buccolingually placed implants to evaluate
DB19 seems to be having an internet issue. We can move on to DB20. We'll come back to DB19 later. DB20, you can unmute yourself and start your screen share.
Am I audible?
Yes, doctor, you are audible.
Are the slides coming up, sir?
Yes, you can start now, doctor. All the best.
Healing is a matter of time, but it's also a matter of opportunity. Good evening, one and all. Today, we are here to present a case report titled Management of Complicated Crown Root Fractures Using Piezo Surgery, Fiber Post, and Fragment Reattachment.
So coming to the introduction part, restoring endodontically treated teeth with a complicated crown or crown root fracture is a challenge. Very sorry, there is some problem with our slides. So coming to the introduction part, restoring endodontically treated teeth with a complicated crown or crown root fracture is a major challenge for a dental practitioner because it requires a comprehensive and accurate diagnosis and treatment planning. The traditional treatment of a complicated crown root fracture include a definitive crown following a crown lengthening procedure, surgical and orthodontic extrusion of the teeth, extraction of the teeth followed by fixed partial denture and an implant, and post and core supported restoration. So, but if the fragment can be retrieved at the time of injury, a reattachment procedure can be done. So the purpose of our presentation is to report ultra-conservative technique of reattachment of tooth fragment using piezo surgery and post and core technique.
So coming to the case report, a 42-year-old male patient came to the department with a complicated crown root fracture of the maxillary central incisors with a history of trauma. The patient's medical history was non-contributory. There was no apparent damage to the soft tissues on intraoral and extraoral examination. On hard tissue examination, a complicated crown root fracture extending from the cervical third on the labial aspect to 2 mm subgingivally on the palatal aspect was seen. An intraoral periapical radiograph was taken, which showed complete root formation with no signs of intrusion or extrusion. The patient expressed his desire to restore the tooth as such because the cost involved was much less compared to an entire cast restoration. So we did an interdisciplinary treatment plan involving periodontal crown lengthening using piezo surgery, endodontic root canal treatment, and fragment reattachment using fiber post was chosen.
So the treatment was divided in 5 phases. Phase 1 is a surgical extraction of the fragment. After administration of local anesthesia, the segment were removed with minimal force and it was stored in normal saline to prevent the dehydration and discoloration of the teeth.
Phase 2, conventional non-surgical endodontic treatment. The root canal treatment was completed using prototype rotary files up to size F5, and observation was done using single count technique as procedure. Then we took a periapical radiograph to confirm the lateral and the apical seal.
Phase 3, crown lengthening using piezo surgery. A comprehensive periodontal examination was done where the crown height and the probing depth was calculated with respect to 1-1 and 2-1. And we came to a conclusion that there was difficulty in maintaining the biological width. So there was a need of a crown lengthening procedure where we used a piezo tome and along with that a piezo surgical tip of CE1 and CE2. The procedure was like, after application of local anesthesia, internal bevel incision of 2 mm was placed on the buccal aspect and 3 mm was placed on the palatal aspect. After that, a marginal credicular incision was done to expose the full thickness pediosteal plug. And following an osseous reduction of 2 mm was performed at the palatal aspect using piezo surgical tips in a sweeping strokes with saline flow.
Phase 4, post-space preparation and fragment reattachment. The post-space preparation was done in the root canal using piezo reamers. Then we tried in the fiber post into the prepared root canal and adjusted it to the desired length. The post waste was also prepared in the coronal portion of the pulp chamber of the fractured fragment to receive the coronal portion of the fiber post. This is the image showing the fiber post aligned with the fractured fragment. Then the entire assembly's alignment was verified. That is, the fiber post, the fractured fragment, and the root remnant was aligned to check they were properly adapted. So once we have made sure that there's proper alignment, we acid etched the root canal, then we rinsed it and blotted dry, then bonding agent was applied. Then the fiber post was luted within the root canal using Reliance resin cement. The similar procedure was done on the fractured fragment also. It was also acid etched, rinsed, blotted dry, and bonding agent was applied, and it was bonded to the root remnants using Reliance resin cement.
So the phase 5 is a post-attachment bevel. A 1 mm deep circumferential chamfer was placed on the fracture line using a number 2 diamond bar, and after that the restoration of the chamfer line was done using a nano hybrid composite cement, and finishing and polishing was done. After that, sutures were placed with the help of a 3-0 black braided silk, and following fiber splinting was done to stabilize the tooth.
Coming to the discussion, a complex round root fracture is the fracture involving inamid, dentin, cementum, and pulp. It accounts for about 5 to 8% of all traumatic injuries to the anterior tooth, as reported by Anderson et al. In 1981, Lewis et al. In 1986, and Martin et al. In 1990. So, compared to the traditional technique, the fragment reattachment procedure is more conservative, it is affordable, and less time-consuming. The added advantages include restoration of the original contact, contour, color, and incisor translucency. So DeMarco et al. Confirmed that no material technique was able to achieve the fracture resistance of the sound natural tooth. Now, why we use fiber reinforced composite resin post was that its elastic modulus is similar to that of dentin, that facilitates a more even distribution of the occlusive forces, resulting in less chances of root fracture. And also, the FRC post needs less dentin removal, and it uses the irregularities that will increase the surface area for bonding.
So in our case, a DLK or resin cement, Reliance U200 was used because it was having a good bond strength and complete curing, and it reduced the micro leakage with very good aesthetic and color stability. And in our case, a circumferential chamfer technique was used, which was already quoted by Carey et al. In the year of 2017 that it is having, and a crown lengthening procedure was carried out, that is a piezosurgery, which reduces the bone, but it preserves the root integrity, and also it is a less invasive procedure with a minimal collateral tissue damage, resulting in both healing.
Thank you, doctors. You are automatically muted by the system as you have exceeded the 6 minutes. Judges, please note that was DB20. Judges can now ask questions. Audience can cast your votes. You can unmute yourself, DB20.
Hello, doctor. A nice case presentation. Or am I audible?
Please unmute yourself, DB20. You will have a pop-up right now asking you to unmute.
Jivardhan sir, you are audible. You can go ahead, sir.
So your case is a crown root fracture. Am I right?
Yes.
So what are the different modalities of treatment we have as for a crown root fracture?
Coming to a crown root fracture, like we can do a certain traditional technique like a crown lengthening followed by a crown placement, or a surgical or orthodontic extrusion of the teeth, or extraction of the teeth followed by fixed partial denture or an implant procedure, or even a post and co supported restoration.
Okay. So we will leave out that removal, extraction of tooth. You have one option called where you extract and surgically extracted and rotation of a tooth, where you derotate it and place it off to expose the fracture line in a supragingivally and do it off. You have that option also, no? 180-degree rotation.
Yes.
Hello?
Yes,
Is it audible?
Yes, sir.
Surgically extracting it and rotating the tooth and re-implanting it 180-degree.
Okay, sir.
Okay, fine. So you have so many options. Either you can orthodontically extrude it, or you surgically extrude it, or something like that. Why you chose this methodology instead of all those things?
Most importantly, the patient had financial crisis because of COVID. So he wanted a procedure that was less expensive compared to the indirect cast restoration. So to scientifically back this up, there are review of literature shows that there are several studies like those done by Rajesh Gopal and all who use fracture realignment procedure that showed that even after 1 year, the prognosis was still good, that the tooth fragment was still in place, and there were better signs of periodontal healing, and there was no signs of periodontal pathology or anything associated with the reattachment procedure.
So besides that, the advantage includes a more conservative procedure and is more affordable for a patient like this, and is less time consuming. We can complete the entire procedure in almost two appointments.
Okay. See how long the case was followed up now?
Yeah, I followed up only 3 months, sir.
Okay, just 3 months.
Yes, sir, 3 months.
No, just I thought it would have been. What about the periodontal status at this point of time?
So, like a comprehensive periodontal examination was done where the probing depth as well as the crown length was actually calculated. And like after doing a piezo surgery and after like we did a periodontal examination, and especially on the buccal aspect, the biological width of 2 mm was maintained. But palatal aspect with respect to 1-1, there was a little bit of deficiency with respect to the biological width. But with respect to 2-1, there was adequate biological width maintenance, and there was proper healing also.
There was no pocket on your palatal aspect?
There was pocket. Yeah, that was what I said. With respect to 1-1 and 2-1, 1-1 was having a little bit of pocket still, being high, but with respect to 2-1, it showed a very good healing, uneven through healing experience.
Fine. Okay, thank you.
Thank you, sir. Up next, we have DB19. DB19, you can unmute yourself and start your screen share. You can go to the full screen mode, doctor.
Yes, sir. Am I audible, sir?
You are audible, doctor. You can start.
Okay, sir. Good evening to one and all present here. Myself, DB19, and I'll be presenting on the topic mesiodistally or buccolingually angulated implants, a clinician's dilemma. The aim of my study was to analyze the stress distribution in and around 2 mesiodistally and buccolingually placed titanium implants supporting a 3-unit screw-retained fixed prosthesis by finite element analysis. My objectives included to analyze the stress at implant bone interface between mesiodistally and buccolingually placed implants, to evaluate the effects of external loading under various directions on the stress distribution in the dental implant and surrounding bone, and to evaluate and compare the stress on prosthesis These are the material models that were created. It was created in SolidWorks and the mesh were generated in which there were nodes and elements that was created in each of the segments and the entire assembly. These figures that are displayed shows the mandible, the section of the bone with the prosthesis and the implant in place, the implant and the fixed dental prosthesis, which are mesh generated. Now, coming on to this figure, the bottom two figures are model 1 and model 2. The model 1 is the mesiodistally placed implant, and model 2 is the buccolingually placed implant. The figures above show the points where the maximum stress is being generated on the prosthesis and the application of different loads. So what we did here was we applied vertical, oblique, and horizontal load at the same time on the fixed dental prosthesis with the implant, the entire assembly. Moving further forward, these were the mechanical properties of the different materials that were used in the model. The Young's modulus and the Poisson's ratio values of all the materials are displayed. Now, coming on to the forces that were applied. We applied 50 Newton force at an angulation of 0 degree in the horizontal direction, a force of 200 Newton at an angulation of 90 degree in the vertical direction, and 400 Newton force at an angulation of 120 degree to the occlusal plane in the oblique direction on the assembly. And these are the results that were generated using the ANSYS software. The first figure is the mesiodistally angulated implant in the model, the 3D model. And in the second figure, it is clearly seen the color coding that is shown on the left side represents the blue color showing the minimum this was 70 megapascal in the connector region, majorly concentrated in the connector region in case of mesiodistally placed implants. Coming on to the cancellous bone and the cortical bone, The values were 8 megapascal and 30 megapascal respectively. And this is the figure of the abutment and the implant. And the maximum stress was 100 megapascal. It is very clearly visible with the color coding that is seen. Now moving on to the buccolingually placed implants. Again, in the fixed dental processes, we had maximum stress concentration in the connective region that was 140 megapascal, as seen by the red color that is clearly visible in the figure. In the cortical bone and the cancellous bone, we had the maximum stress concentration as 15 megapascal and 8 megapascal respectively. Moving further forward, we had the implant and the abutment, in which we had, in the abutment, we had a stress concentration of 200 megapascal, which is again demarcated with the red color that is seen. And with all these analysis, this is the tabulation of the result that we had obtained. And it is clearly visible from this result that model 1 is the mesiodistally angulated implant and model 2 is the buccolingually angulated implant, and the fixed dental processes, the abutment, the implant, and the cortical bone in case of, not the cortical bone, it showed more stress concentration in cases of fixed dental processes, abutment and implant in mesiodistally angulated implant as comparison to buccolingually angulated implants. The cancellous bone showed more or less the same values, but the cortical bone, in the cortical bone, the mesiodistally angulated implant showed more stress concentration as compared to the buccolingually angulated implants. So from all this, we reached to a conclusion that in clinical situation, we encounter many cases in which we are forced to choose, we are unable to place parallel implants, and we are forced to choose either a mesiodistally angulated implant or a buccolingually angulated implant. This puts a clinician into a big dilemma as to which one to choose, because as we know, stress is the most important factor that plays in such situations. So this is why the study was conducted, and the results from my study suggest that mesiodistally angulated implants definitely improve stress transfer homogeneously along the bone implant interface by providing a greater surface area as compared to buccolingually placed implants. Thank you.
Thank you, Doctor. Judges, please note that was DB19. Judges can now ask questions. Audience can start voting. Judges, sir.
Do you have any clinical study related with this?
No, sir. As of now, no. Because, sir, it is actually the reason behind choosing analysis. Sorry, sir?
No.
So the reason behind choosing finite element analysis is because finite element, the major advantage of finite element analysis is that we can consider everything homogeneous and inside a patient's mouth, and we can apply the loads in such conditions. That is why majorly a finite element analysis is used. But in vivo conditions, we actually cannot try and test this on a patient. So in this era, being done is firstly, we are conducting such virtual studies, in vitro studies, in which we can get an idea as to which is better. And further, according to that, we are moving on further with the clinical situation with in vivo studies.
I hope you know about all-on-4 protocols, isn't it?
Sorry, sir.
All-on-4 protocols, all-on-4 protocols.
Yes, sir. Yes, sir.
So those implants are purposefully buccally as well as mesially tilted implants. So
Yes.
on what reasons they have been done so?
Sir, to dissipate the stresses in accordingly, sir. Because like it is a completely edentulous arch, and we are trying to rehabilitate the patient with with the denture is implants. Sorry, sir.
No, I'm not. No, I mean to say that in all-on-4, you are purposely tilting that implants mesially towards the engaging alveolar bone. So that is actually correlated with your study. That's why I asked you, any clinical study was done previously. So that is similar to your study only. So you just please enlighten yourself about all-on-4 protocols also. Okay.
Okay, sir.
Thank you.
Okay, sir.
Okay. Doctor, you have chosen 50, 200 and 400 for different directions, forces.
Yes,
Okay, is
sir.
there any criteria for it? Can you elaborate on it?
Not exactly, sir. Actually, we were trying to replicate the masticatory load that happens because in like if we are for edentulous condition, like completely edentulous condition, the maximum load is sir, around less than 100 Newton. But we were trying to analyze this for dentulous cases also, in which we have dynamic loading. So that is why, sir, we chose such forces. There is no.
Or is there any reference for it?
Not exactly, sir. We have not.
Just randomly you chose the
Yes,
forces.
sir.
Okay, thank you.
Sir.
Thank you, sir. Thank you, doctors, for the wonderful presentations you had done. Thank you, judges, for your time. Up next, over to Dr. Binu, sir.
Yes, Joe, Dr. Jobby, excellent presentations by the PGs. Our next speaker is already here. Speaker might be surprised to see that the topic was on implants. Dr. Arunachalam, are you there? Yes, sir is there. I'm sure you enjoyed the last presentation because the topic today is on implantology. So about the PG presentation, excellent discussion. This kind of discussion has never happened, I guess, in a conventional conference. Hats off to all the candidates, all the judges, Dr. Nirmal, Dr. Jiva, Dr. Ramesh, Dr. Deen Dayalan, sir. We really appreciate the effort behind it, the time you have spent behind it, scrutinizing all that and coming to a final list. You have done a great job. Heartfelt thanks to all the judges for your time. Moving on, we are slightly delayed with the program. Moving on is implantology. That is beyond 2020. What you should know about implantology from Dr. Arunachalam. Dr. Arunachalam, my association with Sir started way back in 2000, 2001 or so. Great personality to meet in Chennai. Smiles India Family Dentistry, a must-visit clinic if you are going to Chennai. And he did his BDS from Madras Dental College and MBS from Government Dental College Trivandrum. He did his MBA from Anna University. So this degrees just go on and on. More than 25 years into teaching. Completely involved in the Indian Society of Periodontology. Was still now the editor, I guess. He is in everything. Ex-Dean of Priyasni Dental College. Sir's credibility, Sir's dedication towards this dental fraternity goes on and on. My association started when we did together an orthodontic course. Remember, sir, what I just cannot forget when I met you first in Smiles India, your dental clinic is, see, orthodontists. Normally, orthodontist means they go with one kit to one clinic and the same instrument being used for all the 50, 100 patients with some spirit swiping or whatever. Why I'm telling this is, I don't know whether you remember, Dr. Arunachalam, you told me clearly that day, unheard of, sterilization concepts unheard of. He has proved that it is possible. You should see the amount of orthodontic kits he has that autoclaved and kept for each patient. That's the level of dedication towards practice. Truly appreciate his dedication towards practice, and then the academic stuff, another story altogether. Thank you so much, Dr. Arunachalam, for coming into our platform. We are extremely sorry about the delay that has happened. I called him up personally and said there is a delay. The immediate answer from Sir was, Dr. Binu, don't you remember the hours we sat together in multiple conference halls waiting for our session to come? Now I am in the comforts of my own home having coffee. Do not worry, Dr. Binu. We will have it whenever you want. That was the confidence he gave me. Thank you so much, Dr. Arunachalam. I'm introducing to all of you one of the finest personalities you can meet in the field of implantology. Arunachalam, sir, over to you.
Thank you, Binod. Are you all able to hear me?
Yes, you can share your slide now, sir.
Yeah, sure. Are you all able to see my screen?
Yes, you are in full play mode. Perfect. You're audible
Yeah.
and slides visible. All the best, sir. Thank you very much.
Thank you, thank you, thank you. Thank you, Binu, for such a lovely introduction and for your friendship and association over the last 2 decades. I'm really privileged to have known you and your family and having visited your practice and the way you are so dedicated towards ortho and of course continuing dental education. Tremendous effort over a period of time and currently on this online learning platform also. So I think the online dentistry is, I was pretty much surprised to see so many people, young postgraduates, so many people coming up and, making presentations and getting their opinions shared, having discussion, having, field to field questions from judges. It's really encouraging. I think even in these pandemic times, I think this is a big step forward. You also have a lineup of very eminent speakers, and I think all of this has contributed to a really successful show. Hats off to you. Congratulations to you and to Joby for organizing such a wonderful event. Excellent. So today my topic is going to be on the digital workflow in implant dentistry, and this is something that Dr. Binu said that I should share with all of you. So I'm sure that you're all familiar that digital dentistry is taking over conventional dentistry, in the sense that the amount of speed and precision and quality that you can actually deliver when you practice dentistry that is supplemented by the technology of digital science is going to make things completely revolutionized. There is a big paradigm shift in the way we've been practicing, and many of the materials, many of the errors that come in the processing have all been tremendously diminished because of the advent of digital workflow. The other important element is the learning curve. See, all of us have had a learning curve. It took me several years before, I could come forward and do, let's say, a sinus augmentation with a direct sinus lift. But today you have younger practitioners who get exposed to the newer technologies and such efficient treatment planning that with quite a limited experience, they can still perform fairly useful surgeries for the patient. So the way in which this has been transformed is tremendous. It has a big impact on your regular implant practice. And I am sure that many of you have already started adopting some form of digital workflow in your practices. And of course, with the implant practice, this digital workflow makes it a much more precise technique. Implants are all about precision, and therefore some effort or some consideration of the way in which your workflow can be bettered, I think is a step in the right direction. So this is going to be on a digital workflow as far as implant dentistry is concerned. It's a very introductory program, and just to infuse you the concept that digital workflows will be the way of the future. So first of all, let's look at how we classify the basic, our processes. We have standard conventional processes. For instance, if you look at the conventional process, what do? We make a diagnosis. If you're going to make a prosthesis, you make an impression, you do radiographs, you do plaster models, and then you make a, freehand placement of an implant with your 2D or 3D radiographs. Whereas when you go completely digital, your diagnosis is not only clinical, but you also take digital photographs, you take intraoral scanning with the help of intraoral scanners, you make radiographs, and you might occasionally do a CBCT scanning as well. So from a freehand placement, you are then able to virtually plan prior to the surgery and have a very guided and precise placement. When I was earlier in my career, one of my professors used to say that any amount of time that you spend in planning will never be wasted, which means it's better to plan ahead and execute, right? Measure twice, cut ones. So you have the opportunity to be able to completely visualize in a three-dimensional manner where the implant is going to be positioned, how far is it going to be from nearest anatomical structures, is it going to have a sound housing of bone all around it, so on and so forth. The lab fabrication process also will move from a conventional to a more digital aspect, wherein you will use newer technologies of additive build-up or subtractive manufacturing in order to create your provisional and your final restorations. So your final restorations usually have polyvinyl siloxane impressions, you have bite registrations, and then you have working casts. Whereas here you have intraoral prosthesis, digital design, and in fact, for most single units and 3 unit situations, there is hardly a cast that is poured when you do an intraoral scanning and make your final prosthesis. And of course, your delivery and thing has the lab time, so there is a time lag between your taking your impressions, pouring your model, sending it to the lab, getting it back, doing your trials, so on and so forth. Whereas today, with the newer technologies, you have the option of manufacturing many of these prostheses in your own office. So what are the things that has changed? Three things: the speed has changed, your work is much faster; quality has changed, your work is much better; and in fact, over time, you will actually see that it will be turn out to be a little more economical. At the present point, your initial capital investments in all of these is a little higher, but as time goes by, I'm sure that some of these capital burdens will come down. There will be much less sunk capital. There'll be some time involved in planning, but beyond that, your if you can outsource many of these things to supplemental units, you might be able to have a more economical, driven treatment delivery. The basic steps as far as the digital planning is concerned is fairly simple. You have to you take a digital impression or a digital scan, you take a CBCT data capture, you plan your prosthesis, you manufacture the prosthesis, and then eventually deliver the treatment. So all of these have got a stream of action. This is the cascade of the process. You have data acquisition. This acquired data from multiple sources has to be superimposed. For example, if you have cast data, the cast which has been scanned to be superimposed on a CBCT, or a denture scan to be superimposed on a CBCT, or an intraoral scan to be superimposed on a CBCT, uh, so on and so forth. Then you also have the virtual planning of your prosthesis, and then your fabrication of your provisional prosthesis, any guides in between during the surgical phase, and then eventually the final prosthesis. So what we'll do is to divide these into these individual structures and see in which way digital technology has impacted each one of these processes. So as far as data acquisition is concerned, apart from your clinical examination, it's good to take good digital photographs. Many a times our treatment planning happens a lot with good digital photographs. Once you have photographed something and you have a stationary, steady picture in your hand, you're able to see the extent and severity of problems much, much better. The second thing is the use of an intraoral scan. Today, the scanning devices have become much, much better. They have somewhat reduced in their prices. The software that goes with the scanning has become better. The speed of scanning has become far, far better. And so it's kind of getting into the realm of a regular dental practice. Of course, 2D digital radiography, we're all familiar with intraoral periapical views. Many of us also have orthopantomograms in our practices. And now you have the question of having a CBCT. So if you do a three-dimensional X-ray or a three-dimensional CBCT scan, which is a limited area or a large area scan of the head and neck region, then you are able to get a three-dimensional representation of the data, and this three-dimensional reconstruction will help you to plan your cases much, much better. So just to give you a few examples, for example, this is a central incisor that needs to get replaced. This is a left central incisor that needs to get replaced. So when you take a CBCT, you are able to see all the planes in action. For example, this is the plane which is called the coronal plane, which is from the front to back. Then you have a sagittal plane, which is your plane from left to right. And then you have a coronal plane, which is basically a plane from top to bottom. And then all of these individual planes can be superimposed or reformatted by the software to create a nice three-dimensional image or a three-dimensional object, which can then be rotated and you can see this object much better. And so you'll get a three-dimensional visualization of the bone, the teeth, any other surrounding structures. So this is a huge improvement from the way you might be working with two dimensions. Let's give you another example. Let's say you're looking at a sinus, and if you see here, you will be able to see that you can see the sinuses in all the different planes. You might be able to see nerve tracks, for instance, in here. And therefore, this type of three-dimensional imaging is very useful in your basic diagnosis, is very useful in your treatment planning, and also during your implant placement and following your implant placement for evaluation. So each one of these has got a specific clinical need, and if you identify that clinical need, you will realize the value of three-dimensional imaging. So in those situations where you are completely necessitated to see, you can see here how three-dimensionally you are able to completely locate the position of the implant into the canal in this coronal view. If you look at this view here, it might be that this, if this were in a two-dimensional radiograph, this implant could be either buccal or lingual to the entire neural canal or neural channel. Whereas here, if you see, you will be able to completely see that the implant is sitting right into the nerve canal. So this kind of representation is far perspective. We have many options, 2D options, including intraoral radiographs and pan views and cephs. While you also have in 3D options, conventional tomography and CBCT. Of course, your justification, optimization, load dose limitation, all of these will factor in when you order a CBCT. But the indications generally would be if you have any bone defects, if you want to do any sinus augmentation, you might want to see three-dimensionally how the sinus is, whether there's a mucocele, how's the thickness of the lining, whether the ostium is patent or not, how much is the volume, are there septae, fins. So much of information can be got from a three-dimensional scan. You also will be able to evaluate intraoral donor size. For example, if you're working at the ramus, or if you're looking at the chin area, or if you want to take out any from the tuberosity area, all of these can be assessed much better. There are also, if you are using any special surgical techniques, and so special surgical techniques also, it will help. For example, if you're doing bone splitting, or if you're doing indirect augmentation, even there it can be very much useful. Any computer assisted treatment planning and placement, and of course to assess any post-operative complications. So this would be the basic summary for which you will be using three-dimensional radiographs. Once you have a three-dimensional CBCT data, what do you do with it? Now, as far as implants are concerned, this data can be used to plan your implant placement. And this is usually done with the software. The software, basically what it does is it takes all the data of the multiple tomographic X-ray images are all collated, and they are systemically arranged. So once they are systematically arranged, you are able to split them in any of the three planes and also reconstruct them. And you can also have a multi-planar reconstruction. In multi-planes, you can reconstruct the image. So what are the features of such software? What do these softwares essentially do? First of all, they give you an interface to visualize the anatomy and map any vital structure. You take a panoramic radiograph, your panoramic radiograph has an area of focus. So when you take an OPG, that focal plane, if the canal focal plane, you will be able to see the nerve canal in the orthopantomogram. Now, let us say there is an anterior curvature of the inferior alveolar canal before it exits from the mental foramen. Now, if that curvature is beyond the plane of the OPG, you may not be able to see it. Whereas when you take a CVCT, the same panoramic view can be seen in multiple planes. So you choose the plane where you see the nerve canal the best. So you can actually visualize the anatomy of the various important vital structures. Also, you can also superimpose multiple data sets. For example, if you have an intraoral scan, that is one set of data. If you have a photograph or a facial scan, that is another set of data. If you have a CBCT, that is one set of data. If you have a guide or a denture that has been scanned, that is another data. So multiple data can be superimposed by identifying common landmarks, and one can be like a stacked on top of one another. And that is a very useful thing, because you can three-dimensionally visualize under which tooth in the denture is the head or neck of the implant. So this is pretty useful as well. Also, you can do what is called as segmentation. We'll look at some of these things. Segmentation is you will be able to identify and select special areas. For example, just around that section where you want to see of a standard density of bone or iso density of bone, you can segment that area, you can take that area. If you want to segment the mandible, you can separate the mandible and segment it and take it off. Segmentation essentially means you're separating that component from the entire data. Also, you have a number of measuring tools, you have positioning tools, you have a library of implants, so you can choose implants from various companies. You can have a library of teeth, which means you can choose teeth of different sizes, of different morphology. Therefore, you will be able to identify and set the teeth according to the size, according to their shapes, and you can verify all of these things. So generally all of these are the standard features of many of the software that we see. And of course, eventually you can export all of these data so that they can be used for printing or they can be used for milling, and you can create a nice report so people can find that very easy to go through. So there are a number of softwares that are available which help you to do this. Of course, in the previous slide we saw that there are proprietary software. Nobel Clinician is one, Simplant, Blue Sky Plan, 3Shape, Code Diagnosis, Romexis, and so many others are there. Some of the free software that you can find on the internet are these. Some of these can help you. Today, the ones that are most popular are Blender and, of course, Blue Sky Bio, which is, of course, you have Osirix, you have so many others. But we generally use Blender and we use Blue Sky Bio. Of course, these are open source medical software, and many of the features in this are free, except the feature when you want to export some data. So if you want to export an STL data, at that time you will have to pay. So basically how the system works is this: you get your CBCT or DICOM data. DICOM data is the standardized format in which the CBCT is being, you get the CBCT, and eventually you take the DICOM data, the raw data, and you put it in the software, and the software will analyze the data and help you to plan. So you can work out a treatment plan. Now, not only can you get the data from the CBCT of the patient, you can also get the data from their impressions or their models, and you can pull all of them into this and into the treatment plan. Once you have got the physical data into the treatment plan, once you've got the radiological data into the treatment plan, you can combine these two and create a surgical guide. And with the surgical guide, you can create not only an implant placement, but also you can create a provisional prosthesis and eventually finish your case. So let's look at how the entire sequence of operations works, just to give you a very brief idea. Now, this is the standard screen that you will see in most of your planning software, where you will begin to see serial sections here. These will usually be serial sagittal sections. This will use is usually a coronal section, and here you have a multiplanar reconstruction window. This window is usually a three-dimensional evaluation window, and this is a panoramic window. These are the 5 windows that you can have. You can change this format. You can have 3 windows, 2 windows, single window, whatever you want. So I like to work in this format because it helps you to see all the 3 planes. It gets you the three-dimensional view, and it gets you the panoramic image here as well. You'll see that in the next slide. And most of these have all of these menu driven systems in the top. So you will have a separate menu for implants, you have a separate menu for other tools, you have and then the same similarly you will have all of these menu driven also. We'll talk a little bit about that. On the right hand side, you can toggle on and off some of the menus that you need, and if you don't want some, you can toggle them off. So this also, when you're working, this helps a lot. So let's look at this here, simple situation here. Once you have imported a DICOM file, you see that your DICOM file is here. You choose the area of operation, whichever area you're looking at. Let's say you're looking at this area. So you choose, so you see here a panoramic image. Here we are working on the maxilla. So you see a panoramic image. You see here a coronal plane. This coronal plane is the mandibular coronal plane. So what you do, the first thing is you import the DICOM file and you do what is called a panoramic curve. You identify and tell the software that this is the shape of the mandible. The mandible is going to lie within these 2 planes. You can manipulate this in any which way you like depending on the shape of the mandible. The software will also automatically create its own panoramic profile. This will be a multiplanar reconstruction. This will be your sequential sagittal views, and this is your three-dimensional view view. So you can adjust the density of this to various formats and see how much you want to see. Suppose you want to see more of soft tissue, you move the density slider down and you will see more soft tissue. If you want to see more hard tissue, you move this density slider forward and you'll see only hard tissue. So there are many ways in which the entire data can be manipulated. So once you have drawn the panoramic curve and you identified this and drawn the panoramic curve of the area of interest, you can then start working on the individual areas. So you start creating what is called as a 3D model. So the particular software itself will create a three-dimensional model or a stereolithographic model, which comes in the file format .stl. So many times you will see .stl file format, so or .dcm file format. .dcm stands for a DICOM file format. STL stands for a three-dimensional file format. Once you have got that three-dimensional reconstruction done, you choose from the implant library whatever type of implant you want. So you will have, if the software you use can import, there are 600 different implants available in the market, and the STL files for all of these implants are there with many of the softwares. So you will be able to work on that as well. Then what you can do is you can try to provisionally place an implant in that area and check how it is. So you see here that here an implant has been placed in this area, and then you will be able to, once you start placing an implant in any one of these windows, for example in this MPR window or a 3D window or the PAN window, the same implant will be visualized in all of the other windows as well. So any manipulation that you do of the implant in any one of the windows, in each and every single window, that manipulation will change. So here you can adjust the settings. You can adjust what transparency you need, what is the length of the implant, what is the length of the abutment, what is the length of a guide tube. We'll come to that shortly. So all of these can be manipulated. You can see that here the implant is getting housed in a sound buccal volume of bone and a link palatal volume of bone, and positioning the implant is also can be defined very clearly. So three-dimensionally you can virtually plan. You can also plan the type of tooth you want to place. So you have a tooth library and you can choose either a small, medium, large tooth, and then you can choose whatever, you can increase and decrease the size of the tooth once you've chosen that as well. So having positioned your implant in the appropriate place, having positioned your tooth in the appropriate place, you can manipulate the tooth and you can see whether how the emergence profile of the tooth is. So this gives you what is called as a composite 3D verification. It helps you to verify where the exact position is going to be. Then what you do is you import also the model. You can import the model of that patient or model scan, and you can superimpose both the model and the CBCT. So once you have superimposed the model and the CBCT, you can then begin to fabricate a guide. Now, many of the guides have what is called as a guide sleeve. The idea of the guide sleeve is that when you pass a metallic drill through the guide is usually made of resin. You do not want the resin particles to go into the implant osteotomy. So you have a metallic guide, which is a firm guide, which will not be easily trimmed off. So as the drill passes through the guide will not change its, it will not wear off. And that's the purpose of the guide. So you have to make a provision for the guide. So even the guide provisions are there, and it tells you what is the kind of guide that you have to place. What is the length of the guide? What's the internal diameter of the guide? What is the external diameter of the guide? All of these can be fixed. So eventually you can come back and design a nice surgical guide with the guiding metal sleeve as well here. So once you have done that, this can be separated. All this is segmentation. All this is, each one of these has been separated. Once you have separated that, you can then formulate a guide something like this. So what is the advantage of a guide? Here you will see that you can precisely transfer the position of the implant as you would want it into the mouth. So once whatever you have planned, what you saw on the model, what you saw on the scan is exactly what will go into the patient's mouth. So what will happen? Your anxiety and stress during the procedure will be reduced. Your procedure extremely predictable, very consistent, and you'll be much faster than before. Your learning in this will also be much, much faster. So, and these are all your requirements to do guided surgery: your CBCT scan, intraoral scan, implant planning software, and a guided surgery kit. So let's quickly look at some scenarios where you will require different types of, and what type of scans you require for different types of scenarios. So here you have a partially edentulous scenario. In a partially edentulous scenario, you look a CBCT scan, then you can superimpose the intraoral CBCT scan and the intraoral scan, and you can create what is called a tooth and soft tissue surgical tissue supported guide. You see that the guide is supported on the teeth. It's like a splint, and then you have the guide sleeves here, and you can go directly through this type of a guide. In a completely edentulous situation, you can also make a bone supported guide. So you can segment the bone out and you have a bone supported guide. This guide is anchored to the bone with pins. You can also have a bone reduction guide. For example, if the bone level is uneven and you want to flat it out to a standard plane, you can use a guide like this and you can cut off. It's called a bone reduction guide. It helps you to cut exactly the amount of bone that you need and create a flat plane. And this would be your implant drilling guide. So you have these drill slots, and into this you have the sleeves, and then you can make a implant drilling guide as well. Your completely edentulous situation, you will have a slightly different type of scanning, which is called as a dual scan technique. There's also a triple scan technique, but the dual scan technique, what you do is you get your denture, you identify at least 6 landmarks. So you put 6 points, gatapacha points, glass beads, whatever you want on the denture, and take a CBCT with the denture in the patient's mouth. Once you have taken the CBCT with the denture in the patient's mouth, you also take a CBCT or a scan of the denture. And then you identify these two things. So identify this point as this point, this point as this point, so on and so forth. You identify all the individual points so that you can correctly superimpose this denture on the CBCT. Once you have superimposed this on the CBCT, you know that this is where the teeth has to come. So under that, exactly whichever tooth you need, you can have your implants designed. Similarly, you also have a triple scan technique where you can scan not only the CBCT but also the denture and also the cast. So you get a much better idea of the soft tissue, in which case you will be able to place a flapless implant procedure. So without opening the flap, you will be able to precisely position the implant as well. So as far as the manipulation of this DICOM data is concerned, there are several features that you have to basically know. Of course, all this takes a little bit of learning, but one of the key things that there is the biggest advantage is what is called a segmentation, where you can choose an area of similar density and the computer will automatically choose areas of similar density. So if the bone in the mandible is something you want to choose, you can choose it. This is either automatic or it is semi-automatic, where software helps you a little and you can choose additional points, or it can be completely manual. So when you have completely manually selected and segmented it, you can separate the mandible out and then you can work just on the mandible alone. So this way what happens is you are able to separate the area working. Suppose you're an endodontist, you can separate out the tooth, one particular tooth where you're working. You can see the nerve canals in the tooth, you can see the branches of the nerves, you can see the lengths, you can measure the thing, you can know where the access points you have to drill. So all of these are possible because of you're being able to segment that particular component away from the rest of the data. So that's a very useful element. So then what you do is you do what's called as a crown down implant planning. You start with the crown, you begin with the end in mind always. So you decide, okay, this is where the crown is going to be, so this is where my implant is going to be, and this is where it looks on the CBCT, and that's how you start your process. And of course, all of these individual positions and views of the implants can be seen. The emergence of the crown out of the implant can be visualized. We just had a presentation by by a doctor who was talking about the angle and the way in which the angled abutment is used and the direction of forces and the stress analysis. Pretty interesting study. So all of these can be visualized in your treatment planning itself. So, and then you can position the implant, you can set rules. For example, you can say that I want my implant end to be at least 2 millimeters away from any vital structure, like the inferior alveolar canal. So this software will not allow you to progress beyond 2 millimeters, closer than 2 millimeters to any important anatomical structure. Or you say, I need 1.5 millimeters of buccal bone, or I need this to be 3 millimeters beyond the crest of the ridge. Whatever rules you give, the implant will be following those rules, depend what you set them, and therefore you will be able to position them safely in all 3 dimensions. So this is what you see here, how the implant shoulder is pursued, where the emergence profile is going to be, how much of interocclusal space you have, how much of restorative space you need. All of this can be very well programmed, making your workflow far easier. You can, with once this has been done, you can also design a provisional simultaneously, so that the time you place an implant, say you put multiple implants like this, you can simultaneously print a prosthesis and have the prosthesis in place even before you anesthetize the patient. You have a prosthesis in place. So once the implant are placed, the prosthesis has to fit like a glove over the implant abutments. So many different types of surgical guides exist. Simply put, they are either bone supported, tissue supported, or tooth supported, and depending on the kind of situation. So if it's tooth supported, that means you're looking at a partial edentulous space. If it's tissue or bone supported, you're looking mostly at a longer extended edentulous space or a completely edentulous space. So a surgical guide will have all of these components. It's like you'll have the frame itself, which sits on the tissue or on the teeth, whatever the case may be. You will have the sleeves, and then you will have the pins, and of course, pin tubes. So this is the intaglio of the guide, which sits against the tissue. You have guide tube holes, you have guiding cylinders, and of course the fixation pin tubes as well. Okay. So we also design the offset for the implant. For example, your handpiece has a certain height. Your handpiece will go and hit the guide at a certain point. So for all of these things can be measured for the handpiece. So your whatever is the make of handpiece you use, that also can be programmed. There is a library for that. You can program that in the software. I can verify these offsets by how much difference in height you'll have to be. So all of these can actually technically be programmed. You also have guided kits, guided implant kits, and then of course you have your regular kits as well. If you are using regular kits, we use keys like this. In this, you see there is a single guide that's been placed, single surgical guide, but the single surgical guide has a wide diameter sleeve. But if you want to use a 2.8 millimeter drill, for instance, you want to make a 2.8 millimeter drill, but the drill hole is much bigger, in which case we use a small spoon or a key like this. So the key is a 2.8 key which fits into the slot, and once it fits into the slot, the drill can go right through the key, and then your direction and axis and everything else will be cleared. Okay. So this is these are some of the things. The other way is you use completely guided kits. If you look at this guided kit here, you see that the shank length diameter is the same for all the kits. So there is a shank, the shank diameter is the same. Therefore, the shank is going to stop it here. So you have individual depth specific drills. That means for every depth you have a drill. So you have a 6 mm drill, 8 mm drill, 10 mm drill, 11 mm, 11.5, 13 drills, so on and so forth. So you can assess the drill length, you can have the sleeve length, and you see here how the drill will go and fit exactly into this spot. So here you will have the stop, which will go and stop at the sleeve, and then your drill will be completely up to depth. Okay, so there's a stopping section and a guiding section. So all I'm trying to say is it'll be an extremely precise mechanism in which you'll drill. So having said that, this is how you plan using your software. What are the ways in which you can manufacture a guide? So guide manufacture is by many ways. You can either do an additive manufacturing or you can mill. Most people usually do a resin printed guide. Basically what you're doing is you're doing these 3 steps. You're basically doing the 3D file. You're then creating and printing a guide. You're choosing a material and you're making the final guide or the final prosthesis. So what are the ways in which you can do that? The ways in which normally we do it is we do resin and wax printing. So the commonest now what we are using are usually multi-jet, and then we use a digital light projection or a continuous light interface projection guide. So which is polymerizing a liquid resin in a vat. So the vat, there is a tray, and we'll show you something like that. So it looks something like this. This is how this whole structure will, the wax printing will work. So you can see here. Yeah, I really hope the video plays. Okay. So basically what we're doing here is we have a vat of curable resin, and this vat of curable resin is allowed to raise layer by layer by layer. So there'll be a UV light at the bottom which will polymerize the layer. And like any other resin, the top layer will be oxygen filled and it won't polymerize. So the next layer will get added on top of it, so on and so forth till the final layer. And depending upon the quality of your printer, each and every layer thickness verification, polymerization will be verified depending on the quality of your printer. And then you can have the entire structure completely printed. Digital light processing is another mechanism to print. Here basically you use a safe light, not a UV light. And then of course you have individual similar layer being printed and the entire thing pulled out. So in short, there are multiple mechanisms by which you can print, but some of these are for simple casual printing. The resins that we use normally in for guide printing, we use stereolithography, DLP, or clip, or what's called as continuous liquid interface production, or multi-jet printers. Of course, your DMLS crowns that you make, that is for printing metal. And then you have selective laser sintering that is also used, where powdered metal is then sintered or melted with a laser, and that's printed. There's so many ways of additive manufacturing, but normally for the guides we normally use a multi-jet printer. Okay, so let's look at how a sample digital workflow will be. Once you've got the data in, you take the data into a planning software, processes planning software. So what we have done thus far is we've looked at the CBCT, we have looked at the guide fabrication software, or the software that helps you manipulate this data. We also looked at the way in which the guides are materials in which the guides are fabricated. For the final processes, this is how the fabrication is done. You use a software which helps you to plan the process. In this case here, this is Exocad. And then once the model is being scanned, the model comes up and gets nested in your field. And in this field, eventually you can either scan a single crown separately like this, or you can scan the entire model as well. A simple die also can be scanned. You see that the die is getting scanned here, and then you get a nice 3D reconstruction here. So once you got a nice 3D reconstruction here, you can check the occlusion. If you have a bite or a scanned bite, that's fine. You can also identify points, and automatically there, if you register the bite, the software will automatically register the bite as well. So once the bite is registered, you have disks. This is a software which helps to convert the data that you have got, whatever you have designed. It converts or sends it in a language to the milling machine. So this is the way in which you nest. So like, for example, if you look here, you will see that there is an area where this particular crown is getting made. So this entire, out of this entire disk of zirconium, you can see that you have these three struts which are available, and then you have the premolar, what you wanted to mill is nested and kept in this. So you don't essentially waste any of these. You're looking at proper utilizing the entire disk volume itself. So finally, choose the material and finally finish the milling process. If you're doing a printing, you see here that resin is getting printed here. So this is another way in which this is 3D printing. In that case, you saw subtractive manufacturing. So here this is additive manufacturing, where you 3D print the entire design. So this is how it is nested in the 3D printer. Then you pour the resin in this tray. This is the resin tray. You smooth out the resin, and eventually, yeah, you will have the building platform, and then you can build the whole thing. So you can see here that there has been a bar that is getting printed here. You see individual crowns getting, you see a bridge work getting done. So all of these things can be done in a single print. Usually overnight the printer is left, and then it starts printing out. This is usually in wax or in resin, and eventually this is melted out and then cast, and then you can build on top, ceramic on top of it. Now almost so many different companies are completely reliant on digital technologies to provide you the quality of care that you can deliver to your patients. And across companies, there's a huge boom in the entire digital market, and everybody is jumping on to the bandwagon of digital dentistry, where people are beginning to see how these structures will work. And of course, you also have other navigational technologies, where you look at completely guided navigational procedures, where you can essentially navigate between the your procedures. So you have a like a GPS sensor which is sitting on top of your dental chair, and your handpiece and the sensor talk to each other. So the way your handpiece moves, you can actually see it moving on a screen. And if your handpiece is getting into the bone, you can actually see that getting into the CBCT. So there is a GPS guided navigation technology that is also becoming increasingly popular. At the present point, it is in training and teaching, but eventually also some in practice. Eventually there will be a lot more in practice, so that you can, all of us can do guided procedures, like robotic procedures getting done, let's say by a urologist or a general surgeon. You can have a guided procedure entirely being done. So I hope I have given you a brief introduction into what are the possibilities with digital dentistry, starting from the role of 3D X-rays or CBCTs with the help of software, what you can do and how you can plan your guided implant placement, and how you can fabricate your guides through additive manufacturing and your final prosthesis to subtractive manufacturing. And basically, what we have with us is a landmark invention in the form of a CBCT, which is much more convenient for our patients. Our intraoral scanning devices have made it far more easier to take information from the patient's mouth and put it as a virtual model in our hands. There's also a cutting edge treatment planning softwares that have come up, and manufacturing with CADs have become so much better. And then of course all of these are able to help us to provide solutions which are accurate, which are fast, and eventually will also turn out to be much more cost effective. Okay, so thank you very much for this wonderful opportunity. I'd like to thank Dr. Binu again for this kind invitation and for helping me share some of my thoughts and views on this. Of course, Karthik and Selvam of Banyan Dental Lab, with whom I work a fair amount, and of course my clinical associate Dr. Priyanka, who is extremely talented in 3D technologies and radiology. She's an oral radiologist and helps us in almost all our treatment planning. And I'd like to acknowledge the contribution of all of these people into this. So thank you very much once again for this excellent opportunity.
Thank you very much, Dr. Arun. As, as usual, to the point. Any questions here? Any questions? You can quickly come to the chat box and ask your questions in YouTube or Zoom. Dr. Joby, you're there. Meanwhile, you can see about the next speaker.
Yes, ma'am.
And start off. Let me just clear the question session here.
Yes, ma'am. Yes, ma'am. I'm checking in the YouTube. Any questions are there? I will let you know.
Sure.
Dr. Usha Kiran has asked in Zoom. I don't know whether it's a question. No, that is previous. That's related to the PG presentation. No, not your session, sir. Very good session, sir, is coming up in Zoom. Let's see for some questions. See, these are all basically conveying the latest stuff going on, so questions may not really come, you know. So when questions doesn't come, it means two things. They understood everything you said, or they didn't understand anything you said. But whatever it is,
it is just a primer, so it's just an introduction.
It's yeah, excellent presentation. Very very well explained, very informative, clinically relevant. Thank you so much for sharing your advanced knowledge. So we're getting a lot of responses in Zoom regarding the lecture. So I guess that's it. No specific questions as it is. Dr. Arun, thank you. Oh, scope for a full day program is one comment which we got. Obviously, implant cannot be trained in 1 hour. And he already has his full day program, 3-day program, whatever, sir. You have 6 months program. He has every stuff going on there. You can contact him personally. He will help you on that. Don't worry about that. So, Dr. Arun, thank you so much for coming in.
Yeah.
We really appreciate your time. You came in so early and we were a little delayed, but you took it so positively. Thank you so much,
Thank
Dr.
you. Really
Arun.
enjoyed my time here. Really enjoyed.
Take care. You have been watched by little less than 500 people, but with YouTube thing going on, yesterday's program today is showing 3K. So this is going to be going all around. Thank you very much, Dr. Arun, for coming into our platform.
Yeah. Thank
once
you.
again. Dr.
Yeah.
Joby,
Bye-bye.
over to you.
Yeah, thank you.
Thank you so much.
Thank you.
Yes, Dr. Vinu, I just the next speaker is about to come, Dr. Giorgio Kotur. I'm just waiting for sir to join.
And for the information of all the candidates here, Dr. Giorgio Kotur is joining soon, one of the finest endodontists you can meet. Great human being, a person to talk to, person to meet, person to be with for a couple of days to learn about root canals. Finest root canals being done in his center. An academic person, and he has an academy of his own on root canals. One person to meet is coming soon. So just wait. And immediately after Dr. Giorgio's program is our own Dr. Joby talking about how to choose the right myofunctional appliance at the right time. Very important, guys. How to choose the right myofunctional appliance at the right time. That's what Dr. Joby is going to talk about. Just stay tuned. Everything coming up within minutes. All right. Yeah, Dr. Joby?
Yes, brother. Dr. Vinu, are you there? Good evening, all. I would like to take this opportunity to announce the winner of UG poster. I just got from the judges the list of 5 winners of UG poster. So I would like to announce it's my privilege and honor to announce the best 5 UG poster winners that the judges have selected. There are 5 people. They are all best. And these 5 people who have selected have to come on Sunday and present it again one more time. All the details will be given to soon. The first person to be selected by the judges DB001, and the topic title of UG poster is, the name of the person is Reshma Rajan. Okay, Reshma Rajan, Light Management Analysis Module, a boom in the field of salivary diagnosis, is selected by the judge as one of the best 5 UG posters. Congratulations to Doctor. All the best. See you on Sunday. Schedule will come. on that. Stay on that. I have an announcement for this group to be made. The second one selected by the judges are DBO6. DBO6 is Dr. Akhila S. Nair. Dr. Akhila S. Nair, she talked about, the poster was about mineral trioxide aggregate. So she is the second best UG posters among the 5. Now the third one is DBO7. DBO7, Mehul Bakmar. Okay, I hope its pronunciation is the same. Mehul Bakmar, and her topic is enamel engineering, fiction or future of dentistry. So you are the third one selected by the judges on UG poster presentation. And the next one is DB11. DB11 is Mohit Bakmar. Okay, the DB11, and his topic is advances in reinforced restoration. DB11, advances in reinforced restoration. And the fifth one, DB14, 14, and that is Dr. Prakshika M. Chandane. Dr. Prakshika M. Chandane, and her topic is oral and systemic health and interlink. Oral and systemic health and interlink, DB14. Congratulations to all the 5 best poster, UG poster titles. You will be given a link where your original presentation in front of the judges will be uploaded. You all can go and see those links, see those videos, listen to the judges' criticism and improvement what they said, but do not change the poster. You can come back on Sunday. Time will be announced soon by today. You will come to know that. And Sunday, 1 to 4 is all competitions. Final 1, 2, 3 will be judged. So those people who have selected for the final 5, again, a congratulations from our side. Go to the link, will be posted soon in your respective groups where you are in. Click the link and watch it again. Criticism by the judges, see it, improvise it. You have more than 12 hours now. You improvise and practice this and come on Sunday in between 1 to 4 p.m. We will let you know. And the judges are going to again see your improvisation because they have already judged it. And all the best. Thank you so much. Yes, Dr. Jojo sir has come. Dr. Jojo has come, sir. Are you there? Joe, can you make sir as a co-host?
Yes, sir. I've done that, sir.
You've done that? Jojo sir, Dr. Jojo, are you come? Are you there?
Yeah, I'm here.
Yeah. Thank you. Thank you so much. Thank you so much. Thank you so much. Good evening. Thank you so much for coming. So shall we start? We are just waiting for you. I know you are a busy day, Saturday. We are done.
Yeah, I just came back from college today.
Yes, I know, sir. I know.
Please call me Jojo.
Yeah, you told me. My slides are clear. Is there, Dr. Joe? My slides are clear?
No, sir. You haven't started sharing now.
There is no sharing. There's no sharing now, Joby. That's all right. You can introduce, sir. Dr. Jojo, thank you so much for coming in.
Yeah, thank you. my pleasure.
I had made a slide of introduction. Can I put that?
Yeah, sure. Go ahead.
Yeah. Yes. So good evening, all. We have one of the very eminent endodontists today, very enthusiastic artist, you name it. The way that he presents is can mesmerize you. You can never forget the way that he tell. Each word, each sentence, because I have listened to him many times, and each time when I listen to him, there are new topics, there are new points, I have to write it down. So be ready with a pen and paper, because one of the most mystery, you can say, in our practice is endodontics. And we should be well thorough with endodontics. It's changing day by day. And he is one person whom you should meet to find the change, because when I going to talk about him, to introduce him, you will understand why I'm saying that. So today's topic is no way that you can miss it. Each slides are important. Each things what he is going to tell is very important in our clinical practice, because every dentist success is endodontics. That aspect of dentistry cannot be ignored. That is the backbone. All are important, but this is a backbone in our practice. Jojo sir, Dr. Jojo is pioneer in endodontics. He has finished his undergraduates from Meenakshi University, endodontics from Meenakshi University. And believe me, sir is the first endodontist or a dentist in the world who discovered 7 and 8 root canal system in upper first molar. Believe me, I only seen 4 or 5. Sir has seen 7 to 8. That is a dedication, and the compassion for endodontics is having it. And it is published in JOO, International Journal of Orthodontics. Postgraduates, undergraduates, you are there, refer this article, amazing article with CBCT. Sir has given the evidence-based a new perspective that we are not dealing with the 3-4 canal system. A huge lot of systems are there. Then sir is the first person to say that 4 canal root systems are there in lateral incisors, especially maxillary lateral incisors. In this 22 years of practice, I have seen 2 maximum, but 4 canal system. Wow, that means I have to be more cautious, and I should rely on a lot of new diagnostic tools to find out that. And he has got 27 PubMed index articles. It is worthwhile to go through his ResearchGate profile and see the journals. And he is currently working as a professor in Royal Dental College. Believe me, this is not what he is. He is much, much beyond that. His talent in all aspects of life, and the way that he teaches, his passion for teaching endodontics, and the approachability that you can have with him can blow your mind. So any time of your life, if you want to meet sir has got a center called Root Canal Point, which is in Kerala, India, where there is a training happening, advanced training or basic training that is happening. Even endodontists come and get trained at level of training he can give and support you in your clinical practice. That humble, down-to-earth human person is Dr. Jojo Kotur. With that, let me introduce sir without wasting much time. Sorry for this delay. I told you, sir, a 45 minutes delay will be there. Thank you for your patience. We are all waiting to listen to you. Thank you, sir. You can start your sharing.
Okay. Is the screen visible?
Sir, you have not started sharing.
Okay, 1 minute.
Joe, are you there? Can you just help, sir? Is it a...
Yes, sir, I'm here, sir.
Sir, screen is not shown, no, right?
Yes, sir. So you can start the share right now, sir. Yes.
Yes, sir. Yes, sir. Yes, sir. Great, sir. Done.
Okay, I hope I'm audible, right?
Yes, sir. You are.
Shall I start?
Yes, sir. Go ahead, sir. All the best, sir.
Thank you, Dr. Joby, for the wonderful introduction. I hope I can go up with the expectation in the way you had mentioned about me. So first of all, let me thank the organizers, especially Dr. Joby, for inviting me for this lecture. And we will straight away go to the topic or the subject. And the topic which we will be discussing today is strategic management of endodontic failures. So after this lecture, what the audience will get is, number one, the audience will be able to appreciate the cause or causes of endodontic treatment failure. That's the first thing. And second, you guys will get a better understanding of how to manage these type of cases. So these are the two things what I expect the audience to grab after this lecture. The flowchart of my presentation will be like this. Number one, I'll be speaking about post-treatment disease. Now you may be wondering what is post-treatment disease. Post-treatment disease is nothing but endodontic failures, and there is a lesion under the root tip. So you have done an RCT and you have a lesion there, and that lesion is called, generally we call it as post-treatment disease. That's because that's a disease that happens after the treatment, and the reasons for this disease could be many that we'll be discussing later. The second will be, how is post-treatment disease recognized? How can you recognize it? The third, I'll be discussing the diagnostic consideration, and fourth, the treatment consideration, and finally, we will see the treatment options available for post-treatment disease. So let's understand what is post-treatment disease. I had mentioned this post-treatment disease is nothing but a failed root canal treated tooth. That is simply means a post-treatment disease. You have a disease for that particular tooth because of the improper treatment, the primary treatment or the primary root canal treatment that we have done. So if you need good endodontic treatment outcome, we are all looking for endodontic treatment outcome, right? So you do a RCT, you don't want the root canal to fail after your treatment. So if you want the root canal treatment not to fail in your practice, you need to follow these 5 principles. Number one, correct diagnosis. You need to diagnose the case properly. Number 2, you need to disinfect the root canal properly. Number 3 is a good instrumentation. Number 4, you need to fill it 3-dimensionally. And at the same time, the last factor is you should not have any complications during the procedure, like instrument separation, perforation, ledging, and all those things. So if you can do a root canal treatment satisfying all these 5 principles, you definitely will get a good treatment outcome. Okay, so but if you had done some compromise in any of these 5 factors, or you had done some complications, definitely that will lead to post-treatment disease in the form of periapical lesion that you may see on a radiograph, or swelling of sinus tract that you see during clinical examination. So what are the primary cause? What is the primary cause of root canal failure? The primary cause of root canal failure is the presence of microbes inside the root canal system. And this can happen because of 2 reasons. Number 1 is a persistent infection. What do you mean by that? It simply means that you had kept some bacteria inside the root canal. Okay, you didn't fill it to the apex, or you may have missed a root canal. So there is a lot of bacteria which is there inside. So you have persistent infection, that is residual bacteria. The second cause of the primary cause of root canal failure is secondary infection. This could be, I can explain it like this. You have done a good root canal treatment, but you have failed to give a good post-endodontic restoration. So you will have bacteria entering through the uh, uh, coronal portion, which is called a coronal microleakage, and it will enter into the root canal and again will infect the root canal system. So that is called the secondary infection. That is not because of the improper RCT, but rather it is because of the improper coronal restoration. What could be the secondary cause? The secondary cause of the failure of primary root canal treatment is basically because of iatrogenic errors. What are iatrogenic errors? The errors that is caused by the dentist or the endodontist who is doing the procedure in the form of ledging or separation or probably perforation. All these things can cause iatrogenic errors. So when you have iatrogenic errors, that could be another reason why the primary root canal treatment fails. Now there are certain tertiary causes of endodontic failures. Now this tertiary cause most commonly seen in a well-obturated root canal. You might have seen in your clinical practice. Radiographically, the root canal treatment looks perfectly fine, but still the lesion is persisting. So you may be wondering at that time, what could be the reason for the persistent infection? There are few causes for the persistent infection, which you have seen in a good root canal treated tooth. Number one is extraradicular infection. Number two is non-microbial causes. What do you mean by extraradicular infection? It simply means that the cause of the lesion is not from the root canal, but rather from the outside the root canal, that is towards the outside of the root, outer surface of the root. So the main cause of such an infection is something called periapical actinomycosis. So actinomycosis can survive on the outer surface of the root, and that will in fact cause persistent periapical lesion. The second cause is infected root dentine debris. So while doing the primary root canal treatment, you may be pushing a lot of infected debris beyond the root canal or beyond the minor or major foramen, to be more specific. So these infected debris have a lot of bacteria. It is necrotic or it is totally infected. So these infection of bacteria will persist inside the periapical region, and that can cause persistent infection. The non-microbial causes include foreign bodies in the form of GP or extruded sealer, which can cause persistent lesion, or it could be because of a true cyst. I hope you know what is a true cyst. True cyst doesn't have any communication to the root canal. So even if you've done a good RCT, the cyst is going to persist there. So these are the causes which I can enumerate why the root canal treatment fails. Number primary cause, secondary cause, and tertiary cause. So let's see a case here. If you can see the root canal treatment looks satisfactory, especially on the mesiobuccal root and the palatal root. It is short of apex, maybe by 2 mm on the distal buccal root. But I'm wondering why there is a lesion towards the mesiobuccal root. Radiographically, the root canal looks fine. It is 0.5 mm short of the apex. The reason for this failure is because there was a split of the mesiobuccal root canal at the apex. So this I could find it under the microscope, and I had cleaned and shaped it and filled it three-dimensionally. So you can see the split over here. So this split was not identified and tackled on the previous treatment. You can see only the primary MB1 is filled here, and that is the reason why you have persistent periapical change, or we call this as post-treatment disease. Okay. So the next thing what I'll be discussing is how is post-treatment disease recognized? How can you recognize it? You can recognize it by 3 ways. Number one, you have to take relevant history. Number two, good clinical examination. Number three, a very thorough radiographic examination also. So let's discuss the relevant history that we need to ask from the patient while identifying the post-treatment disease. Number one, we should ask the patient, where was the treatment performed? So these are the things which I ask during my practice, because my practice basically a referral practice. I get a lot of patients referred from many dentists to do this retreatment, and almost 70% of the work what I do in my endodontic area is retreatment. So when a patient comes to me, I will ask these questions in specific. The first question I'll be asking is, where was the treatment done, or the primary treatment done? Now, why I ask this question is, I may be getting certain information from this. So sometimes the patient had done root canal treatment in certain universities or colleges, or it could be performed by an undergraduate or a postgraduate. So I may be understanding the quality of treatment that was done performed during the primary treatment from this question. Second question, the most important question is, when was the treatment performed? For example, I have a lesion and the treatment was performed 2 months back, and radiographically the treatment looks fine. It may be a healing lesion. So this question is very relevant in order for us to identify whether the lesion is healing or it is a persistent infection. So if the patient is reported to me that the root canal treatment was done almost 3-4 years back, definitely that lesion is not a healing lesion. This is a persistent lesion. Number 3 is, what was the cause of initial RCT? This is also very important, because I may be understanding the amount of problem that the patient initially had. For example, the patient is telling, I had swelling. So that means swelling means during the primary treatment itself, the tooth was severely infected. So, or the patient is telling that there was a fractured tooth. So I can expect the fracture could be beyond the CG, and a lot more information I can gather before I start the treatment. The fourth question which I'll be asking was there any discomfort before, during, and after the root canal treatment? So if the patient is telling, yeah, during the treatment I had severe pain, that is a potential cause of a complication. So there could be some complication which the primary dentist hadn't informed the patient, or probably it could be a flare-up. There could be many reasons, but we will get a glimpse about what was happened to that tooth before we initiate a retreatment. So these are the relevant history what I will take or acquire from the patient. The second thing I'll be looking is clinical examination. So I basically have a 10-point checklist for clinical examination. Number 1, I always check the occlusion. So being an endodontist, I'm a restorative dentist also. So definitely all of you should check the occlusion before starting with endodontics. So I can speak more about this, what all I'll be looking in occlusion. But because of the limited time, I'm just briefing out what are the things which I'll be looking for during clinical examination. So number 1 is occlusion. Number 2 is the status of the existing crown. I may be deciding whether I have to go through the crown or take out the crown before the treatment, depending upon the second factor. Number 3 is swelling. Is there any swelling externally? In that case, if the swelling is there, I may be seeing whether it is firm or fluctuant. I may be also seeing whether it is localized to one area or it is diffused. I can also palpate and see whether it is soft or hard. So these have clinical relevance. Number 4, I will look for sinus tract. And if there is a sinus tract, I may be doing a sinus tracing in order to identify from where exactly the infection is originating. Number 5, palpation. I may be palpating the buccal and the palatal aspect or the lingual aspect. Number 6, percussion. Do not try to percuss the tooth directly with the handle of the micromirror that many people does that way. When I used to do that maybe 6-7 years back, because that is how it was taught to us. Because you should not do that, because sometimes the patient will have severe pain and you tap with a mouth mirror, patient will jump. Instead, what I do right now in my practice is I take the thumb and press the tooth and ask the patient, do you have any pain? If the patient is saying, yes, I have pain, then I'll be very careful in tapping the tooth with the mouth mirror, or maybe I may be eliminating that procedure because there is tenderness to percussion. Number 7, mobility. It is something that considered to be some sort of periodontal problem, or could be a root fracture, or it could be many things, but definitely you should look for the mobility. 8, periodontal probing. You need to walk the probe around the tooth, and it's very important. This is also something that many people miss. I always say during my lecture that the first instrument that should go into the patient mouth should be a periodontal probe and nothing else. Number 9, I look for the restorability of the tooth, because that is very important as far as I am concerned, because you do a good root canal and later you understand you cannot be restored. No point in doing a treatment that way. And last, I will look for the teeth, assessment of the teeth. I will look for the strategic value of the tooth. If the tooth doesn't have much strategic value, yeah, probably I may say it is better to extract it. So the strategic value of the tooth also should be assessed during clinical examination. Radiographic examination, the third one, also have a lot of importance. I generally spend around 5 to 10 minutes for radiographic examination. I have seen many people, including me, sometimes I look on the radiograph and maybe 2 seconds or 3 seconds and just come back to the clinical scenario. It should not be that way. You have to spend some time on a radiography examination, whether it is a 2D or a 3D, and that will give you a lot of information if you look it properly. So what all thing I look on radiographic examination is the status of the extracoronal restoration. I look for the filling material, status of the permanent filling material or temporary, whatever it is. I look for secondary decay. I look for missed root or canal. I also look for posts. In the modern era, it's very important because most of the fiber posts have a radio opacity similar to gutta-perca, and it's very difficult to differentiate between a gutta-perca and a post. So you should look very carefully in order to identify a fiber post. I look for iatrogenic errors like perforation and all those things, periapical change, and adjacent anatomic structures. So these are the things which I look during radiographic examination. Now, if the radiograph, the two-dimensional radiograph or the IOPA didn't give much information what is required for the treatment, I may be taking a three-dimensional image. For example, in this case, this is a referred case. The complaint from the general dentist was there was a lot of bleeding when they instrument the palatal canal. So when I took a radiograph, I could see a big radiolucency here, suspecting of some sort of resorption. So definitely you need a three-dimensional imaging in the form of CBCT, wherein it gives a good picture that the internal resorption is towards the palatal root, and most importantly, it is perforating and there is lack of palatal cortical plate here. So I'm not going into the details of how I manage the case, but rather I'm going to show the post-op radiograph here. I filled the palatal canal till the perforation with GP, and all the perforation, not the perforation, I mean to say the internal resorption area is filled with MTA, and a good post-endodontic filling was given. And a post-treatment radiograph also was taken. So you could see the gutta-perca inside the root canal, and wherever there was internal resorption, this is totally filled with MTA, and a permanent filling was also given here. And this is the follow-up radiograph which was sent to me by the referring dentist, and he had done a good overlay here. You can see the margin Lydian disilicate definitely. So the third part of the presentation is diagnostic consideration. What all things you look in the diagnostic consideration? The first thing is that if we establish a post-treatment disease, don't do endodontics directly. This is a big mistake that many people does. You see a lesion after an RCT, many people directly start re-root canal treatment. No, please don't do that. The thing is, first we need to identify the cause of the post-treatment disease. It could be endodontics, but it could be peri also. So the post-treatment disease could be due to endodontic reasons. Definitely you can, if you identify it as endodontic, definitely you can start the treatment. But there are post-treatment disease that happens because of iatrogenic complications. So if you didn't identify that, you won't be able to finish the treatment very well. So you have to look for iatrogenic complications on the radiograph or with the patient's history. In addition, you should look for the post-treatment disease because of periodontal problems. Sometimes there will be some sort of progressive periodontitis or generalized periodontitis that may lead to periapical lesion, and not because of primary endodontic reason. Or it could be because of the prosthetic reasons. For example, if they hadn't delivered a crown properly, it had violated the biologic. Patient will say, I have pain during chewing. And if it is a traumatic occlusion, definitely it may lead to periapical change. So it's very important to identify the cause of the periapical lesion or the post-treatment disease and tackle accordingly. Do not directly jump into re-root canal treatment without properly identifying the cause. Let's see the first part, that is endodontic post-treatment disease. You can see post-treatment disease towards the mesiobuccal root here. This is basically because of a primary endodontic origin. You can see the mesiobuccal root canal is short of apex. There is no evidence that an MB2 canal is filled. It's an young permanent tooth, so definitely there is 95% of having an MB2 here. So this is a clinical picture. The dentist itself had started a re-root canal treatment, but he couldn't identify the MB2, so that's why it is being referred to me. So this is the temporary filling what the general dentist had given after the re-entry. So I had removed the miracle mix or the permanent restoration here. This is miracle mix, okay? So never give miracle mix. It doesn't create any miracle, to be honest. It is one of the worst restoration I can recommend for you. So I don't recommend using this miracle mix in your clinical practice. So after removing the temporary filling and the permanent filling, I could see secondary decay here. And this is MB1, this is DB and palatal here. You can also see a lot of burr marks here, and here it's little deeper. If it had gone little more deeper, definitely it had ended up in a perforation. And finally, I could see a bleeding spot here, and that is the MB2, which was totally infected and inflamed. That is why patient had pain. And this is after cleaning and shaping and the pre-endodontic buildup. And this is after obturation, and this is the post-operative X-ray. So here you can see that MB1 and MB2 is having a separate exit, and that is exactly why this particular root have post-treatment disease. So this case is a classic example of primary endodontic post-treatment disease. The reason is primary endodontic. So let's see another case. Again, here, this patient referred to me because of swelling and sinusitis. So if you look here, both the roots, there is GP. GP is to the apex, but there is a lot of voids between the GP. There is a perforation here. You can see the vertical bond loss here. I'm suspecting a perforation here also, but it could be a primary endodontic secondary perio. You understood? Because the distal root looks very much infected. I could see a radiolucency under the distal root. So it could be because of the primary endo, which lead to a secondary perio, and that is why the photoradiolucency had happened. Again, I'm not explaining the treatment part, but you can see after the treatment, I had repaired the perforation with MTA. There was no perforation here, but rather it was primary endo secondary perio. This is immediately after the treatment, which was done on 27/9/2017. This patient reported to me after a year. So you can see the beautiful healing that had happened here. Why it healed at the furcation is the cause of this radiolucency is primary endodontic and secondary perio. So we are given an onlay in this case, which I may be showing it in another presentation. So this is another case, multiple problems here. There is a missed root called radix endomolaris. Radix endomolaris is nothing but a missed distobuccal root. Distolingual root. So the distolingual root is being missed totally here. The distobuccal is short of apex. The mesiobuccal also is short of apex, and probably on the mesiolingual there is a separated rotary file. So I have multiple things in managing here. Again, this is after the treatment. You can see the radix entomolaris, that additional root which was missed also is tackled. The instrument was removed, and all the canals was cleaned and filled to the apex. So this is the follow-up radiograph. The patient reported back to me for another root canal after a year recently. And I took a follow-up, and this was a picture. Complete formation of bone towards the furcation. There's a little bit of lesion towards the distal root. I don't know why, but the patient is totally asymptomatic. If I was the one who was delivering the crown, I definitely should have opted an individual crown, but this bridge was given by the general dentist who referred the case to me. So this is how you should go ahead. You should always identify the cause rather not to directly jump into endodontics. So let's see the treatment consideration then. So the first thing we need to look is the strategic importance of the tooth, whether the tooth is worth saving. So that is something that we need to look in treatment consideration. Number two, the motivation level of the patient. That is also important. Do not do the retreatment if the patient is not motivated well. It's our duty to motivate the patient, but if the patient is not motivated good enough, better extract that particular tooth. Number three, isolation possibility. Retreatment is not something that every person can attempt. If you want to attempt a retreatment, in my opinion, you should be good enough to do a primary root canal treatment well. So if you're a beginner, please don't attempt a retreatment because you're trying to rectify a mistake that was done by someone else. So you should be well versed with root canal anatomy. You should have a lot of practice in terms of endodontics. Then only you can do a good treatment. Also, isolation is very important in order to do retreatment because if you have isolation, you get better vision with loop or microscope, or whatever it is. So isolation possibility should be considered during the retreatment strategies. Mouth opening is also very important. How much time the patient can keep the mouth open, that also should be asked. Whether the patient have any TMJ issues, which directly have some success in the treatment that we are going to deliver to the patient. Procedure complications should be assessed. Complexities should be assessed. Referring dentist reason should be also considered because we, as a specialist dentist who practice basically referring practice, we need to satisfy the dentist and the patient. So the referring dentist reason should also be considered. Clinician ability, our own ability should be assessed. Economic status, you need to discuss the economics of the treatment with the patient, that also should be assessed. Then finally, the patient preference. The patient preference, we need to give a lot of the treatment options available. And finally, we can ask the patient, okay, which treatment you want. It's our duty to tell the patient the advantage and disadvantage of each treatment option, but the final take should be given to the patient. And whenever you are planning a retreatment, you should consider endodontic, restorative, prosthetic, and periodontal problems. So you should not finish the retreatment with endodontics. Okay. So many patients have a belief that you do a RIA-CT properly, then that's it. That's the end of the game. No, it's not the end of the game. RIA-CT is only a first step, and then they have to receive a good restoration. Then they have to have a good prosthesis over it, and they have to maintain the periodontium. So if all these 4 factors is taken into account, then only RIA-CT will be successful. We call that as a predictable treatment for a longer duration of time. Probably we can assure the patient this tooth is gonna stay in your oral cavity lifelong if you can take into consideration of all these factors which I have discussed. Now the last part is the treatment options. What are the treatment options available in retreatment? Number 1 is no treatment. Keep the tooth under review. Number 2, root canal retreatment. Number 3, surgical endodontics. Number 4 is extraction. So these are the 4 things what we have if the tooth is having post-treatment disease. So we will discuss the number 1, that is no treatment. Keep the tooth under review. When will you do that? This is what I generally follow in my practice. That is, if the patient, these are cases which was referred to me for retreatment. But I didn't do retreatment here. We should not do it because it is unethical to do retreatment in this case because the patient was asymptomatic and there's no periapical lesion. If you look, even though it doesn't have any correlation with what we had learned in endodontics, you have a separated instrument here. All the root canal is short of apex. They're done almost 15 years back, but there's no lesion. So why should we do a retreatment here? No, you should not do a retreatment here. Look at another case. This treatment was done almost 20 years back. Let's see, only 2 mm is filled. If someone is filling a root canal 2 mm short of apex, I can understand. It is human error. But if only 2 mm is filled, it is intentional, to be honest. But still, this dentist could be lucky because there's no lesion. It is perfectly fine. So in this case also, I hadn't done any retreatment, but there is a secondary decay here. So I had done a good post-endodontic filling. That is fair enough. So that's about the first option, that is leave the tooth as such. The second option, treatment option available is root canal retreatment. So when should you attempt a root canal retreatment? So whenever you see a lesion or a post-treatment disease because of primary endodontic failure, you can attempt a retreatment. Here you can see a lesion towards the lateral aspect of the root and also towards the tip of the root. So this is after the treatment. This lateral lesion is because of a lateral canal here, and this radiolucency is because of the improper RCT. So this is after the treatment. Now this is also very important. That's why I written it here for you. It is important that the patient has a realistic understanding of the complexity of both the problem and the treatment. It's very important that we explain the situation to the patient. The patient should also understand the complexity of the problem and the treatment then that we are doing. Then only the treatment have some value. Otherwise, they are not going to value the treatment that we have done. So in my practice, I give 4 important instructions for the patient before starting the RIA-CT. Number 1, what I will say is the retrievability of the existing material. I mean, I always tell the patient that the prognosis of retreatment depends upon 4 factors. Number 1 is the retrievability of the existing material, which include GP, post or sealer or whatever it is. Number 2, identification and negotiation of all root canal to the working length. Number 3, restorative diagnosis only after dismantling the crown. This also I will clearly explain to the patient. I can only assess the restorability after dismantling the crown. So we should always tell these things to the patients. Otherwise, they won't understand the complexity of the treatment that we are doing. And at the end of the treatment, if we explain the complexity, the patient will really appreciate the treatment work we have done. So in root canal retreatment, there are certain clauses. Number one is that root canal retreatment can only be carried out if the tooth is restorable. Now, even if you have a post-treatment disease because of endodontic reason, if the tooth is not restorable, please do not do retreatment. There's no point in doing retreatment if the tooth is not restorable. So if you look into this case, this patient badly want to save the tooth because the patient is a dentist. That's why she need to save the tooth. But if you look into the root canal, which someone had done for her, only one canal is filled. That is a palatal. The mesial buccal and distal buccal is not filled. I don't know what is this exactly, but you have a separated instrument beyond outside the root. If someone fractures a file within the root, I can understand, but we hardly find someone fracturing a root canal treatment file outside the root. I don't know what treatment this was. Anyway, I had asked her to dismantle the crown or bridge. So we dismantled it, and this is what we had found. Seeing that, I was thinking about my daughter's favorite dish, that is the spaghetti. So it looks like spaghetti here, but definitely this tooth is beyond savability because the restorability of this tooth is severely compromised. So there's no point in doing any hierodontics here. It is better to extract. So another case, this patient also want to save the tooth badly because again, she's also a dentist and there's no scope in saving this tooth. So you can see the focal radiolucency, there's a perforation. There's no point in doing any crown lengthening here. So no way. So it is better to extract this tooth, and this is what she had done. It's better to put an implant in this particular case. So the second aspect in retreatment is management of existing extracoronal restoration. So there is always a diagnostic dilemma whether to remove the crown or go through the crown. So the thing what I follow in my practice is I will ask the patient when was the crown placed. Now, if the patient is telling that, or the referring dentist was communicated to me that the crown was placed maybe 2 months or 3 months or maybe a year back, then sometimes I may be doing it through the crown, because what I assume is that since it is recently placed crown, there won't be any decay underneath. So I am believing the previous treatment and I may be initiating a treatment through the crown. But if the patient is telling the crown was placed maybe beyond 2 years, I highly recommend or insist my patient or educate my patient to remove the crown, because there could be decay underneath. And if I fail to remove the decay properly, my retreatment is going to fail. So this is the basic strategy which I follow in my practice. Number 3, removal of post. Retreatment is not only removing the gutta perca, it is also removing the screw post, cast post, or fiber post, whatever it is. So when it comes to cast post and screw post, it should be removed with ultrasonics. So you can see I'm trying to remove a screw post here. There are certain screw post removal tips. This one is from Statex. So you transmit the ultrasonic energy to the cast post, and cast post will transmit it to the cement, and cement will break, and that's exactly how the cast post become loose. So it's a little time-consuming procedure. It's an edited video. Don't think the post had popped out like that. So it had took some time to come into this last scene of the post to jump out of the root canal system. So this is after the treatment. If you have a screw post, you can again remove it. This was a video, but somehow it's not working. Apologies for it. Anyway, if it's a screw post, the strategy remains the same, but only thing is you put the ultrasonic tip and rotate it counterclockwise, because you're screwing it clockwise. So always the energy should be given in a counterclockwise manner. And the last thing what we need to remove is GP, sealer, silver points, or separated file. That also comes under retreatment. So here you have a fractured file. There's no way I can remove this fractured file. So in that case, I may be opting whether to remove or bypass. So in this case, I have bypassed it. You can see I have bypassed the fractured file. The file is still here. And the GP can be removed with rotary files or edge files, or probably you can use some solvents, even though it is not recommended much now. Or you can use some heat carriers like touch and heat or something like that. Anyway, you have to remove the gutta perca completely, because why we are doing a retreatment is because the root canal is filled with bacteria. And if you leave some gutta perca inside the root canal, definitely that gutta perca is infected. That's why I written it here, infected gutta perca. So you need to remove that gutta perca in order to make sure that the retreatment is predictable. Okay. So you have to remove the gutta perca and the sealer also. If you want to remove the sealer, the best solution what you can use is EDTA, irrespective of the sealer. You put EDTA and activate with ultrasonics. That's the best way, according to me, to remove the sealer. So it is ready for observation, and this is after observation. The file is still here. Okay. Sometimes you may find beautiful, more opaque white color thing like this. These are silver points. Don't get confused that with a gutta perca. Gutta perca won't have this much radiopacity. So silver point can be easily removed with Stiglitz forceps. There will be always a projection towards the chamber. You can just grab it and pull it out. It's very easy. And sometimes you may get a file like this. Whenever I see a file towards the apex, I always try to bypass, because especially in this thin root, if the root is very thin, it is not easy to take it out. But in this case, I tried my best to bypass it, but since it's a rotary file, I couldn't able to bypass it. So I need to take it out. So this is a video of, oops, it's not playing. I'm sorry. Anyway, this video is there in my Facebook page. You can watch it sometime later. This is a video wherein I'm just trying to show you how I took this file out and completed the retreatment. Give me a minute. The slide got hanged. The pictures have a lot of resolution, so that's why. Anyway, so the third option what is available for us is surgical endodontics. So surgical endodontics is, it depends upon the size of lesion and periapical surgery. So there are specific indications for periapical microsurgery. If you have a lesion, don't do endodontics directly. First, make sure that the root canal treatment is done properly. If it is not done properly, you have to always do a retreatment. Okay, but there are certain scenarios in which specific indication for periapical surgery without doing a retreatment. Number one is irretrievable separated instrument. Sometimes you have a lesion and there is a separated instrument at the apex or beyond the apex. So there you need to do a periapical surgery. Number two, well-fitting coronal crown with a post. Sometimes you may be seeing a well-fitting crown with a post there. So it is not easy to remove the post and the crown, because whenever you see a post, that means the tooth restorability is compromised. So in that case, instead of trying to remove the post and crown and retreatment, you can simply do a periapical surgery. And the last indication is a post-treatment disease on a well-obturated tooth. You will see a good obturated tooth, you can think about the tertiary reason for post-treatment disease. That is probably some sort of extracellular, extra-radicular infection like actinomycosis or debris, or it could be because of some foreign body like sealer extruded GP or maybe cotton. So these are the possible reason. In that case also you can try periapical surgery. So this is one case which we had done. So you can see this is a bridge standing from canine all the way to the other side. And there is a screw post here, and the root canal is improper and there is a lesion. So we don't want to remove the bridge here because already it's a strategically important tooth. This tooth have poor restorability because already there's a post. So this is a specific indication, and the crown looks intact. It looks fine clinically and radiographically. So why should we remove the crown? Instead, you do the periapical surgery. And whenever you do periapical surgery, please make sure that you do a retrograde filling. Also, if you don't do retrograde filling, it is not going to be successful. So you can see there's a micro mirror here. You can see the MTA which I have placed during the retrograde trip, and this is after the treatment. You can see MTA here, but this is biodentine. That is why it is not visible on a radiograph. Biodentine have a radiopacity similar to dentine, so that's why you won't be able to see the retrograde filling here. We are yet to get a follow-up because this case was done maybe 3-4 months back. This is another indication for surgery, a file gone beyond the distal buccal root, and it is probably within the sinus. So we had tried removing it, and finally we could remove the file along with the tip of the distal buccal root. And again, a retrograde trip was done and MTA filling was given. And this is after the treatment. So the distal buccal root had undergone an episectomy procedure with retrograde filling. The patient is fine. It's been on an year now, and she had received a coronal restoration. The last option what we have is extraction. So the specific indication for extractions are non-functional teeth, questionable restorability, and inadequate motivation from the patient. These are the things where I recommend extraction. Non-functional tooth, there's no need of a RCT here. Questionable restorability, definitely no. You have to extract. Inadequate motivation, I always say, if the patient is poorly motivated, better do extraction and plan for some substitute rather than doing retreatment. So here is the case. A patient is around 65 plus. The patient is having diabetes. There is a focal radiolucency. There is some sort of post here. So the moment I remove the crown and try to remove the coronal restoration, I could see big perforation there. And this is not something that can be restored because the time of perforation is important in order to get a predictable result. And this had gone for extraction, definitely. There's another case. This patient was referred to me from Kozhikode. It's almost around 150 kilometers from my place. And look at the treatment, a RCT. This patient had undergone a RCT. And the dentist had, they removed the floor completely. And you can see the burr had gone at this level. And I had seen the radiograph itself. I told the patient is a doctor. I told there's no way scope for the RCT, better extract it. But he wanted me to do something. So I put the rubber dam and seen it. And what you see here, it's very interesting. What you see here, this one, is the septal bone. And then, they had put the burr and created 2 openings on either side of the septal bone. And when I am touching the septal bone, the bone was moving here and there. So I had shown this to the doctor and it had gone for extraction. So retreatment is not an easy one. You have to look into all the factors which I have mentioned. Don't jump into retreatment. Also, case selection is very important. You need to identify the cause of post-treatment disease, and capability is also an important factor. You should not jump into retreatment if you are not competent to do the procedure. So this is a workflow with, for me, this is a video. I hope this will work. Thankfully, this also is not working. Anyway, leave that. Give me a minute. Okay, so if you want to do treatment like this, you need to have few things. Number one, you need to have armamentarium, you should have magnification, you should have knowledge, skill, expertise, and you should have a little bit of luck. So if you have all these 5 factors, then only you can do a good retreatment. You need to have this combination. So that's the end of the presentation. I would like to thank all my teachers, which I generally do after my presentation, all my presentation, because what I'm today is basically because of my teachers, the right guidance which they have given me. So I acknowledge or thank all my teachers for what they have done during my post-graduation. I am extending my thanks to my wonderful batchmates, very competent, fun-loving, or whatever I can say. They actually have changed me, to be honest. So this is the picture that was taken on the last day of my post-graduation. So you can see me here, my batchmate Anuj is here, my good friend Denzil is here, Anuradha, you have Sister Smita and so on. So this is our PG department, Meenakshi Ammal Dental College. So that's it from my side. If you have any queries related to this topic or beyond, you can contact me. You can see all the video which I had shown you, I hadn't shown you on this Facebook page called Root Canal Point. So if you're there in Facebook, you can go to my page, Root Canal Point. There is a Instagram handle called Root Canal Point. So if you're there in Insta, you can follow me there. Or you can email me at dr@rootcanalpoint.com, or you can ping me at 944738963. And maybe may not be answering it all the time, but definitely I'll get back to you whenever I get free, because I do multitasking. So I teach, I practice, I travel. So I may not be able to revert back at that moment, but definitely I'll get back after some time. Okay. And there's a website also called rootcanalpoint.com. So that's it from my side. I hope I grown up to the expectation in the way Dr. Joby had mentioned. And that's it from my side. Over to the organizers.
Dr. Giorgio, thank you so much, Dr. Giorgio. This is excellent. Okay. Excellent. And we have some questions. Can you take some questions, sir?
Yeah, please, go ahead.
How do we decide whether the post-treatment disease is because of endodontic or because of periodontal reason?
Basically, you have to probe the tooth. You find some pocket, definitely you can suspect periodontal problem. So if it is a primary periodontic and secondary endodontic, definitely the patient will have some sort of periodontal issue. So in that case, you need to consult the periodontist first. And the periodontist should say, yes, this tooth can be saved in terms of perio, then only we should do endodontics. So if it's a primary perio, secondary endo, you should always take the consent of the periodontist before initiating the retreatment. But if it is a primary endo, secondary perio, yes, you can start the retreatment without the periodontal opinion.
Such a beautiful, precise, and to the point lecture. So, which is the best sealer to use?
There's no best sealer, to be honest, because as far as current evidence is suggesting, sealer itself doesn't have any influence in treatment outcome. For example, if I am the operator, imagine I am the operator, and I'm doing in 3 groups. Okay, each group have 100 patients, and in one group I used a zinc oxide sealer. The second group I used methacrylate sealer, and the third group I used the bioceramic sealer. Rest everything remains the same. I mean, the instrumentation remains the same. The operator is same. My mood also is same, because mood also will affect the treatment outcome. So if you standardize everything and you differ only with the sealer, I don't think there will be a statistically significant difference between 1, 2, and 3, because sealer is not a dictating factor which influence treatment outcome according to me. What is more important is how you apply the sealer, how you do the rest of the procedure. So I don't recommend any sealer, but I preferably use certain sealers in certain scenarios. If I'm using warm vertical compaction, I don't use bioceramic sealers, because bioceramic sealer requires water for setting. And if you were using heat inside a root canal, these water will evaporate, and there will be the physical and mechanical properties of bioceramic sealer will be totally compromised. So in my practice, I don't do much of bioceramic sealer because of this issue, because I do continuous wave compaction in my practice. But if you're using single con, yes, you can do bioceramic sealer. It works better in that way. The sealer which I use in my practice is AH plus primarily. I also use Seal Apex from Cybron Endo, which is a calcium hydroxide based epoxy based sealer. And also I use PCS sealer, which is called pulp canal sealer. It is also from Kerr. So these are the 3 sealer what I use in my practice, not because this sealer have a better treatment outcome, but rather it is my treatment option.
How to suspect for extra canals?
That first you need good knowledge about root canal anatomy. If you have good knowledge about root canal anatomy, you will see the extra canal on a radiogram. I always say, you will see only what your mind knows. Yeah, there's a saying that way. Your eyes will see only what your mind is prepared to comprehend. So you have the knowledge, you will see the extra canal. If you don't have the knowledge, you will definitely not see the extra canal. So there are various tips and tricks other than this knowledge, like you need after access opening, you can use specialized explorers like DG16. You can use micro openers. You can use bubble test like hypochlorite, bubbles will come. There is red line test, bleeding points will come. There is white line test. When you use ultrasonics, there will be deposition of these debris at one point, and that point will looks more whiter. So there are various strategies to find extra canal, but in a broader perspective, the most important thing what we should have is knowledge about root canal anatomy.
Sir, could you please explain again when it's ideal to re-enter the tooth through the crown?
In my opinion, if you don't find any secondary decay under the crown, which you may not be able to see on a zirconia or a metal crown because it is radio opaque, what I do in my practice is, when the crown, if I get a history from the patient or the referring dentist that the crown is done immediately, maybe 2 months, 3 months, or maybe 6 months, I assume that the dentist had removed all the decay and done a good crown. So in that case, I don't remove the crown, I'll go through the crown. But whenever I see a crown that was placed maybe 4 years back or 5 years back, I always remove the crown. There are other reasons or advantages in removing the crown, because sometimes the tooth may be rotated. And when someone does a crown preparation, they do it in the right way and they put the crown. And as we re-enter, we may be doing the access opening something like a regular, normally positioned tooth. And if the tooth was rotated, we won't be able to understand the rotation of the tooth or tilting of the tooth unless you remove the crown. So I highly recommend to remove the crown, but yes, in certain cases, you have forced to go through the crown.
Thank you so much, sir. We have more questions coming in, but we are really delayed for the next session. So we have to stop here. Those who want to talk to Dr. Giorgio personally, he has given his details. Please do that. So let me now introduce Dr. Jobby. Dr. Jobby, are you there?
Yes, ma'am, I'm there. Okay,
Yes.
can I start sharing? Can Jojo sir, can you?
Giorgio, Dr. Giorgio, can you stop your share?
No.
Dr. Dr. Giorgio, thank you so much for coming in and giving such a beautiful lecture. It has been appreciated by so many people in YouTube as well as Zoom.
Okay.
Thank you so much, sir, for coming in.
Appreciate it. Thank you.
Dr. Jobby, are you ready?
Yeah, Bill.
Dr. Jobby, as you all know, we are together in online dentistry. Last 9 months, many of you have seen us together in this platform. Head of the Department, Pediatric Dentistry, Malabar Dental College. Dr. Jobby is going to enlighten about myofunctional appliances and right appliance at the right time. Do not miss this. Please refer to your friends. Let them all come in, join, and enjoy this session. Dr. Jobby, over to you.
Yes. Thank you so much. So let me just put my sincere gratitude to Dr. Giorgio for enlightening. That was an enlightening session. I was full time listening. This is maybe 4th or 5th time I'm listening, sir, but it is still new to me. It is a very good session. Thank you so much. Coming to my topic and winding up the last session. Yes, sir. Please.
Call me Giorgio.
Yeah, Dr. Giorgio, that's very nice of you. Very nice of you. Yes, yes. We are all one team, doctor. We are all the same idea. We are all the same group. We will meet so soon. Once the pandemic gets over, our regular meeting will soon happen. So coming to my topic of today, it's an entirely different topic to talk from this all these 2 to 3 days that is being happening. It's a very practical approach of some points we have missed. It can be a pediatric patient, it can be an adult patient, whichever patients are there which we have missed because the entire dentistry is changing. There is no limit of application of myofunctional appliance according to the current concept of orthodontics. There is no limit in applying myofunctional appliance. It's not only under 13 years of age because this is changing. So my aim is here is to give you a broad outlook about this protocol that you need to practice to understand. You can even give a 45-year-old also myofunctional appliance, but there are different protocols for that. Biomimetic orthodontics is coming. All you need to read, refer, and understand what is happening. So my aim here is not to criticize or not to do what is said. I just give a broad outlook. What is this myofunctional appliance and its protocol of treatment? That's all. So this is the main key discussion I'll be going. I have an aim. My aim of my presentation is what are these myofunctional appliances? Is it just age-restricted appliances or something beyond that it can be done? And about 10 types of myofunctional appliances is there. And can I give this appliance at what age group are ideal for that? And how I select is what I'm going to discuss one by one. And with that, I'll come to the purpose. The purpose of it is an overall view of myofunctional appliance. I'll be stressing on to some points, but it's an overall view of this myofunctional appliance in our dental practice. Whoever you are, you have a specialist practice, or you are doing a good implants or whatever it is you are doing it, but their patient has got a children, they have a teenager, they have people with you. So if you see that, it is your duty to inform them and let them know that there is something like this and that can be done at this time and this is the best time. If age passes, it is difficult. And I just want to let you know that overall view of myofunctional plans can be done. Imagine you are getting a phone call from a mother saying that, Dr. Joby, I want an appointment with you. I said, what happened? What happened? Why do you want to see me? You know, last week only you came. No, Dr. Joby, I want to show because I'm a little bit worried about it because nowadays Google doctors are there. You know, so many things are happening in Google. Dr. Joby, I want to see what happened. I think my daughter is getting proclaimed it after reading that article, after seeing that in that Google. I think that I want to show my daughter to you. Okay. So, okay, fine. Oh, teeth are coming out. Yes, teeth are coming out. I feel like that I have some confusion and doubt. She's just 7 to 8 years, but I have a feeling that I'm just really worried about it. So that's one mother says that. So that's what teeth are coming out. That's the mother's complaint. Yes, teeth are coming out. That's true. When you saw the patient, yes, teeth are coming out. You said, yes, teeth are coming out. Yes, teeth are coming out. What shall I do? She is just 8.5 to 9 years of age. That's it. The other mother, one more mother calls you and says that, Dr. Chobi, I just want an appointment with you because her 2 teeth came. It is perfect and everything is nice. But now 1 teeth is coming. It is little rotated. It is little tilted. It is little gap is there. I just want to show it to you. No, she's only 7 to 8 years of age. I want to do that. Crooked teeth. Another complaint. Crooked teeth. When you ask the age, it's all going to be the same way. So teeth are little rotated, doesn't have any space. 2 teeth perfectly, the adjacent teeth doesn't have any space. Right. I just want to show you whether it is okay or not at this age or this point of time, 8.5 to 9 years of age. That's it. So when you see yes, teeth are coming out, you can see teeth are coming out. Whenever we see these complaints of 8.5, 9.5 years of age, teeth are coming out. The first thing as a general dentist, what we see is we see inside the upper arch. Oh my God, so many primary teeth are there. Why are you worried about it? Still time is there. When you see the lower arch, yes, still there are 8 teeth or 4 teeth to 12 teeth to go. Shut off. Primary teeth are there. Permanent teeth have not come. Why are you worried about that this age of time? Don't worry, nothing will happen. It's all will come. 12 to 13 years, we can do the treatment. Not now. It's not the time. Milk teeth are there. The moment you put the terminology shedding tooth, milk teeth, parents are so happy. Oh, okay, fine. Oh, primary teeth are supposed to go. They are there. So there's time. Okay, I can wait. They trust you. They believe you that it's time. There are still more time. Growth is still remaining. So let me wait. Let the growth take place. Let me wait. So you are certain their doubt, their confusion that, okay, primary teeth are still there. Growth is not completed. I can wait. So they will be waiting. They will be waiting so many times. This is a very regular routine in our consultation appointment saying that doctor told me to wait till 12 to 13 years. Milk teeth was there. It's supposed to shed. Growth is not completed. Nothing can be done now. So I waited. So many times we see this complaint from the patients there. Now, I just want to project 2 photos to you. So please come to the chat box and in Zoom who are there or YouTube you are there, please come to the chat box and say that which one has got more crookedness. Okay, I'm going to put 2 pictures. 1 and 2 pictures I'm going to put. Come to the chat box and say which has got the maximum crooked teeth or crowding is there. Common person's terminology is crookedness. So that's why. Among A or B, which has got maximum crowding? Please come to the chat box and put, can I see that? Come to the chat box and say which one has got maximum crooked teeth there. Let me see that. Let me see your answer. B, 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 B. B, B, B. Very good. B, B, B. Fine, fine. I'm still waiting. Excellent. Excellent answers. B, B, B. Very good. Mariam Ali, Dr. Mariam Ali, and B because only 3 instances. Okay, fee. Now, if I would have gone a poll, I would have got maximum answer. Only 3 people out of that have answered. It is, I mean, all of them have gone for B. Great. You can see that so much crowding is there, so much crookedness is there, twisting and turning of the teeth is there. Oh my God, B is bad. B is bad, really bad. But let me tell you, now I just want, that is very great of you to identify that is what we are doing daily. But let me tell you, let me just open your eyes and let me ask you to see A closely. There are supposed to be 4 incisors to be erupted. There are no 4 incisors erupted there. Look at that. There are no 4 incisors erupted there. It is already missing. It's already not there. It is not missing. It is hidden inside. It is not erupted there. Now, in the same A, let me show you the upper arch. Let me show you the upper arch. There is no space for the lateral. Both the lateral, there is no space. In the lower, at least one lateral has got a space. But in upper, there are no space for the 2 laterals inside the upper. So there is a greater problem in the upper. So this is what we miss in your clinical examination. We miss that. When we see a nicely aligned arch, we think, what is the problem? No problem, it will get auto aligned. Here, if you see in B, the retained lateral, if you see, there are so many places for the lateral. C, D, E is well maintained, no problem there. But hidden problems are there that is happening there. Look into this case, another 7.5 to 8 year of case with this condition comes. When this condition comes, we look into the arch and says that still, oh, no problem, primary teeth are there. Permanent teeth is still erupted 7.5 to 8, 12 to 13 years, we'll see at 13 and 14 years because so many times are available. Some people even extract the primary teeth and leave. Some people may give a space maintenance. But this same patient at age of 13 years sitting in front of me with this condition. Can you see the condition that is there in the lower arch? And the OPG of the same patient, you can see there is total migration of the permanent first molar and space are completely closed. So according to you, looking into the arch, it is safe and sound. There is no much crowding, but inside the arch, there is a hidden crowding that is there. Hidden malocclusion is a severe kind of crowding that is there. So 13 and 14 years, you will end up into this severe form of condition. A severe condition, established condition. Beyond this, there are no scope to do correcting. You don't have much scope other than the conventional protocol that you do. So that is what we follow, something called an ostrich philosophy. We ignore it. We blindly ignore it without having a proper diagnosis. Just blindly ignore it. You know, this animal called ostrich has got a feature that whenever it faced with an unknown situation, not non-situation, it hides its head, thinking that I am not seeing anyone, so nobody is seeing me. This patient has been only seen by me. That is what you believe. That is what you think. That is a wrong notion. Believe me, every mother and father will take their child or anybody to somebody else and get a second opinion. Imagine you have somebody in your family has got a neurological problem or a cardiac problem or an unknown thyroid problem, whatever problem is there, the endocrine problem is there. One doctor said something, do you trust that doctor? You will take a second opinion. You have the right to do that, right? You will take the best. Who is the best in that town? You will ask, who's the best in that town? You go there, meet them, take the second opinion. Is it the same or not? Not even 1, 2, 3 people you take. You know, dentistry also, the same thing happens. Don't follow this ostrich philosophy. Whatever I say, they believe. No way. No patient is going to believe that. That is ignorance is bliss. That is, we all come in this category called ignorance is bliss. So whenever this kind of confusing, unknown situation comes, we also does the same thing. We also just try to avoid the situation or escape the situation. So the change is that you have to deviate from the norm. To progress, you have to deviate from the norm. Dentistry Beyond 2020 is all about deviation from the norm because it's going to be a digital era. It's going to be adjunctive diagnostic protocols. It's going to be the next step in our dentistry. We have to progress, but progress is your option. It is your option. You can just ignore it. You can continue what you have been doing it. But if you want to progress, you have to deviate from the norm. Think out of the box. Dr. Binu used to say, think out of the window. That is what we have to do. Then only you can grow. Otherwise, it is not possible. You can be still in that field. So this myofunctional appliances and its application in dentistry, it is coming in very big number. Believe me, 10 to 15 years from now, I am telling you, this is applicable even for adults, because many conditions are being treated, already treated or undergone treatment without taking into this consideration. Now, the dentistry is changing to improvise that, and it will come. This will be the future. This will change the field of dentistry. Like orthopedicians, orthopedician changes without surgery, they can mold the bone. We dentists can mold the bone without surgery and without any other thing with this appliance. The significance lies in this appliance. So talk about this appliance. If you imagine, just to make it very simple, why this myofunctional and its philosophy is coming out. Let me tell you very simple way I can explain to you the philosophy, or can say that the simple way this appliance works to make you understand is, imagine you have a ball and it is tied around. The ball is tied around with lots of wires all around. The ball is tied around, and you kept the ball and you started pulling the ball from all sides. Ball means top, bottom, down, right, left, up, down, everywhere you started pulling up on the string. Every corner you started trying to pull it out. So if you start pulling out this ball from every corner with equal forces, the ball will remain there only. The ball will not move, because you are putting a force onto this ball equally from all sides. Equal force from all sides, it will remain there only. So our dentoalveolar structure, your maxilla with the tooth, mandible with the tooth, the dentoalveolar structure are a structure like this forces. There are so many forces acting on this structure. From all directions, forces are acting on it, pulling it all over. What are the forces? Like habits, masticatory muscles are acting on it. Gingival and the periodontal fibers, eruptive forces, all those are acting on one direction. Soft tissues like tongue from inside, muscles of mastication, all are putting a pressure onto where? To this structure. From all directions, this pressure is acting on it. But it doesn't move because all are equilibrium. All are one force. There is no external force there. Everything is fine. So it's called equilibrium position or functional equilibrium. In this position, it performs all the functions like closing the mouth, biting, force, development, everything is good. So it's a functional equilibrium is there. Now imagine that one side, one area, you start putting a lot of more ropes. One side, you start put more ropes and try to pull onto that side. What happens when you do that? You try to pull on one side more ropes and more pressure. Definitely, the ball will move to that side because it has lost that functional equilibrium. Because one side there is more forces there. Exactly the same thing happens. Same thing happens. It was equilibrium, but one part, it started exerting too much pressure. One part. It can be a tongue, muscles of mastication, whatever. Started putting its pressure. More pressure started putting the dentalveolar structure. So what will happen to the dentalveolar structure? It has to move. It has to move against that because pressure is too much from that side. So it will go against to that side. Wherever less pressure, it goes to that pressure. So functional equilibrium is lost. And what happens in the lively is like this kind of dental arch. Crowding, you can say, rotation, you can say, narrow constricted high arch palate, you can say. you can say deep bites with every sort of situation. You can see even proclination which a patient said. You can say you don't know what is it, but you can say all those things that appears. So this is what is been described by Dr. Graeber in his article called AJO, American Journal of Orthodontics, 1963. Muscles can cause malformation and can cause malocclusion. Very simple, because the functional equilibrium is lost. This is where he said we have to regain the functional equilibrium with these appliances. You see the skull of this? Can you come to the chat box and tell me what is this? Is it a human or an alien skull? Can you come to the chat box and say, is it a abnormally developed skull of a human, or is it any prehistoric human beings, or is it alien skull? Can you come to the chat box and say, have you ever heard about this kind of skull? Is it human? Anybody come to the chat box and say that? Have you ever seen what you find this skull? Prehistoric, skeletal class 3, fine. Anything else? Prehistoric, is it human? It can be human. Prehistoric skull with a distortional habit. Frostbite, fine. Skull, you see, because see the skull of that patient. Early human, yeah, fine. So this is early human, not our time. They are like you can say, there doesn't looks like an evolutionary skull. Fine, good. That's what your inputs are very important to me to make you understand. Yes, it is an evolutionary skull. Guys, what you said is correct. It's an evolution, but I don't agree with you, because these are Incas in Peru. Still now they are there in Peru. There's a tribe. They are born as normal human being only, but when their child get born, they start winding. They start put ropes or tight cloth around the child's skull. It's still happening. You can search. And what happens is when the child grows up, they get a skull shape like this. Very young age, born up child, they start doing that. When the bones are not mature, not fused, they do that. Because according to their tribe, a child has got this natural crown kind of thing. It's like a elongated head shape. It's like a natural crown, and they consider those who has got the best, considered very elite or high position in that tribe. They believe that it is human. We are all in same Homo sapiens. But with this pressure exerted onto that human skull at early age with that tight bandages, mold that skull into this shape. That's all. They are not highly intelligent. The brain doesn't develop, it's empty. The height is there, but his brain is empty only. But the skull molds its shapes because of that bandage that is happening. So try to understand that pressure exerted onto the skull at early age, born at an early age, can mold the shape of the skull. So muscle forces, muscles surrounding the upper and the lower arch, put a force onto them. If you eliminate or if you take that pressure, you can change proper tooth eruption or promote the proper jaw development. You can allow the genes to express normally. That is what this appliances does do. It's very simple. Myofunction appliances takes the muscular forces. Either it eliminates unwanted forces or it uses the forces to guide the tooth into eruption and to promote the development of the jaw growth. So this kind of malocclusions or crookedness, whatever you see, with the use of this appliance at an early time, which where can take these muscles and mold the bone, you can get corrected by itself. What it does, it doesn't touch the tooth. It doesn't touch the tooth. It keeps the muscles which are acting on to the dentition. or the bone and keep it away so that the bone can grow naturally and express it itself. So the severity become mild or no. So proper development of the face take place. That's all. That's the simplest way I can put myofunctional appliance. It takes up the force. So the mother A said, sir, my daughter's 8.5 to 9 years, my daughter's teeth are coming out. Here, I am not going to just look into her chief complaint. Yes, your complaint is coming out teeth. Yes, I will see that. I will see how much it is coming out. How much it is coming out. That is one thing, no, right? It is procline means they don't know. No mother will call you and tell, sir, doctor, the normal proclination is 2 to 4 mm at this age. I know that, but now my daughters, I measured it and I have 10 mm. No mother will say, no parents will say. It is up to you to find out how much procline it is. Are they telling right thing or not? So in this patient, you can see at an 8.5-year-old to 9.5-year-old, you can see the proclination or what mother said is true. It is coming out, but how much it is coming out? Put a scale and take a picture and tell them, or it is too much. It's more than, you can say, around 13 to 14 mm at 9 years. It is too much. There is some other thing that is happening there. So looking into the patient, when I saw the patient, is, oh my God, this is not the normal thing. Many times when we see this, we actually bully the child, or we say that, oh, this is a skeletal things, nothing can be done now. Wait till 13 and 14 years or 18 years, that time only we can see it is nothing can be done. This is nothing. Many times we ignore like that. This is exactly what happens there. This was the condition of the child. So here comes the role of diagnosis. If you want to apply myofunctional orthodontics into your practice, first you understand what is myofunctional, nice and well. Next is diagnosis is very important. So diagnosis comes, oh my God, this Ceph, oh, Ceph is very too much of Ceph. I can't understand Ceph. I can't read Ceph. This is not for me. Ceph is not for me. I can't do this. But let me tell you, there are so much simpler methods and identifying simple points. You can justify that, no, madam, you are wrong. You are wrong. The child doesn't have any problem. You can accurately tell the same child, I did that, and the upper incisor angulation, very important, very simple way to identify. There is something called palatal plane and the long axis of the central incisor. You take that angulation, it is only 110 when you can have 113 degree. Up to 113 degrees considered to be normal. It is only 110 degree. So parents says that procline teeth, what reliability is there in their chief complaint? It's nothing, but something else is causing it. Procline teeth is not the real thing. Skeleton and tooth is showing it is not procline. So that is what simple diagnostic protocols will tell you. It is not tooth that is procline, but the mandible is way behind, which gives the feeling that tooth is proclined. Tooth is perfect. Mandible, which is supposed to be more forward, is not growing. There is a problem with the mandible. What is the problem? We'll find out. So you might say, oh, this is Ceph, I can't do, sir. Ceph, it's a very complicated thing. I don't like Ceph. I cannot interpret Ceph. So this is one way that you can do. But let me tell you, there is a simpler way. Without even Ceph, you can make the parents understand. Even without Ceph, you can make the parent understand in this kind of situation. So in this child, without even Ceph, what we did is I just told the child to bring the mandible forward. Nothing else. When procline was there, I told the child just to bring the mandible forward. Nothing else. Procline was there, I told them to bring the mandible edge to edge. Just bring the mandible to edge. That is no Ceph, nothing. Oh, the moment the child brought the mandible forward, you can see an absolute improvement in the profile. All the mandolabial sulcus, the mandibular retrognathosum, proclination is gone. Everything is gone. It's like in one straight line. That is called VTO, visual treatment objective. Look at the procline teeth. Look at the 4 Bugs Bunny teeth, the bunny teeth, you said the bunny teeth, it's gone when she brings the mandible forward. So there was no need for the self actually to show the patients, okay, to show the patients, to show the parents, to motivate them. If you show this picture in front of the mirror, child will be so happy. From that moment onwards, this child will always try to keep her face, her mandible forward like edge to edge. Believe me, I've seen this. After showing this many times, the child, when I asked her to bite, she forgot my old bite. She started biting front forward because she knows that her proclination, that Bugs Bunny teeth is gone with this simple test called VTO, functional or visual treatment objective. You don't need a SEF to do that. But accurate diagnosis, you might require that. Exactly that protocol was followed to her. 1.5 to 2 years, she showed exact tremendous improvement in the profile. Now, this is 7, 8 years of age. And now when I'm talking about 11-year-old child, exactly the same problem. He was so much bugged with that 2 Bugs Bunny teeth and that proclination. He want 4 teeth to be done, make my face straight. That is what he was very definite in this. Sir, take the 2 teeth. I don't want to see the 2 teeth. When I smile, my friends are bullying me. Take the front 2 teeth and do something for me. I want to have a tooth not be seen when I close my mouth. So this was the complaint, and he had that proclination was there. So self, again, I told you need to learn more about it. But if you see procline, I told you 113 plus 2 or minus, you can say little more higher side of proclination is there, but that was not the main problem. Mandible at the 13, 14 years was too much of retrognathic it was, but still growth was remaining, luckily for this guy. So BTO, tremendous improvement. So before and after treatment, you can see nothing has been done to him. 1.5 hours in a day, nothing, no orthodontics has been done to him. Myofunctional of molding the mandible has been done to him. So happy he is. So happy he is. You can see the facial change, the occlusion, everything has changed. So whenever you find a definitive diagnosis where mandible is behind, simple clinical test I told you, you can confirm with a radiographic diagnosis, but whenever a definitive diagnosis of mandibular retrognathism is there, you like to bring the mandible forward, which gives you a better profile and facial aesthetics. You can use appliances to bring the mandible forward. And one of the appliances is a tin block, which is very commonly used. Every general dentist should know, pediatric dentist should know about this, orthodontist should know in depth about tin block at an early age, which can bring the mandible forward. It can be indicated in type 2B. I don't want to go into detail what's type and all, but class 2, div 1 and div 2, one most common, simplest way I can put into you can bring the mandible forward with this kind of appliances. And even non-compliance patient, you have something called fixed tin block. Amazing. We are soon going to come up with an extensive full day webinar on tin block. All sort of fixed, adult, and pediatric or age group patient. We're going to do that. Now, can you come to the chat box and tell me what is this appliance? Look into this appliance. Can you come to the chat box and tell me what is this appliance? I'm waiting for you, sir. What is this appliance which is being projected onto your screen? What is this appliance? Okay, somebody said, Dr. Geetu L. Vijay said there is a triangle. Dr. Dhardi Patel said FR1. Dr. Chetan said FR1. Fine, FR1, triangle. Nice. At least you identified. Yes, it is a triangles appliance. That's at least I'm happy that you identified this appliance. It's a triangles appliance. It's a functional regulator or a FR triangles appliance, but it is FR2. Class 2 malocclusion, functional regulator 2, FR2. How will you say it is a FR2? Because you can see that lip pad in an FR2 is always onto the lower side. Lip pad is always on the lower side, and the mandibular guidance is there on the lingual pad. You can see that is also there. So that is also on the lower side. So it's guiding the mandible forward and occluding with the lip pad, which is keep the lips away to promote the growth of the mandible. Can you see now? The lip pads are guiding the mandible forward. Sorry, the lingual pad is guiding the mandible forward, and lip pads are keeping the lips away. The function, the muscles are kept away, allowing the mandible to grow. So it is indicated in a condition where mandible is retrognatic or growth of the mandible is hampered due to some functional problem, skeletal problem due to some functional problem. Mandible is retrognatic. So this appliance keeps the muscles away and allow the mandible to come forward naturally. Functional regulator, FR2. Can anybody come to the chat box and tell me what is this appliance? Come to the chat box and tell me what is this appliance according to you. Anybody? What would be this appliance? Oh, great. And what it is used for, Dr. Geetu? You are answering it very nicely, Dr. Geetu. What it has been used for? That's great. That's very great, Dr. Geetu L. Vijay. That is great. Yes, Cynthia, Dr. Jennifer, great, great. Yes, class 2 correction. This is another appliance called Bionator. It has been also used for class 2 correction, myofunctional appliance to correct retrognatic mandible, Bionator. The only problem is the bulkiness of this appliance. You might have heard about Anderson's activator, right? So it has been modified from that and reduce the bulkiness. So it also works. Bionator for class 2 correction, it also works. Now, what about this appliance? Can anybody tell me what is this appliance? In the chat box, can you come to the chat box and tell me what is this appliance? Yeah, yes. Shamim, you're fastest now. You're the fastest now. Good. Congrats, Shamim. In Zoom, I don't know in YouTube how many of them are doing it. And then followed by Dr. Geetu. That's great. That's Herbst appliance. Herbst appliance is a fixed class 2 corrector. Fixed class 2 corrector. It can correct. It's fixed onto that. You can do this appliances in a little more older or non-compliance patient. You can do that. What about this one? Let me see who will answer this. What about this appliance? Who answered that? Oh, Dr. Geetu L. Vijay. Okay, her forces appliance. Anybody else? Yes, Dr. Jennifer, Joyce P. James, congrats that you want that. That you want that answer for this question. It is Jasmine Jamba, another fixed character, which can be used little more older age, fixed character. Let's see this appliance. Now let's see this appliance. Can anybody tell what is this appliance? Yes, Jennifer G, you are correct. Dr. Jennifer G, you are correct. It is the forces appliance. So there are appliances that correct the mandibular retrognatism. In adults also you can do in young age also. Now as I went into little more adult correction, but when I started simple appliances like a tin block and FR2 in a young age, mixed dentition, early mixed, late mixed dentition, 12 to 13 years, amazing appliances are there. You don't need this kind of thing to do correction, but no chance, there are no other way you can do fixed orthodontics, and along with that correction, with this kind of appliances also availability is there. That's an expertise view, an orthodontist will do that. So options are there. So, and let me tell you, newer developments is an amazing newer developments in correction of a class 2 without too much of complication. There is something called simple way bond two molars, bond two lower molars, and make a A6 retainer on the lower molar, and then keep an appliance called Carey's motion device. That's called Carey's motion device appliance. You just keep this appliance motion device for class 2 correction. You can keep this one from the upper molar to the canine and put a class 2 elastics. You remember class 2 elastics? you put a class 2 elastics. You can derotate the molars. You can do class 2 corrections also. So things are changing in correction of class 2 mandibular retrognathism there. Okay, class 2 elastic has been put onto that, and you can bring the mandible forward. Dental collection can be done. Carries Lewis Carey in 2004 brought out this appliance, and it's called Carey motion device. So I talked about adult correctors like Herbst appliance, Jasmine jumper, forces, and Carey's motion 3D appliance are there, which are fixed functional appliances are also there for a little more older age group. When the growth is completed and you want to correct that, you can do that. But it requires a lot of patient compliance. Can be go along with the fixed orthodontic appliance, and treatment line is less. And one study you can go around is a 25-year-old clinical evaluation experience with the fixed functional appliances. You can go and read about these articles. And finally, he came into conclusion that fixed appliances causes only dento-alveolar changes. But early appliances like tin block FR2 gives more of a skeletal changes compared to a fixed appliances which are done at a later time. So always go for your early appliances when compared to fixed function appliances. You can read this article, it's available in online. You can read for that. Now let's talk about the mother B who said, sir, my daughter is having a crowded or crooked teeth. Can we resolve this crookedness of teeth or rotation of the teeth or crowding of the teeth with the help of a growth modification appliance is the next question. This kind of crowding, can we relate that? So whenever crowding is present, the next thing is indicate an OPG. First indicate an OPG whenever crowding is present. But when they bring the OPG back to us, OPG is like an MRI scan. Like a neurosurgeon looking into an MRI, you don't know what to look and where to look in an OPG. How to tell the patient there is some problem that is happening. I have to tell them. It's like you look into each other, parents look into each other, you both look, yes, there is a problem. What is the problem? Yes, there is a problem. What is the problem, sir? Tell me what is the problem. There is a problem. What is the problem, sir? Yes, there is a problem. But no idea to tell, yes, it has this specific problem, this thing has to be done, this that to be done. No idea, we don't know how to do that. So that is the importance of OPG analysis and giving myofunctional appliances, simple myofunctional appliances to rectify that problems along with the functional problems. So mild to moderate crowding with a deep bite or a distal occlusion is happening. One of the best appliances you can give is functional regulator 1, FR1. That's an appliance you should give with mild to moderate crowding that is present and deep bite. Distal occlusion, you don't have a class 2. Nope, class 2, but you know, it's like a endon-molar relationship, or it's neither class 1 nor class 2. Neither class 1 nor class 2. A super class 1 or super class 2, you can say. Mild to moderate with a distal occlusion is present. One of the best appliances FR1 way. So that is what I gave to this patient. FR1 is given to this patient, and within 1.5 year, amazing result. Ongoing follow-up. Let me show you amazing arch development of this patient has been seen with midline coinciding. I don't have to do a fixed orthodontic for this girl because of continued follow-up and guidance, keeping the muscles away, allowing the dentition and arch to develop. Mild to moderate crowding with mandibular retrognathically present or not. An amazing result you can give with this appliance. No need for any fixed orthodontic. Dental expansion will take place. This is another case of a 7.5-year-old child is reporting with a crooked teeth. Parents complain is crooked teeth. Teeth are not coming regularly. 7.5. So there is a gap between the tooth. One tooth is perfect. Other tooth is coming ups and down. Side by root stems are remaining. Should I remove the root stems of that lateral incisor? That is the concern of the patient. Will they get space? They're not worried about space there or no. They just want to know that lateral incisor, That black tooth should I remove because it's all coming crooked? Should I do? Its child is only 7.5 years of age, upper arch and the lower arch. I'm not going into the thing that of this patient, but this is a condition. This is the patient there. Here, I told the mother that I don't want an OPG and SEF. I don't want. Went into detailed history of this patient, and she was a chronic obstructive mouth breather. With the look itself, I can say that. So I don't want an OPG and a SEF and say these are the things. But 7.5 to 8 years, this kind of facial features are very definitive of a chronic obstructive mouth breather. So mouth breathing with everted and hypotonic lips. One of the appliance that you can think myofunction appliance is called a vestibular screen. An amazing appliance that you can give with good myotherapy. You can give into this appliance, vestibular screen. It can change. It can change. It can keep the muscles away, give tonicity to the muscles, make the patient, convert the patient into a nasal breather. You can see tremendous effort, tremendous change into that patient. So vestibular screen was given with a good myotherapy for her. And believe me, the exercises like this, tug of war exercises with the screen, tug of war, push the appliance out, but resistance is being followed, develop the upper and the lower muscles. And the stretching the lips, stretching the upper and the lower lips all around that loop changed her into this. Within 1.5 to 18 months into treatment, she's changed from this to this. No appliance therapy, kept the muscles away, allowed the mandible to grow, crookedness went, everything went. Believe me, nothing has been done to her other than that. From this to this, amazing change can happen with this myofunctional therapy. And you might have heard about pre-orthodontic training, same philosophy. There is no big science involved in this. It's all same philosophy that is happening all around the world. It's all the same. Frankel's philosophy. They even started putting Frankel's cage inside that. And it's all same, but it appears better. Patient complaint wise, it looks better. Child might accept it because of the color, because of the size, because of the components. Patient might, but it is no. The philosophies are almost the same. You can use that or trainer. Now, so use of this trainer again, same trainer. You put it inside. There are specific ways to put at the upper and the lower. Put it inside and do the same exercises of blowing out or puffing. All those exercises you do, and that you can get back into the normal form and function. Keep the muscles away. All the exercises can be done. So the final question will come to you is that, yes, sir, you are talking about crowding, you are talking about mandibular retrogradism. What about class 3? Can functional appliance do some good in class 3 orthopedics? Where class 3 tendency or class 3 is developing, can functional appliance has got any role in that? Can I get an answer to this question in the chat box? Do functional appliance has got any role in class 3? Can I get an answer? Do? Yes, yes, yes. Fine. Yes, 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 fine. So let's see the where we have missed the link. Where we have missed the link in that, let's say that patients with a what is this condition? Class 3. You can see a crossbite, anterior crossbite that is present. So can I give functional appliance in this kind of situation? So the effect, listen to me very carefully, write down the points. It is all literature supported one. Effects of functional appliances in class 3 corrections, primarily dento-alveolar. Please note down these wordings. It is all dento-alveolar. That means dento-alveolar changes functional appliances can do. Be it be a trainer, myobrace, FR3, it can do a dento-alveolar changes primarily. Like proclination of the upper anteriors, it can procline the upper anteriors. If it is retrocline, it can procline the upper anteriors and correct the crossbite. So the crossbite was not due to the skeletal problem. It was due to a dento-alveolar. The anteriors was retroclined. The functional appliances can easily upright it. No problem. It can correct it. So it will do that. lower anteriors was too much retrocline. There can be a class 3 kind of bite when lower anteriors are retrocline. It can apply or retroclination anteriors can be done. It increase in the lower facial height. Whenever there is a deep bite is present, or lower facial height is present, when you keep this appliance like a trainer, myobrace, or a FR3, it increases the lower facial because the supraeruption of the posterior teeth automatically take place and it can increase the facial height. So it can be indicated in patients where class 3 is present or class 3 kind of bite is present when the upper incisors can be proclined, lower incisors can be proclined because it's already proclined, can be proclined, or lower facial height can be increased. So there is some deep bite is present, you can give this appliance. So when to give and when not to give. That's the next part. This is a simple case where you can easily give because upper anteriors are retroclined. You just want to procline that you can give. Which condition and which time you have to give. These two conditions definitely you can give, but these two conditions are not the condition where you can give. You can see the amount of crossbite that is present. You can see in the first left side, there are 2 teeth in crossbite. So you can easily give that because a segmental or it's a skeletal or it's a dental crossbite, you can just bring it out. But right side, you can see that's not the time to give because it's a fully established crossbite, skeletal, retrograde. You don't know what it is. Something bigger is happening there. That is not an indication for a functional appliance. Right side, 2 conditions are not indicated for a functional appliances. But left side of your image, you can see that 2 teeth and the primary dentition, you can give that. Mild to moderate skeletal class 3, you find with the tooth into the problem, you can give that. So primary dentition or early mixed dentition would be the ideal time, or late mixed dentition would be the ideal time to give that. But not into the permanent dentition when the canines and the premolars are fully interrupted. That is not, that's a bigger situation that you're talking about. Second thing is vertical grower. Is the child a vertical grower or not? So what do you mean by vertical grower? The lower facial edge is too much. So one of the way to see is the CEF, the gonial angle. You need to read more about it. The gonial angle is too high. The y-axis, you can say it's too high. That's not a good indication for a functional, because I told you it increases the facial height again. So already the lower facial is too much or increased. That's not an indication for it. But a horizontal grower with a class 3, you can give. A horizontal grower, even with a class 3, you can give this appliance. This is a horizontal grower where the lower facial edge is not too much increased. You compare with the previous case, you can see the lower facial is too much and a class 3. But here you can see a patient with a lower facial height is reduced, but a class 3, you can give an early age functional appliance. But in this other case, I won't give a functional appliance and spoil it. So that's one point that you have to come. So what is this appliance that I'm almost done? I'm almost done. 2 to 3 more slides done. What is this appliance you see in the screen? Can you come to the chat box and tell me what is this appliance that you see in this one? What is this appliance? Okay, Shamim Taha has already answered. Okay, FR3. Good, FR3. Now you know the difference, FR3 and FR2. FR2, the lip pad was on the lower side. You can see in FR3 there are no lower lingual guidance or lingual, nothing is there. Can you see that any lingual guidance is there? You don't need that. All you need is to stimulate the maxilla, to keep the maxillary lips away and stimulate the maxilla. So you can see when the patient put this inside, mandible is already controlled with the labial bone. So you don't have to guide the mandible there, but you have to stimulate the maxilla. So the pads are there on the upper arch for an FR3 appliance. That is called, it's called FR3 appliance, functional, or for a class 3 where you have to stimulate the maxilla. So Dr. Frankel was very definitive, very simple. I'm not going to the philosophy of Dr. Frankel. Let me tell you, he's very particular and very systematic, saying that FR3 is given in maxillary retrusion and patient says that class 3. For us, class 3 is important. Listen to me very carefully. Frankel's or FR3 is given in patient with maxillary retrusion, mandible normal or fine. But we give whenever a maxillary class 3 in primary dentition, mixed dentition, blindly we give FRP, think that is a class 3, it will correct. No, that's not right. That's not what Frankel ideally wanted, is a maxillary retrusion. Stimulate the maxilla, come it forward, mandible is normal, let it be there only. And FR2, maxilla is normal, no problem, mandible is retrograde. Very specific in his philosophy. Please read more about it. So whenever mandible is normal, but maxilla is the problematic, you can give this and you can jump the bite easily during early age of development. And it's at the same principle with I3, your myobrace trainers with Frankel stage and all is there. So all the same philosophy. Or latestly, many people are asking, sir, can I do it? I have not done this called reverse tin block. That is also works wonders. That the literature says, but still now I have not done. This is a picture taken from Google because still now I have not done because of the compliance of the patient. I have not done a reverse tin block, but it can be done because it supports for that. Reverse tin block is also there. So finally, when can I give this appliance? Do you know that what is this? Why this tree is being tied with so much poles around it? Why you should don't allow the tree to grow as if as the tree wants? The reason for that is that it's called tree braces. If you look into research, you can say tree braces are there where they want the tree to be upright. They don't want the tree to branch at one particular point. It has to be erect and upright. So what they do is when they are very young bud itself, they start tying it up and make them upright. So they grow all upright in a uniform matter. At one particular level only they branch out. So that is called tree braces, and they do it early time. Without that's called tree braces. That particular height only the branches and they will be upright. And they don't start late; they start at very young age. But these are the trees which doesn't have any control. They don't have anybody to control them. They grow by themselves like themselves. So that can also happen. So when to start treatment for a malocclusion? If you ask that, it's not when it is established. It is not when it has become aggressive. It has to be like the tree braces. When they are very young and tender at the right time, you should start identifying the diagnosis and making the parents aware, and that's the time that you should start the treatment. So when the problems I started or developing, you should start treatment. Start early. One point to take home point is start early. Like this, this glass works, beautiful glass works. When they are very hot, it is easy to bend. The same way, when the iron rods are very hot, you can bend into beautiful shape and size which you want. Exactly the same way, you can mold the more bonds. The bonds of the jaw can be molded at your will and wishes. So what did I cover in this 1 hour to allotted to me is to treat the person, not the treatment holistic approach. I told you it's not just the procline teeth, the crowding, we have to treat the cause, holistic approach. And myofunctional appliance, it's nothing but take care about the muscles and allowing them to perform better way. Start early, primary or early mixed dentition. Diagnosis is important. You need to read more about that. And I almost covered 10 types of functional appliances, removable and fixed type of myofunctional appliances. Early age, middle age, late age also you can give if you have a fixed orthodontic protocol with you. And 5 types at least you can use. I only as a general dentist practice or pediatric dentist, basic things like FR1, 2 and 3 you can give. Tin block you can give. And your pre-orthodontic trainers or your I3 trainers. So 5 basic myofunction appliances early as you can give. But other appliances like Forces, Mara, and all those things, you need more training. Don't jump into that. And the latest advancement, you might read that. So I covered all those appliances, and overall, the conclusion of my presentation is that this myofunction appliances is not going to limit it to orthodontics to pediatric dentists. It is going to be an integral part of a private dentist for all aspects, because lots of undue things have been done and we need to rectify that. And that can be done with this one, because biomimetic orthodontics, which says that any age group we can stimulate the growth, and stem cells can be stimulated, growth can be stimulated, bones can be made bigger slowly and progressively. So this can change, because a lot of implant studies shows that stimulation of the muscles can give the sutures to regenerate, or it can give signals to the sutures. The pluripotent cells can signals to the sutures and make them grow. Future is coming, and all we need to do is get updated onto that. So start timing better. You start early. Old age you can do, but it takes time. Thank you so much. This is done. I'm done. And you can catch us at all these platforms on social media. We are available. This is my personal number. You can catch us in all these platforms. And if you can say that this pandemic gets over, you can come to Kerala, one of the most must visit land, where you have beaches, you have hill station, backwaters, Venice, everything you have except snow. We have everything. And thank you so much. Is over to Dr. Binu. I am open to the questions and answer session. If you have any questions, you can put the questions on the Zoom.
Joby?
Yes, sir. Yes, Binu.
Dr. Joby?
Yes, Binu.
Yeah, it's all excellent session, great session. I'm not seeing any questions at this point of time. Let's see. Nice presentation. Amazing, knowledgeable session. Always your lectures are brilliant, sir. Excellent presentation. Joby?
Yes, Binu.
Not getting any questions at this point of time. Okay. Frankel useful in general practice. Is Frankel useful in general practice?
Oh, amazingly, doctor, it is very useful in general practice. All that thing is we do not promote it because of the fear that the child will wear or not. Because once you see, show the picture of a Frankel and the preformed one, definitely the child will choose that, the preformed one. But it's a way that you promote your practice and make them understand. But let me tell you, much more productive and long term and less expensive is the Frankel. All depends upon your case selection. That's all.
All right. That's it. I'm not. Oh, a child patient of 9 years with class 2 malocclusion. Which appliance should we choose? Like twin block or Frankel? Is there any specific criteria?
The criteria, doctor, the criteria depends upon, one depends upon the child's cooperation. Second depends upon the growth pattern of the child. If the growth pattern of the child demands an immediate advancement, because the skeletal growth and the dentition growth, you can't correlate. You said 9 years, that doesn't mean that child growth is attained or not. We have to find out if it's a peak growth of the time, you can go for twin block. Otherwise, what I suggest is a class, your Frankels will do a good job. And also the degree of class 2 is taken into consideration. How severity, how much overjet is present, all those things also has to be taken into consideration.
Joe, Dr. Joe, are you here? You want to announce that? Joe, are you here?
Yes, sir. Yes, I am here, sir.
Go ahead, do that, and then I'll take a couple of questions after that. Joe,
sure.
It's yours.
Yes. Sure, sir. Thank you, sir. So now the much awaited results of the competitions in association with DB 2020 are out. The results are as follows. For postgraduate paper presentation competition, the top 5 selected candidates are DB01 Urvashi Tanwar for the topic Contemporary Restorations of Endodontically Treated Teeth, a Case Series. DB02, Dr. Vishnu Rajje for the topic Turn the Tide, Non-Fluoride Remineralization. DB14, Dr. Litty Prince for the topic Knowledge, Attitude and Practice about Teledentistry among General Population in Kerala during COVID-19, a cross-sectional survey. DB09, Dr. Avani V. Sudhakar for the topic Knowledge, Attitude and Practice about Infection Control Protocols among Pediatric Dentists and General Dentists in India during COVID-19 pandemic, a cross-sectional survey. DB16, Dr. Arunima Chandran for the topic Comparison of Efficacy of K-file, Canal Brush Technique and Sonic Irrigation Technique in Retrievability of Metapex from Root Canals and In Vitro Cone Beam Computed Tomography Analysis. Moving on to the PG poster competition results. The top 5 selected are DB05, Dr. Shobros Tantre for the topic Salivary Metabolites, Signatures of Oral Cancer and Leukoplakia through Gas Chromatography Mass Spectrometry. DB10, Dr. Urvashi Tanwar for the topic Evaluation of Immediate and Delayed Push-Out Bond Strength of Apical Plug of MTA mixed with 2% chitosan nanohydrogel, an in vitro study. DB04, Dr. Usha Kiran for the topic Digital Education in Children, a pilot study. DB17, Dr. Mangetri Fasle for the topic Lasers, a contemporary key to early diagnosis and a healthy child. DB11, Preeti Dureiraj for the topic Plasma, a new realm in dentistry. Moving on to the undergraduate section. For UG paper, the top 5 that have come up are DB02, Aster Shahil Vas for the topic Hand-Arm Vibration on Dentists using Ready Reckoner, a cross-sectional study. DB05, Mehul Bagmar for the topic Nanorobotics, Fiction or Future of Dentistry. DB10, Dr. Soumya Soin for the topic The Application of Multi-Baseline Digital Caliper and ABFO Photometric as a Qualitative and Quantitative Comparison in Forensic Odontology. DB11, Vishnu Chandra Menon for the topic Comparative Evaluation of Mucosal Vibration with Topical Anesthetic Spray to Reduce Pain During Administration of Local Anesthesia, a randomized controlled clinical trial in young adults. And DB17 for the Dr. Mishika Arora for the topic Assessment of Antimicrobial Potential of 30% ethanolic papaya leaf extract against Candida albicans and Enterococcus fecalis. About the UG posters, the top 5 that have come up are DB01 Reshma Rajan for the topic Light Image Analysis Module, a boon in the field of salivary diagnosis. DB06 Akhila S. Nair for the topic Mineral Trioxide Aggregate. DB07 Mehul Bagmar for the topic Enamel Engineering, Fiction or Future of Dentistry. DB11 Mohit Bagmar for the topic Advances in Reinforced Restoration. And finally, we have DB14 Dr. Prashika M. Chande for the topic Oral and Systemic Health and Interlink. Congratulations, all winners.
So it's a big congratulations to all the winners of all the 4 competitions. It was a very tough decision. We had multiple Zoom meetings with the judges and crisscrossed, and we came to this diagnosis. I mean, so for the final finale. So what is happening is you have the YouTube link of your presentation. The best 5 with the respective segment will get a YouTube link by tonight or maximum by tomorrow early morning. You will get the YouTube link. All you need to go is click the YouTube link, see your presentation, evaluate yourself, rectify what the judges have told and come in between 1 to 4 p.m. And I'm going to announce by tomorrow, maximum by 9 o'clock, the schedule will be announced to you. And you have to come online and present yourself on those particular times. The same judges which you evaluated, best 5 is done. You are the best 5 in India in poster, paper, UG and PG. That is in all over the world. People are participators. You are the best. There's nothing. But among them, best 1, 2, 3 will be streamlined. And the sponsors have offered a cash prize for them. But everybody is good. Let me tell you, the presentations today, it went more than 1.5 hours extra. We supposed to stop at 6:45. We stopped at 7:50 because of the enthusiasm of the postgraduate presentation. That's the spirit of it. You had time to defend yourself, and judges had the time to talk and interact with you. All are so happy with that. So hold on to yourself. We are going to announce the time and all is done. Now all your link is going to come. Watch it again. Rectify yourself. Who can give you this provision of watching your own mistakes and rectifying it? That is what online dentistry. We want professional ethical group to develop and come forward and present and master the world. So thank you so much for supporting us.
Dr. Joby,
Yes,
Dr.
Bill.
Joby,
Yes,
Dr. Joby, there are a couple of questions more. Okay, I wanted that results to be announced and come back to the questions.
Yes, I am there, Binu. I am there here. I am there here.
Transverse maxillary expansion question mark. So I don't know. Transverse maxillary expansion question.
I can, from the doctor who has asked this question, from that knowledge, I know that there is a, with the function appliances, you will get a dental expansion, but if you want really transverse expansion is required, you have to skeletally open up the maxilla. That for that, you need a rapid maxillary expansion. You know, many cases we do that first and then we go for functional appliances as a retainer.
Whether you do fixed orthodontics after functional appliances, if not, then how to charge?
Dr. K.R. Balaji, let me tell you, Dr. Function, the function appliance therapy is usually basically done for soft tissue correction. With that, some skeletal correction, like a retrographic maxilla, mandible or though, that's all. So it's like a stage-wise treatment protocol. So the stage 1, with what type of functional appliances are you prescribing the patient? Depends upon the charges. So can be a maxillary deficiency or can be a mandibular deficiency. Functional appliances with myotherapy, full the minimum what we charge is 15 to 18,000 in Indian rupees in the first phase. And then fixed orthodontics, which can be 25 to 30, or depending upon that, sometimes they go for even clear aligners also. So that depends upon that. So basically what we are doing is skeletal corrections. In orthopedician, doing a correction surgically or non-surgically, it's chargeable, right? So we are having a 2 to 2.5 year interaction with the patient, and you don't have to charge on the day 1, I want 15,000, then all I will start. No way that. We have a split up, we have a protocol for that, we'll do that. And this 2 years appointments, we need your sterilization of the instruments, the COVID protocol, all those things are there. So we split up the charges and patient tell the patients initially how much you have to pay, and then each appointment you have to arbitrary number of appointments also be told to them, and we charge in that split up and goes there. Any more questions, Dr. Bill?
All right, Joby, we are almost done. Okay. So that was great. We are a little delayed, but it was excellent. Thank you so much, one and all, for coming in. I'm having some net issues, so I've switched off my video to save the bandwidth. Thank you so much, one and all. Please be there tomorrow. A lot of classes tomorrow. A lot of sessions tomorrow. Do not miss it. Please be there. Good night, one and all. Joby?
Yes, good night. Good night. Good night.
Good night.
Good night, Norm.
See you tomorrow.
See you tomorrow. 11 o'clock tomorrow, amazing sessions are there.